Check, check, check. Good morning, everyone. So hopefully we will have no sound issues today. Welcome to today's Public Health Committee public hearing, Wednesday, February 26th. I did need to be reminded about the date in case anyone else was needing to be reminded. I will turn it over to you, Senator Amor, for any opening remarks.
Thank you. Looking forward to hearing from everyone. Thank you, Madam Co-Chair.
Thank you very much. As we often say at our meetings, members of the committee, including leadership, will be in and out. There are quite a few hearings today, so I know we will be seeing folks in and out. Representative Clara DeStitria.
Thank you, Madam Chair. Welcome, everybody, today. And I was going to say the same thing. People will be in and out all day today. They have multiple meetings. Thank you, Madam Chair.
Thank you very, very much. And with that, we will begin. And we are happy to welcome our first guest, I should say, today, Commissioner Jani. Welcome.
Thank you so much. Appreciate the opportunity to speak with you today. Good morning, esteemed members of the Public Health Committee. Thank you for raising the department's bills today. I'm here to discuss 5 pieces of legislation that have been proposed by the department. Just to summarize, the first is the department's recommendations regarding food safety and oral health. The second is that regarding hospital emergency department diversion. The third is regarding drinking water. The fourth regarding various revisions to the public health statutes. And the fifth regarding physician recruitment. In the interest of time, I'd like to give you back the floor and open the floor for questions on these 5 pieces of legislation.
Commissioner Jani, that's absolutely wonderful and welcome. And I thank you. I actually would love to ask if you are willing to just briefly summarize for us each of the bills before us today, and then we'll get into questions. Thank you, Commissioner.
Okay, happy to do so. So the first act regarding food safety and oral health, what I want to be clear here is there is no policy change, nor is there any cost that is suggested in this bill. What we are trying to do is maintain the status quo as it pertains to the way things currently are in Connecticut at this point in time. The first is regarding fluoride levels in water systems. The current guidance provided by the Department of Health and Human Services is referred to in our statutes as something that water systems, public water systems serving people over 20,000 must comply with. The federal guidance is only that. It is a guidance document. And so what we are trying to do is be able to say that at these low levels of fluoride in water that are required for water systems supplying people over 20,000, that we want to be able to maintain that as something that our water systems in the state of Connecticut do. The second is around the Model Food Code. The Model Food Code was passed unanimously by the legislature in 2017. It took several years. It was a priority of mine when I came into this job in 2021 to make sure the regulations that needed to accompany that statute were put into place. Those were finally put into place in 2023. We've done a lot of onboarding in terms of our local health departments, in terms of restaurants, and to have disruption to that regulation would be incredibly disruptive, not only to the businesses in our state, but to local health departments that actually enforce and ensure safety. So the goal in this particular proposal is just to be able to maintain the current standards, which we know are working, which help to, for example, in the Model Food Code, ensure that allergens are identified for people who are purchasing food in restaurants. So we hear of instances where people have eaten something that they did not know was in the food. The Model Food Code helps create that kind of regulatory establishment. And we basically want to be able to stabilize things so that our food providers and local health departments can continue with food safety in our state. The second act regarding hospital emergency department diversion. Currently, there is a guidance document that has been agreed to by member hospitals and the industry. This is not a document that DPH has endorsed per se. It is also not something that we can enforce. As a department, we are required, and hospitals are required, to have an emergency department. Currently, hospitals are not required to tell us when their emergency department goes offline. When things are functioning normally, there are no issues. When things are not functioning normally, often people come to the department asking for information, wanting to know who has had to go on diversion, why did they have to go on diversion? And we do not have eyes on that situation at all. A few examples might include if there's a behavioral health surge in children, as we saw over the last several years, when there was a need to go on diversion, or if a given hospital is asking for assistance from other hospitals and those other hospitals do not want to or cannot provide assistance, we have no eyes or authority to do anything about it. In the most recent scenario of a cybersecurity attack, for example, on one of our hospital systems, or a struggling hospital system that may be in the process of being considered for purchase, those types of situations, when again, people want the department, people turn to the department to ask, have they had to go on diversion? The reality is we don't know. And so in order to help provide some eyes onto these types of situations that arise in our healthcare industry, this gives us some visibility, and it creates a standard that everybody will have an opportunity to weigh in on what those standards should be for when somebody goes on diversion. The third act regarding drinking water really is trying to put some processes in place. For example, we are transitioning a number of regulations from DEEP regarding 7,500 to 10,000 gallons to the Department of Public Health. And oversight of that, we are on track for those regs to be in place for July 1st. There's a public comment period that's open right now. So I think we are on track for that. However, in the event that there are any hiccups along the way, it gives us the opportunity to have policies and procedures in place. Currently, we do not have authority for policies and procedures. One of the things we want to do is be able to have that authority just in case those regulations don't go through for July 1st, so that we can in fact begin that work. That is one of the major things from that particular one. The next one I wanted to mention is various revisions. Again, here you may be hearing from others about the Rare Disease Advisory Council having the ability to apply for and accept grants and donations for the purposes of carrying out its responsibilities. That is part of various revisions. Some of the other things that are part of various revisions are allowing the department to communicate within ourselves around maternal deaths, being able to have that information go to our own vital statistics department. Right now, we don't have the authority to share that information even within the department. One of the other things is to actually try to streamline some of the regulatory requirements. We have federal and state mandated inspections of a variety of healthcare institutions. What we're trying to do is say that if some of those inspections are required every 2 years by state standards, but every 3 years by federal standards, if there are no problems, if there's nothing in particular that requires that 2-year state inspection, that we can waive that and just stay on the schedule of the federal inspection. So that is one of the opportunities. And I think a number of the other things in various revisions, I will refer to questions if people have them, because there are a number of different areas within that. Lastly, I want to just talk about physician recruitment, which is the last bill that's put forward. One of the major things we're trying to accomplish with physician recruitment is be able to expand the scope of physicians, the number of physicians that can work in the space. So, for example, we have had a retired dentist and retired nurse, including APRN license, available to retired dentists and nurses in our state. We have not had a retired physician license available in the state of Connecticut. By providing retired physicians an opportunity, particularly to work in a pro bono basis under the malpractice of the institution that they may be working for. We will increase the number of providers that we have to be able to provide primary care and behavioral health services. That is the goal of this retired physician license. In addition, in this bill, we had a student loan repayment program that was established and that has been fully executed. Those funds are, have all been allocated. However, the statute that allows us to run that program was repealed last session. So part of the things that we're trying to do in this is reestablish that. We do not have additional funds to go towards student loan repayment, but should we get funds in the future, at least the platform would be intact and the statute would be in place should we be able to get funds in the future, whether it be state funds or federal funds. We have received in the past HRSA funds for federal dollars. In the future, as things currently stand, if we were to get HRSA dollars, we would need a state match in order to do that as well. So that is a summary of our bills, and I will turn it back to you, co-chairs.
Thank you very much, Commissioner. A couple follow-up questions, and then we'll go to my good co-chair. So in terms of the Senate or House Bill 6977, the drinking water bill, you talked about wanting to have policies and procedures. The regulation process is underway. You're hoping to have those in place by July 1st. We're not regs review, so maybe just for the sake of the committee and the public at large, actually, what's the difference between having policies and procedures? What are they versus the regulations? Just as a way to provide some education.
Yes, thank you for the opportunity for that clarification. Policies and procedures is an opportunity for us to get the guidelines out there so that they can be enforceable and so that the industry actually understands how to be able to move forward with the work that we're trying to do. Regulations go through a much more rigorous process. They need to be approved by the legislature, by the committee who actually reviews them. It has many additional steps. There's a public comment period, as I said, that is open right now. But if there is a gap between being able to have policies and procedures in place, which we currently do not have the authority to do, we are ready to start this work on July 1st. But if we don't have policies and procedures in place, the industry and people, homeowners, will not know, and people who have maybe buildings or other things that would require this type of regulations for subsurface sewage, they would not have anything to be able to operate on and would need to wait until those regs turn in place that are approved and actually in place. So there would basically be a limbo period. There would be a window where people would not be able to move forward. And we are ready to do that work as of July 1st. But without that authority to have policies and procedures in place, we can't even give anybody in the industry any sort of idea of what we're looking at.
Thank you. And that actually leads to a follow-up question, just in terms of the timing. If you anticipate the regs to be passing July 1, is that what you had said or no?
Be
You
in
can
place by July 1. That is what we are hoping and anticipating. However, right now we have a public comment period. After that, they would need to be ready for the regs review committee and they would have to be passed in a timely fashion. There are a lot of things that we don't know. Sometimes they can be rejected with prejudice. Sometimes they can be rejected without prejudice by the regs review committee. And then we have to go back and make changes. So if the regs review committee, which is made up of the legislature, decides that what we've put forward, they reject, then we might not have anything in place by July 1st. And then we would not be able to do this work.
Wonderful. Thank you for that. And then another question related to the emergency department diversion. I know there is some testimony in opposition. Specifically, my question is, if there were some large scale catastrophe that occurred versus the situation that you referenced when you were talking about the reasons for wanting to have this conversation communication, would that not be a difficulty in terms of what you're looking to do for the bill, and how would that be addressed?
So every hospital needs to have COOP plans, or basically emergency preparedness type plans for catastrophic events. And so and those plans are submitted to the Department of Public Health, the kinds of plans where if there was a catastrophe, no electricity at all, generators go offline, some sort of climate catastrophe, there are plans that individual hospitals need to have, and they do need to report those to us. However, diversion in the event of such catastrophe, whether it applied to, let's say, a specific area of the state, maybe multiple hospitals go into that sort of situation. We currently have no eyes on that and no authority to even ask for that. So again, as I mentioned in the beginning, hospitals are required to have an emergency department. Hospitals are not required to tell us when they don't have an emergency department, when they have to say that their emergency department is offline and they cannot accept patients because they're going on diversion. So in my experience over the last 3.5 years that I've been in this job, there have been multiple scenarios in which legislators and others have asked what is happening with a given hospital. And I don't have eyes on that, and I don't have answers for that.
Okay, thank you for that. And one last question related to Senate Bill 1326, the food safety and oral health. And just to clarify that the milligrams per liter of fluoride, that is not being increased. That's not a suggestion to increase that. That is simply to place in statute what is the current federal recommendation, I guess, or guidance.
Guidance, that's correct. So we are not making any policy deviation from the way things are right now. What we are trying to maintain is the status quo. The current guidance is 0.7 milligrams per liter. And this has been identified as an optimal level. There is allowed for there to be deviation no more or less than 0.15 milligrams per liter. Our water systems are all in compliance with this. This is something that we are able to measure and monitor on a regular basis. And it's very clear that areas that have removed fluoride from their public water system, again, remembering that public water, which is something that everybody can have access to, when those systems have removed it, we've seen more caries, we've seen more challenges with being able to eat, being able to smile, being able to have self-confidence. We've seen, and these are all challenges that we know children experienced through COVID, and the implications are far beyond just routine dental care. There are so many aspects that good teeth have in terms of overall good health. And quite frankly, for even adults, poor dental health has impacts on self-worth. It has impacts on cardiovascular health. It has impacts on infection risk. So the impacts are profound. One of the major things about public health interventions is they often seem like simple interventions, but they have profound, wide-scale impacts on an entire population.
Thank you, Commissioner, for that. That level has been in place for how long?
Many, many decades. So in Connecticut, we have had a variety of different laws that were passed over several years, but this type of level has been recommended since the 60s, since the 1960s.
Thank you. Thank you for your comments. I started my morning this morning at 7:30 with my dentist, and I will share, I know I'm not testifying, but I did lose a front tooth last year. And I can share that my willingness to smile or eat in front of other people without that was tremendously impacted. I know it seems like a small thing, but I thank you for that. And with that, Senator Elmore.
Thank you so much, Madam Co-Chair. Thank you, Commissioner, for your testimony. I just wanted to clarify a few things and then use this opportunity. First, thank you for the work you do and your entire department does. The first question I wanted to ask you was, again, on the fluoride level. We are not changing it, but I've seen a couple of emails about this topic where people are talking about the IQ of the people being impacted by this. Could you help clarify and demystify the numbers, and then what are the risks and the benefits, and are these levels that are being proposed going to be harmful from the IQ perspective, and is there data to prove that?
Yes, so thank you for that question. What has been identified and raised is that neurotoxicity for children, pregnant women, when the levels are 2.5 milligrams per liter, is when neurotoxicity is something that is possible. What we are looking at is, again, not a change. We're not looking to increase anything, is maintaining the current levels that have been able to maintain good oral health in Connecticut for decades at the level of 0.7. So the concerns around toxicity, and specifically neurotoxicity for children, are at a level almost 3 times what we currently have as part of our regulations. And so I firmly believe that we are at a level and in a state where endorsing and continuing to have what we have in place right now is important to maintaining health overall. Again, public health is all about prevention. This would be primary prevention. The last thing we want to do is harm people. And primary prevention is maintaining good oral health. The consequence of taking it away would be more health care, dental care, more burdens on the system overall and for individuals. So the levels that we're talking about, there have been multiple different scientific publications that go into these details about the various levels. But just to summarize, the level at which there is toxicity potentially is 3 times that which we have here in the state of Connecticut.
Thank you so much for clarifying that. So again, for the people who may be seeing some of the data about this, we, for the past multiple decades, have had this level, and that has been seen by studies, and there's no evidence whatsoever that this is harmful or neurotoxic. I just wanted to just mention, my understanding is that there were some studies in underdeveloped part of the world where the numbers were off, but they did not look at the lead levels and the mercury levels, and that actually was a bigger issue than the actual numbers. So can you touch on that?
Yes, thank you for that question. There are a number of studies from non-US areas. So areas in Asia, in Africa, where there were epidemiologic studies that were done. These are not trials. These are not controlled. They're observational. So from a scientific standpoint, there are other confounders, as you mentioned. And in a number of those systems, they do not have the kind of regulatory authority and control over a number of different contaminants that can be in water. As you mentioned, whether it be lead or mercury or other chemicals and toxins that could be in the drinking water supply. It is actually pretty profound, the advances that America has had on maintaining safe drinking water in our country. And maintaining that is something we want to try very hard to do, and do rely on our federal partners to be able to help us do that. And it is not just around fluoride, which in some instances is added to maintain oral health. Some public water systems already have some fluoride in the system. But it is really essential to highlight that some of these observational studies that were done in other areas of the world, and not in the United States, did not control for those other potential toxins that could also have impacts in terms of neurotoxicity.
Thank you so much, Commissioner. My last question is, I know the answer to this, I just wanted to underscore it. Your bill, the proposed bill from Public Health, is asking for the Department of Public Health to be informed for diversion, not get permission, but to be informed about it. Just wanted you to highlight that if you could.
Thank you very much for that clarification, because that's absolutely correct. We are not asking to provide permission. We are only asking to be informed so we can inform those who ask us when there are challenges that arise in certain situations.
Thank you so much. Back to you, Madam Co-Chair.
Thank you very much, Representative Steinberg.
Thank you, Madam Chair. Good to see you, Commissioner. Referring to the drinking water bill, some questions on clarification. When we're talking about these kind of sewage treatment systems, are these different from what we refer to as fast systems?
So the systems that we're talking about are subsurface sewage disposal systems. So these are systems where we've already had the authority to do it for less than 7,500. This is increasing it to 10,000 because some of the regulations that were in place at DEEP versus DPH, making it consistent and allowing us to do that. So specifically fast systems, I would have to get back to you on whether that's another term that's used for subsurface sewage systems. So we can get back to you on that.
Typically, those are septic systems, but not your traditional ones, and they tend to be smaller. So they sound like
They
already covered
sound
by
similar.
Okay. That leads me to my next question. Is the reason for the need to promulgate regulations because of the shift in responsibility from DEEP to DPH?
Yes, that is part of it. I think that also the requirements are slightly different. What is encompassed within 7,500 up to 10,000? And yes, because this is new work for us, making it consistent and across the board with what we were doing at 7,500 up to 10,000, because DEEP had the regulations before, we've needed to do that. And part of the reason for this shift is because of what the actual regulatory requirements are. So in order to make it consistent and something that's operational, that's part of the reason that it's been come to DPH.
You know, I couldn't help but notice over the years, there was this sort of sharing of a lot of water responsibilities between the two agencies. Would you be willing to venture a statement about whether or not you're comfortable with the way it's currently being divvied up?
Absolutely. So in general, the way I usually try to explain it to people is that in general, DPH is responsible for water going into the body because it affects human health, and water that is going out into the environment is in general with DEEP. Now that's a very broad general statement because what I'm going to talk about right now is an exception to that rule because I'm talking about subsurface sewage. However, subsurface sewage ends up being in a property itself. And when you have leakage out of the property, when you have problems that happen, if you develop a cesspool because there's some sort of break and now you have bacteria or other things that could now impact, let's say, a well, which again is back to the drinking water. And so this is where we work very well with our DEEP partners. And again, because of this somewhat murky situation, no pun intended, around the subsurface sewage, that was something that was asked to come to us, and we've built up the capacity so that we could deal with that. And I'm very comfortable with the work. We're ready for it at this point.
And that brings me to my last quick question. You mentioned you have the capacity. You've always had a relatively small department to deal with these issues. Do you have the staff to meet the needs going forward?
This is something that we've raised as a concern over the last couple of years, and we've received the support to be able to execute on this ask of us to do this work.
Thank you.
Thank you very much. And thank you for the questions, Rep. Steinberg. I believe, Commissioner, that the committee will be seeking actually a meeting to talk with you in DEEP a little bit more about some of these issues. So we appreciate those. Senator Gordon, to be followed by Rep. D'Amico, to be followed by Representative Reddington Hughes. Senator.
Thank you, Madam Chair. And some of my questions have already been asked, and I do want to follow up on two of the bills. And thank you for being here, and thank you for the work that DPH does. I know it very well in my other role as a doctor. I know there's been a lot of concern by some people about fluoride in water, and we all know that there is naturally occurring fluoride in Connecticut in water. It's at such a low level it does nothing really. And I believe it was 1962 that the feds first proposed about what to do about fluoridating water and have certain requirements and certain levels, as you mentioned. And you've highlighted that what you're looking to do here in Connecticut is really a continuation of what's gone on for decades from federal guidance, and you're not changing any of that. And there's been some discussion as well about concerns people have had about harmful effects. I've never seen any of the studies that really have proven that there's been a harmful effect. And a lot of it has to do with child development for neurologic function and brain function. I've also been hearing from some people saying that they've raised concerns about adults who have already developed and grown. Have you seen anything that has come across during your time with DPH and before to indicate that if fluoride is put into water and it's within these guidelines, that's been the case for decades, that there is any harm that has been proven to adults?
I have not seen any data at the levels that we are discussing to show that there has been any harm to either children or adults.
Thank you. I've not seen that either. And I think it's important for folks to know that really the two sources that we really get for fluoride is if it's added to water and if you use toothpaste that has fluoride in it. Really, otherwise, there's really no major intake of fluoride to any substantive degree that accumulates over decades. So I am glad to see that an effort here in Connecticut to see what to do with fluoridating water, you have guidelines that are been established for decades. And that's an important point, that you're not looking to change those at all. About the, my last question is about the emergency room diversions. We know that's been an issue for a long time. It's getting worse. And I know you've mentioned that you're not looking to establish, to give permission or deny permission if an emergency room at a hospital, for whatever their reason is, has to go on diversion. I know hospital systems really don't want to do that. There are some unfortunate circumstances out of their control that sometimes has that. But to follow up on that, my question to you is, for what you're looking for is to gather information to be able to know in real time what's going on, so DPH can be of help as needed, if needed. But you're not looking, is my understanding, correct me if I'm wrong, to create any regulations that's going to tell a hospital system with an emergency department what to do medically if they have to go on diversion, patients that are already there once a diversion has occurred, the proper safe transport of patients that have to be diverted if they're en route to a hospital, to an emergency department. Your department's not looking for any of that. It's more to understand what's happening in real time, so that way we can better understand what we might be able to do moving forward.
Yes, that is correct. Our goal is to be notified. In addition, I will say that currently there is a document that hospitals have agreed to themselves on reasons to go on diversion. However, a hospital could choose to abide by it or not abide by it. This is something that is a, so to say, gentleman's agreement. And one of the goals would be to say that some sort of document be agreed to by everybody, that then if DPH is asked to enforce, we actually could. So in terms of the reasons, the goal would be for it to be within the reasons that have been identified as legitimate reasons to go on diversion, and then for us just to be informed.
Thank you, and I appreciate that. And I do have some other friendly questions that I can take offline, because I think I know the answers, but I just was going to seek some clarification at a later point. But thank you for being here. Thank you, Madam Chair.
Thank you very much, Senator Gordon. Representative D'Amico.
Thank you, Madam Chair. Thank you, Commissioner, for being here today, as always. So I had a couple questions for you about House Bill 6978, specifically Section 5. You spoke about it briefly earlier in your testimony about waiving the inspection and investigation. Does that apply just strictly to nursing homes and nursing facilities?
So specifically, this would give us the opportunity. There are a group of facilities that it would apply to. Currently, state law requires physical plant inspections prior to renewal of licenses for hospice, home health agencies, ambulatory surgical and end-stage renal dialysis facilities every 2 years. So it would specifically allow us the opportunity to extend that to the 3 or 3.5 years for the federal requirements in these institutions.
Okay, thank you. So while we're on the topic, it brings to mind a couple of questions, if I may, Madam Chair, briefly. So the inspection and the investigation process, in addition to nursing homes, you inspect hospitals,
Yes.
you inspect other medical facilities. As a practical matter, on what type of schedule would that occur?
So the answer is it depends a little bit, in the sense that there are routine inspections that may be in place, but then there are also complaint-driven inspections. And so there are some facilities that we are in all the time based on complaints and based on what specifically is the standard of care and the quality of care that is going on. In other situations, a little bit of it depends on the facility. So I gave you the example of these facilities where there may be a distinction between state requirements and federal requirements for physical plant inspections. We have many challenges, as people have known, with nursing homes over the years. We have a much smaller team that does hospital licensure and some of these other facilities that I discussed. Part of the goal here is for those facilities that are performing well and that seem to be on target, we can use resources towards those facilities that need that more intensive follow-up on a regular basis. So a little bit of it depends. It may be on a yearly basis. It might be 2 years. If it's state regs, it might be 3 years. If it's federal regs, and it might be every few months if it's complaint driven.
So it's possible that a hospital, for example, might go for 3 years without ever being subject to inspection, assuming that there are no complaints.
That might be for the state surveyors, but there are other regulatory bodies that may be in place for hospitals. But I would say in general that it is unusual for us to not have complaints. And we do follow up quite a lot.
So do you investigate every single complaint or only the serious complaints, if I may ask?
Yeah, so we can get back to you with more information because there are very specifically outlined. For hospitals, our authority is really through CMS. We are the agents of CMS, of the federal government. And there are very discrete, complicated rules in terms of what gets investigated. Everything gets investigated, but then they have different degrees of severity. And depending on severity, that may trigger an on-site visit and more in-depth investigation.
So if I may ask one more, Madam Chair. So let's say, for example, a hospital, someone complains that a hospital doesn't have proper equipment for specifically for people with disabilities. Would that rise to the level of an immediate inspection? Would that be put off for a year? What would happen in a case like that?
I think I'd have to get back to you with the exact specific timeline on, because I hate to say that it depends. The reason it depends is if it actually impacted a specific patient in a specific time and caused potential harm to a patient in real time, that would be investigated in a much more short duration than something where somebody just noticed that there was no equipment, but nobody was harmed. At the end of the day, it really depends on harm or potential for harm in a given situation. So that's why it often depends.
Okay, thank you very much. I appreciate it.
Thank you.
Thank you, Madam Chair.
Thank you, Representative. Representative Reddington Hughes.
Oh, thank you, Commissioner, for being here today and
Thank
giving
you.
us some enlightening information. My question has to do on the raise bill 6979. And in this, it has the commissioner may impose any conditions or restrictions upon the scope of practice of a physician whose license is reinstated pursuant to the provisions of the subdivision. And then going on to say that relating to the provision of volunteer services without money and compensation. And I understand the purpose of the bill is to allow retired physicians to provide free healthcare at nonprofit clinics. would the doctors that have retired and would now be re-engaging and reinstated be limited to volunteer work, or could they then re-engage with a paying practice?
So some of this may need to be sorted out as well, but one of the biggest challenges for many physicians is they may not want to pay for malpractice, because that's really the issue,
Yeah.
right? The issue is if they want to pay for their own independent malpractice. They want to do that. That is certainly something that's possible, but I think what we're trying to allow for first here is that without having to do that, without having to take on that additional financial burden, that they could provide free service.
And do you think that this would affect the standard of care in these cases?
I do not believe that it would impact standard of care. We're really talking about having a scope specific to primary care and behavioral health. And of course, it would be on the institution who's hiring that particular person to ensure that they can provide those services. And these particular physicians would still have a license by which we have the authority to ensure quality of care. So if there were any complaints submitted against somebody's license, they would be investigated just like anybody else who gets a complaint lodged against them and have to potentially undergo the same disciplinary action that any other physician would have to go through. So I believe that this provides us with the regulatory oversight to ensure quality of care is maintained.
And if the clinic is providing services free of charge, are the doctors being paid for their service?
That would depend on the individual clinic and what their model is. So it would depend on what they wanted to be able, what they do in general.
It's because it seems that the bill, the intent of it seems to suggest that the doctors are donating their time.
Yes.
And I'm just trying to clarify whether or not that is the case, or if in fact the nonprofits are paying these now reinstated doctors for their services.
Right. So the initial intent of this is pro bono. That is the intent of the bill. And, I have received outreach from many physicians over the years who want to provide pro bono services in their retirement. And given the shortage we have of primary care providers and behavioral health providers in our state, this at least could provide an opportunity, particularly in those clinics where often our most underserved people are, and where we could expand the number of providers to be able to provide service.
So in the instance where this is pro bono, then the malpractice would be under the umbrella of the nonprofit, correct?
That's correct.
Thank you.
Thank you, Representative. Let me just check online. Okay, seeing no further questions. Commissioner, thank you very much for the
Thank you.
time that you've spent with us today, the answers to questions. I know we will remain in conversation, and certainly other members of the committee may have additional questions as we go forward, but we appreciate your time with us today.
Thank you very much.
Next, we will go to Mr. Michael Werner. Welcome.
Thank you very much. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Datria, Senator Marks, Senator McCrory, Representative Belton, and other distinguished members of the Public Health Committee. My name is Michael Werner. I'm the lead aging policy analyst for the Commission on Women, Children, Seniors, Equity, and Opportunity. I'm joined by our commission undergrad policy intern, Madison Danu, who will introduce herself in a moment. And we are here in support of HB 6920, an act concerning patient-specific emergency medical care protocols for persons with a rare disease or special health care needs. HB 6978, an act concerning the Department of Public Health's recommendations regarding various revisions to the public health statutes, and Senate Bill 1325, an act permitting naturopathic physicians to prescribe and administer vitamin B12. And in addition to my role at the commission, I'm also the Long-Term Care Advisory Council Administrator and the co-chair of the statewide policy work group of the Alzheimer's Disease and Related Dementias Coalition. And we want to begin by really thanking you for raising these very thoughtful bills that help to meet people where they are, give them choice, and assure quality of services. I would be remiss if I didn't mention today's Alzheimer's Day, but yesterday was Rare Disease Advisory Council Day. I had the good fortune of attending that and seeing a number of legislators, including the chairs of this committee and of Human Services, among many other legislators, attend that event. And it was very powerful to hear the stories of patients, their experiences, their family caregivers, and of course, the innovative providers that we have here in Connecticut to help address these serious issues. Rare diseases are comprised of over 10,000 different conditions. And in our state in Connecticut, we have over 300,000 people who would be considered having rare diseases, which is almost as much as 1 in 10. And we heard yesterday a lot of really powerful facts, including about 70% of the rare disease sufferers are children. So these bills go forward thoughtfully in alignment really with the legislature's work, including through biomarker testing, helping people really age in place, and also support family caregivers. So we do have one recommendation on 6920 is that the bill should establish a clear time frame for when a protocol must be created after a rare disease diagnosis. So once someone is diagnosed, potentially within 30 or 60 days, to have a protocol developed so that in case of a flare-up or a medical incident, that any provider would know how to best take care of them.
Excuse me, Mr. Warner, but your 3 minutes has ended.
So I'm going to now go to Madison for her remarks.
Mr. Warner, if you just give me a second, I'm just going to ask you a question and I'll ask a follow-up. And
Very
if you actually could introduce the person who's sitting, or you could introduce yourself before I go forward. Madison, can you introduce yourself?
Yeah, I'm Madison Dainu. I'm a student at Central Connecticut State University with my getting a degree in policy and gerontology. And I'm also an intern for the senior subcommission.
Wonderful, wonderful. Mr. Warner, so your comments specifically on the patient protocols with rare disease, you're asking for a clear time frame. But I believe we have some other specific comments on some of the other bills as well. Is that right?
We have submitted, with the help of Yale School of Public Health Fellows, very robust written testimony that I encourage you all to read. If we have more specific questions, we're happy to follow up with you, but our primary recommendation for today's public hearing is simply to go along with these 2 rare disease companion bills, is just to simply say upon diagnosis, to really make sure that that individual has a protocol developed in a timely fashion.
Thank you for that. I will say that your written testimony is extensive and wonderful, and I would recommend to the members of the committee and others that they take a look at that. Madison, did you have any follow-ups to that you'd like to add?
Yeah, I'd just like to place my support and thank the public health for listening to Senate Bill 1325, permitting naturopath physicians to prescribe and administer vitamin B12. There's a lot of benefits to this bill. Mostly spreading awareness and to the services available provided by naturopathic physicians. It's building off of previous legislation that is supposed to or intended to make naturopath services more visible. Building off of 2014 established naturopathic doctors to practice based on their education. in 2022 is amended that these services could be covered under Medicaid. And just last year, they're able to prescribe medication. So this bill allowing them to prescribe and administer vitamin B12 will help broaden their services as well as increase the amount of people able to receive vitamin B12, which is definitely in high demand, especially with the older adults of Connecticut. Thank you.
Thank you very much. Senator Anwar.
Thank you so much. Mr. Werner, I wanted to clarify your support for 1325 for naturopaths. How does that fall into the realm and responsibility of CWCSEO? Is that your personal testimony or is that your official testimony for that? Because that will be important for me to know.
Thank you for that question, Senator. In 2022, our commission testified in favor of, I believe it was Senate Bill 280 at the time, an act concerning naturopaths to make them eligible for Medicaid recipients. We're continuing our support of naturopathic doctors as far as choices and options, and part of an overall theme of aging well in place, having choice, having quality services.
So you feel that's part of the commission's responsibility to weigh in on this issue? Or is it a personal choice of people who are serving in some capacity? Because I'm not able to understand the commission's has a mandate, has a responsibility. And I'm trying to understand where does it fall under that, because my reading of that is it does not necessarily fall in that category to advocate for a specific group of people on naturopathic physician.
Yeah, part of our mandate is to advocate for systems innovations. We're being supportive of a trend by the Connecticut General Assembly to allow the practice of naturopathic medicine as it was established in, I believe, 2014, and then in 2022, Medicaid now has a waiver that allows for naturopathic doctor visits by Medicaid recipients. We appreciate the thoughtfulness of this bill and we're supporting it as it's on the agenda.
So in the recent past, the naturopaths have changed their position, but during the pandemic, the official position was that they did not feel that any vaccine would be effective. They felt that there's some medicines that they may have in their cabinets that could actually change and boost the immunity and thus change the pattern, and no child, no adult needs any treatments. So that's why I'm trying to understand that for an entity like yours, in the past to be there and also putting in a blanket statement like that is interesting for me. So I just wanted to make sure that we are in sync with what's being said by the organizations that you're lending your support to. But they're since then, they're changing their perspective from what I understand in my conversations, and hopefully during the course, they will come and speak to that as well. But there's evidence-based stuff, and then there's things on the shelf that people said that thing. And so what is that thing in the shelf? Well, I can't tell you. And so it was quite interesting to say that in the midst of a pandemic that killed 14,000 people in our state, to say that I have something in the shelf that's going to fix that was pretty fascinating. But I heard your testimony with interest. I want you to be aware. Thank you so much.
Well, thank you very much, Senator. And if I may simply reflect that there's a regulatory framework that governs this established practice, and we're simply supporting testimony, but I certainly appreciate your remarks and we appreciate being here today. Thank you.
Thank you, Senator Gordon.
Thank you, Madam Chair. I have a lot of questions, but I'll limit it to two at this time. One thing I just want to see clarification on, I understand the need for various protocols for rare diseases, and it's just not rare diseases. It's also many of the different drugs that are out there that have very unique side effects, such as immunotherapy that gets treated in very different ways than, for example, immunotherapy causing diarrhea has to be treated very differently than diarrhea from norovirus. developing protocols, I don't have a problem with per se, and that can be very helpful. But you're not at all looking to have these protocols be set in stone. There's still going to be the judgment, the decision-making of the medical professionals in that emergency situation to use protocols, but also adapt as they may need to in any emergency situation. Is that correct?
Thank you for that question. I'll first state that we're very fortunate here in Connecticut to have such great resources as Yale, UConn, the Jackson Laboratory, and the Connecticut's Children's Hospital, who have a lot of experience in this area. And, you know, the reflection on developing protocols are for emergency situations. I do believe that, you know, part of our work in supporting Rare Disease Advisory Council and just rare diseases in general, we took a call from a constituent. I remember clearly, it was in 2023. She was a older adult family caregiver in her 70s, caring for her daughter, who was 41 years old, who had stiff neck syndrome, which is widely recognized. Celine Dion, the famous musical performer, has this condition as well. And she would talk about how she would go into the hospital. They wouldn't know how to treat her daughter, and it would end up always being 6 hours, 12 hours, very long stay. So I do believe the intent behind the legislation is to help get people in and out. My understanding is that, you know, in the 80s and then previously there was, you know, the condition of sickle cell anemia, which is now has a lot of more awareness. There weren't protocols developed at the time. Now there are. So when folks have a flare-up of the condition, that they're able to receive services in a timely fashion due to the development of protocols.
No, thank you. I appreciate it. I can tell you that sickle cell anemia protocols have been in place for decades, especially throughout my entire career as a doctor. They've been in place. I just want to make certain that we're understanding with protocols, they're not going to be set in stone and tie the hands of medical decision making that has to be done at that moment, because sometimes things have to change with and adapt a protocol to an individual's care. So I'm not against protocols, they're guidance, but as long as they're not set in stone. And if I may, I just have a question about B12. And if I can just ask that in two quick parts. One is, there was a comment made during testimony that there's a lot of elderly who have B12 deficiency. In the United States, do you know what the prevalence of true B12 deficiency is, the United States of America?
The prevalency of the deficiency, having stats on that, not at my fingertips. I do understand that there's a connection between cognitive decline or impairment that may naturally be occurring that B12 may potentially remedy and address. And so that might help with quality of life for older adults in our states to be able to receive those.
I can tell you as a blood specialist, the data is around 5 to 6% of adults greater than 60 have a truly diagnosed B12 deficiency. And the vast majority of those are readily treatable with oral B12 that you can recommend someone take over the counter at 1,000 or 2,000 micrograms a day. So the actual number of people who really truly benefit from B12 intramuscular injections is actually low. So the reason I'm mentioning it is we need to be careful when we talk about that B12 injections. If a naturopath physician wants to do it, it gets overused, and there's a lot of problems where people don't properly make the diagnosis, such as they see a low normal B12 and assume it's low and don't check, for example, a methylmalonic acid level, provided the person's renal function is okay. So the diagnosis gets overdiagnosed, and that's been known in the literature. So I just want to caution, if we're going to be talking about B12 injections, we really understand its use. And that's extremely important. I know medical doctors do and others do. So I just want to make certain we put this into perspective. It's not a widespread epidemic. So that's why I was asking the question about the prevalence, because that's important to understand. You know, there's what there really is out there relative to people who benefit from intramuscular B12. There are some who do, but a lot of folks get it and they don't actually need to get it. But that's my question. Thank you, Madam Chair.
Thank you very much, Senator Gordon. Seeing and hearing no other questions. Thank you very much, both of you, for your time today and being with us.
Thank you very much, and thank you kindly for raising these bills. We appreciate you.
Thank you. Because we have reached the first hour, we are going to go next to Kathleen Garrity, to be followed by Mr. Sanjnani from the Office of Health Strategy.
Thank you, Representative. Senator Almore, Representative McCarthy-Vahey, co-chairs, and members of the Public Health Committee. I am Kathleen Garrity, Executive Director of the Connecticut State Dental Association, and I have the privilege of appearing before you today representing our state's oral health care providers and our patients. I will be speaking in favor of Bill 1326 regarding water fluoridation and raising concerns on Bill 1331 regarding the state's health information exchange. We have written testimony on both matters. CSBA strongly supports Raise Bill 1326, which enables Connecticut residents to continue to benefit from fluoridated community water systems as they have since 1965 by enabling our state to control the fluoridation levels. There are 75 years of scientific data to prove that not only is fluoride safe for humans, but it is in fact beneficial. It benefits the whole spectrum of life, infants to seniors. And I appreciate the Commissioner's previous comments on the topic of IQ and development impact, and I appreciate how factually she addressed those issues. Community water fluoridation is recommended by the American Dental Association, the American Academy of Pediatrics, the World Health Organization, and the CDC, which named community water fluoridation one of the 10 greatest public health achievements in the 20th century. Almost 90% of all Connecticut residents have the ability to access fluoridated water from 32 public water systems. It is a valuable tool, especially for our vulnerable populations, including those that are Medicaid eligible and people with disabilities. The simple act of drinking water can vastly improve oral health and keeps your teeth strong while reducing tooth decay by 25% in children and adults. This means that we have better oral health, fewer cavities, and less dental pain. It also saves money for both the patients and the healthcare system. I'd be happy to address questions on that, but I would like to quickly shift topics and go on to discussion of Bill 1331. CSBA supports this bill. We have been providing both OHS and the CONI system with information, both directly and as part of the working group for several years, and continue to raise concerns regarding the cost of oral health care providers to participate in the exchange, the data privacy issues, liability of providers, and other matters. But regarding this specific piece of legislation today, we would recommend, instead of a study, the committee consider the substantive recommendations submitted by Mag Morielli, Amanda Gunthal, and Dr. Anthony Yodel, who are appointed members of the working group created under Public Act 2419. We have sent a letter dated in November of 2024 to OHS, specifically with recommendations. This letter is included in my written statement. As part of the coalition of 23 healthcare provider associations and organizations, we notified OHS that we supported the recommendations in the letter, and in addition, our request that OHS review the fiscal impact of dental practices to participate in the exchange. We continue to support these recommendations, which provide a detailed roadmap of legislative and other changes necessary to protect patient information and to shield healthcare providers from onerous requirements. Thank you.
Thank you very much. You got a lot in there in that 3 minutes. That's wonderful. I just want to make sure that you did submit written testimony on both of those. Is that right, Kathleen?
I believe they're forthcoming. I don't think we've hit submit yet.
Okay, that's great. I would love it if you will. And so we
Absolutely.
can make sure that that's up on the bill page and everyone has the opportunity to read that and to see it. Are there questions? Seeing and hearing none, Ms. Garrity, thank you very much for your work and for being here with us today.
Thank you for your time.
Next, we will have Mr. Sanjnani. I hope I'm saying that correctly. I apologize if I did not. Please welcome. We're happy to see you here in person.
Good afternoon, esteemed members of the Public Health Committee. My name is Sumit Sajnani. I serve as the state's Health Information Technology Officer based out of the Office of Health Strategy. I have always appreciated the engagement of the Public Health Committee. I have had an opportunity to work with a number of members of the Public Health Committee on the HIE, and I have also appreciated the interest, not just of the Public Health Committee, but also the stakeholders in Connecticut on the statewide health information exchange. I'm here today to talk about a bill that's been raised, Senate Bill 1331, which is an act concerning the exclusion of patient health information and the opt-in and opt-out procedures relating to the statewide health information exchange. This is something that we've been working on, and extensive work's been done on it. And what my goal here is to highlight some of the work that's previously been done, in hopes that the committee can see that this study would be redundant and possibly detrimental to the existing program. And I have provided written testimony which details out the previous work, but I wanted to highlight a couple things on behalf of OHS, as well as the engagement that we've had with a number of providers in the community and patient advocates and others. So the health information exchange currently is connected with 3,000 provider locations in Connecticut. So it is an existing operating program. Prior to it getting operational, we took consent management very, very seriously. Patient privacy within OHS is a critical matter, and it goes back to actually 2010. The Health Information Technology Advisory Council, which is a statutorily created council, has responsibility to advise OHS on a number of health IT items, including the HIE. The appointed seats on HITECH include provider organizations, patient advocates, and others. And as part of that, there were a number of committees, public committees created, which included formal recommendations on consent management, including in 2019. Those recommendations then went through public comment period for 30 days. We received a series of public comments on that. It was then included in the Health IT annual report in 2020, which also went through public comments, and we received a series of public comments. So before Connie became operational in 2021, this work was done, and the recommendations made both by the subcommittees and the Health IT annual report were accepted, and the consent policy of opt-in, which is what the current HIE policy is also the national standard. Additionally, last year, there was a statute passed, PA 2419. What that required OHS to do is to create an additional public subgroup, which I'm fortunate that both the co-chairs of the Public Health Committee and the ranking members of the Public Health Committee had seats on that and actively participated in that. Those public meetings then resulted in recommendations that came out, which were documented and submitted to the committee, I believe on December 31st of 2024.
Excuse me, Mr. Jani, but you've reached your 3 minutes. Thank you.
Thank you. If you want to summarize, I know we have a number of questions, so I have a feeling we're going to be able to get into a bunch more with you. But if
Okay.
you wouldn't mind summarizing what you were just saying, that would be wonderful.
So a number of provider organizations that had raised concerns last year had an opportunity to participate in that committee. They made written recommendations. We included in our report in entirety all of the recommendations made by those organizations, including the discussion summaries that took place in the meetings. Again, these were public meetings, public comment was welcomed, and that all of those reports that I'm referencing are available through links in my written testimony.
Thank you. Thank you for that work. I know it's been extensive, and it certainly will be an ongoing conversation for you, and I think for all of us, just with not just the technical issues, the cost issues, but the ongoing issues related to privacy are, I think, significant. But I'm gonna turn it over first to Senator Anwar.
Thank you so much for your testimony, Mr. Sajnani. So good to see you. I've seen you on Zoom many a times. Now I get to see you in person. Um, Here's a clarification I wanted to understand. In technology world right now, the thought process is that there will be a breach. It's not a matter of if, it's a matter of when. And so that's the mindset as people who hear from the general public and also various groups. Now, when the information is all consolidated, it becomes a treasure trove for people who want to hack and control it. And I know the purpose is a very good purpose for what we are trying to do. We want information to be able to create more efficiencies, understanding, and then patterns, and then see that this makes sense why it needs to be done. And the anxieties are around some of the information you don't want in the quote unquote dark web or whatever it may be. And so with that in mind, the issue comes down to is that we have an opt-in and opt-out option available, but it's almost like an all or none phenomena. So, and that's where there's an opportunity to fix it. So for example, if somebody has a cardiac issue, they want to opt into HIE to be able to say, you know what, I need this. But let's say that person wants to have a plastic surgery, or they may have some other medical problem that they do not want 5 years, 10 years, 50 years down the road to be identified by anybody. So there should be a menu of opt-in and opt-out rather than an all or none phenomena. Is there any thoughts on that, and can that be an option?
So Senator, that's a great question. And I think that's a question that a number of health data entities, not just the statewide HIE, but whether that be EHR systems, data sharing, struggle with. The couple of things I would first just point out. I think in terms of data security, as you said, it's not a matter of if, it's a matter of when. What we have done with the statewide HIE is the highest level of certified, high trust certification on security that currently exists. Number two, in terms of the analysis of the overall opt-in versus a menu of selection items, the concern here has been if we want providers to rely on a complete medical record to provide treatment, and if they don't know that certain critical components of the medical record are missing in the HIE because the individual had chosen only to put in part of the record, then they might provide treatment that might have contraindicators, whether that be from a medication perspective, because certain medications weren't included. So this is something that nationally is being discussed. It's been discussed within Connecticut. We've had a number of consent presentations around that. But the reason we haven't proceeded with that is, and this is again, not just for the Connecticut HIE, this continues to be a concern for all health data organizations, is what is the negative impact when you have a partial medical record in terms of providing treatment? And the statute, the reason for creating this official statewide HIE in Connecticut and what the statute requires us to do is make sure we have the complete medical record. That said, there are components of the complete medical record that we have been on record saying that we would exclude. So marriage therapy type of medical records, which don't directly tie into coordination of care, we said we would exclude. Any court-ordered type of psychological evaluations, we would exclude. Substance use disorder type of records are going to be handled separately as part of the 42 CFR Part 2. So there are a number of exceptions built into this that either come directly from state statutes, federal statutes, or the discussions that have taken place in Connecticut. But we're open to continuing to have that discussion on the Connecticut statewide HIE to see if there are additional examples that we can restrict or exclude.
And so somebody else mentioned this in a conversation I had, and I wanted to clarify. So let's say an individual has opted out and they do not want the information. Next time around, there's this electronic sweep, if you will, that goes and extracts the data. When that happens, that the previous opt-out may be forgotten and it may still go and get this the way the system is set up. Is that accurate?
No, that is not accurate. So once you opt out of the HIE, you truly opt out of the HIE. So your preference of opting out is registered. And as soon as records start coming in from the provider organizations, they're going to get filtered out for you. And we won't even go back in time. So let's say you had opted out and you decide to opt back in again. We're not going to go back in time for the period that you had chosen to opt out to go sweep your record. So that's just misinformation out there. If people believe that even after you've opted out, your records can be included in the HIE for care coordination, the TPO purposes.
And do you anticipate a menu-based system coming in soon where people can opt out of various parts of their health, mental health, and other components, or it's automatically done?
So what is in production now, what is operational today is, except for the SUD, where you do get to give affirmative consent on your records, and FERPA, where you're protected based on educational records, everything else is either all in or all out. And there are individuals in Connecticut, close to 7,000 individuals who've taken advantage of that opt-out option. We have advertised these options to patients through different mechanisms. All of the privacy disclosures at provider organizations that are connected to the HIE include this disclosure and how people can opt out. In the future, there is an opportunity to explore from a technological perspective and understanding the clear disclaimers to the person who's receiving the record, the care coordinating provider who's receiving the record, to know that there might be something missing from this record because the patient did not want that included in the HIE.
Thank you. My final question is a comment. I appreciate the meetings that you all held with all the various healthcare providers and people in the healthcare world. I just want to know the anxiety that everybody has around this issue is so significant that people who are never in the same room at the same time were all sitting down holding hands about HIE and how they were scared and concerned about it. So you brought the entire healthcare world in one place. So thank you for that, I guess. So thank you, Madam Chair.
Thank you very much, Senator Anwar. And I see no further questions from members of the committee. Oh, I'm sorry. Thank you, Representative Reddington Hughes. Please
and
proceed.
Thank you for your testimony. And this is going back to what we were just discussing. Do you see a day where the patients who are being treated who have opted out would have to sign something from a doctor's office saying that they've chosen that, because they certainly are not giving the physician or whomever the full picture of who they are treating? And I just would wonder about what the liabilities were there on the part of the doctor as a result of that.
Well, you bring up a really good question. So the way the opt-out works is you can do it a couple different ways. You could directly contact the statewide HIE Connie and choose to opt out. On the SUD portion, there is the provider affirmative consent, and soon to come the patient consenting to those pieces of the SUD. We, in our provider agreements, include these within the language so providers are aware which records are controlled which way. So that is how we're managing any provider liability, because those are clearly defined in how those records are going to be handled.
Thank you.
Thank you, Representative. Thank you very much for being here with us today. I imagine that these conversations, as many here today, will be continuing. Certainly your work will continue, but thank you for the time today.
Thank you for having me.
Next, we have Mary Ann Langton, to be followed by Senator Austin. Is Ms. Langton here? Okay. Senator Austin, it looks like you're up. Welcome.
So Hold on a minute. Got to grab out my testimony. Because apparently I can't remember anything anymore. So. Like to know those that testified in front of us for you guys. That's what I have in my pocket right now. So good afternoon, everybody. I apologize for not being completely prepared. I don't like to do that to anybody. So I'm here to speak in support of Senate Bill number 1325. It's actually an issue that I've been dealing with for a number of years. And this would permit naturopathic physicians, different than naturopaths, but naturopathic physicians to prescribe and administer vitamin B12. The Commissioner of Public Health is required by Section 61 of Public Act 24-68, conducted a scope of practice review for naturopathic physicians to determine whether they should be authorized to prescribe, dispense, and administer prescription medication. In response to this act, the Connecticut Naturopathic Physicians Association submitted a detailed scope of practice request asking for the expansion of their practices. And why would I think that this is something appropriate to do? Now, I've talked to doctors all over the place. Senator Anwar is a doctor. And I would like to see us work more with the naturopathic sides of things. The naturopathic physicians are trained. I think this makes a lot of sense. I myself don't go see a doctor, mostly see an APRN. And I know that saying this, I'll have 65 emails from APRN saying that they're better trained than everybody else. Quite frankly, I think we need to broaden our scope. So some know, some may not know, but I spent some time in Japan when I was in the military. And the eastern part of the world treats a lot of things more naturally than the western part of the world. And I am more inclined to seek a more natural way or way relative to dealing with issues. As a matter of fact, I have often said to Senator Anwar, I stay as far away from doctors as I can. Don't care to see them ever. Would like to see us do more and more along the natural way of things. I also think that Native American have a way of looking at things, and I just have a clear affinity more with the natural way of doing things. Now, I've had family that have had to use regular doctors. I broke my leg. I found that you need a regular doctor to stitch it back up again. But I would like us to consider this as a small beginning to us dealing with this issue. Now, I'm not asking and never will ask for naturopathic physicians to be involved in opioid kinds of things, because I think we use them far too much, even today. And so I appreciate you all bringing this up and actually bringing to fruition a bill that we could actually see if we could get over the finish line and start moving more clearly in that direction. I thank everybody for the emails that I got from the doctors on this bill. They were pleasant. Probably a little bit strident on their opinions, but I'm equally strident on mine, and I would like to see us start to move in a more a natural way, herbal way, low-key way of dealing with things, and would like to see people stem away from medications as a first line of defense on things. So again, thank you very much. I'm hoping to see this bill make it out of the committee and then ultimately pass as law. I would talk about Representative Ezekiel Santiago, who was very much in favor of this. I'd like to see us consider this.
Thank you, Senator. And I know Senator Anwar will have some questions for you, but people haven't been able to see me smiling. I appreciate you coming and testifying before the committee and taking time away from appropriations as we're following along here behind the desk as well.
I got 5 minutes to get up there.
So
Ask away.
the question I have is, when it comes to this issue, that there can be a lot of sensitivities in this, and we certainly were having some conversation earlier related to vaccines, and you brought up opioids. So there's a lot there, and certainly a lot that we're talking about in the public
Right.
domain at this point. But from your perspective, and this is, I want to make sure I'm hearing you correctly. What you're saying is you would like to have a range of options, not that you don't believe in certain medications, prescribed medications as necessary. You're looking for a different range of that. Is that what I'm hearing you say?
That's absolutely correct. Now, a lot of people talk about vaccines based on the fact that we had the pandemic and COVID and a number of other things. So when I was in the Army, and in basic training, of course, basic training's a super lot of fun. I encourage everybody to attend basic training sometime. But they have you walk through a phalanx of people, and they say, don't tense up, because that immediately puts you at ease when they say, don't tense up. So I'm telling you, you tense up. But if you tense up, the shots that you receive in your arm, can hurt a little bit. I went through all of that. I had no problem with any of that. You're going into different countries. You have to have inoculations against the different things that you may come across. And so I probably had 50 or 80 shots, probably in like a day or two time frame. I'm thinking that probably makes you feel a little bit bad, but hey, you're young and who cares, right? But I am not interested in saying that traditional medications are not absolutely necessary. And I think everybody has their own way of dealing with this, but I really think that for people like me who are more interested in dealing with, like I rarely drink. I just recently went back to caffeine. I try to do many of those things without interjecting some of the consequences of those products. And I would really like to see us step back and have some other authorizations. And am not asking that this take the place, but be in addition to for some people who are interested in this type of medication.
Thank you, Senator. I appreciate those answers. We had a press conference earlier today related to heart disease, and Representative Exum was talking publicly, so I will share that here, about her own husband, who also very healthy, but had genetic cholesterol issues and needed to take medication. So I appreciate your answers. I'm going to turn it over to Senator Anwar.
Thank you so much, Senator Austin, for the work you do and in your testimony. So I'm trying to reconcile with the mindset that naturopaths are providing treatment through natural means, and the non-naturopaths are using treatments which are, for lack of a better word, unnatural means. But why would naturopaths be interested to move towards the unnatural means when they're doing so well in the natural treatments?
Great question. So naturopathic physicians are using means that are not prescriptive in nature, but some of the minor prescriptions, like if you have a UTI, you just need an antibiotic. You can't treat it without an antibiotic, but their regular doctor, the person they always see that understands that, and introducing an antibiotic to somebody is not over the top. And rather than having to pay for the naturopathic physician who knows them, not naturopaths, naturopathic physicians are different than naturopaths themselves, to have the ability to institute this. And this is just for B12. Quite frankly, I would expand it to a very small formulary. But I'm willing to just accept this and to prove to people that this is another way of sort of handling healthcare. And I think when people decide that they are the only way, that is, we already have a huge problem, quite frankly, with a distrust of the traditional medical field. And I joke about it with you, but it's not really a joke. You know, for someone like me, I'm not interested in starting out with that higher level, and often feel that quite frankly, and I have no idea how many doctors I'm going to hear from now, but I have like 600 emails right now that I have to finish answering. So what's a couple hundred more? But that think that they know my body better than me and not willing to listen to what I am saying. And I find that to have a conversation with a naturopathic physician who is a trained physician is someone that is willing to listen to me describe what is going on with me. And that is, and I appreciate that. But when I go to see somebody else and they walk in and they spend 2.5 minutes with me and then walk back out, and I get billed for half an hour, whatever I get billed for, is not something that I find as creating that trust environment. And we don't have primary care physicians anymore, relatively speaking. We don't have enough to fill that gap. And so often you're going to see somebody who is busy handling more complex problems. And I envision this as that initial interplay with someone. And I'd really think that, you know, I was talking to my grandson. He went to see the doctor the other day, and he's somebody that goes to doctors unlike me. And the doctor came in and he could hear him asking questions to other people. The doctor came in and didn't even deign to give him attention. Said, oh, we forgot to tell you that you had to get all these other tests before we can actually talk to you. Now he's sensitive to people dismissing him, and I felt like this person didn't even care to have a conversation with him. I'd prefer him going to somebody like this that's going to actually listen to what he's saying is going on with his body. And I think sometimes we have so made it an expensive endeavor, and the work that you have to do is giving people not a lot of time to actually sit down and talk about it. I prefer this sort of conversation and care than other kinds. All due respect.
Thank you so much, Senator Austin. Your as my colleague and as my
Late.
yeah. Thank you.
So
Take care. We'll talk more later. So thank you
okay,
so
you
much.
can chat more, and I thank everybody in advance for their emails.
We do have another question for
Okay.
you.
Oh,
Ready
thank you
to
for being
use-
here. I know you're busy. I'll make it quick. So right now, naturopathic physicians, they can prescribe the B12, but it has to be, whoops, it has to be oral, correct?
It's probably Tony asking where I am.
Oh.
That has to be oral.
Oral. Okay,
Yes.
so what we are basically asking with this bill is to, in addition to them being able to prescribe it orally, that they can inject it, correct? So the really crux of this is that I mean, some people prefer physicians, you know, medical doctors. Some people would like to go to a naturopath. What this bill is doing is to give them the freedom of choice, correct?
Absolutely correct.
All right, thank you.
Thank you, Representative. And Senator Austin, I will add, I think that when patients see Senator Anwar, they certainly receive a loving, caring response.
I'm not
I
criticizing
I know-
individual people, but I
I-
am saying that our medical system is not fully staffed, and this is
That's
another means, and I would prefer this means.
And that's absolutely correct. I think my point is it's certainly a systemic issue. And also that trust and relationships in medical care in behavioral health. Those, you're raising that point as a very integral, central point. And I think that's important, but you're right, there are systemic issues, whether it's related to reimbursement, shortage areas, all those things. So thank you for the time with us
Okay,
today.
I'm going to need a note from each and every one of you that I was late. for
We
my
will
meeting
vouch for
because of
you.
All of you. Thank you.
We will vouch for you. Thank you for being here, Senator Austin. And next on our list, we have, I believe, Kim Sandor is with us online. Welcome.
Thank you, and good afternoon to all of you. Senator Anwar, Representative Kristen McCarthy-Vahey, Senator Summers, Representative Clarice Dietrich, Representative Belton, Senator Marks, Senator McCrory, and members of the Public Health Committee. It's nice to be here with all of you and nice to see new faces that have joined the committee this year. My name is Kim Sandor. I am the Executive Director of the Connecticut Nurses Association, and I have the privilege of representative nurses across the state of Connecticut in all specialty areas and practice settings. And part of our ethical duty is to also share our knowledge in the workplace and as members of the healthcare system to elevate issues related to patient care and the healthcare landscape in Connecticut. And with that, I'll be commenting on 3 bills before you today. I don't know if I'll do it as quickly and eloquently as my former folks that have been on, but let me give it a try. I just like to start with 6975, that is addressing the biennial study of payment parity for services in the state. And I just want to elevate, we all know mental health is so important. It impacts all individuals, and our healthcare providers are experiencing mental health issues at the same or higher rates than the general population. The daily burdens of our work is not much different than the daily burdens of many in our society, but nurses are having 40% feeling depressed and 60% feeling very anxious. And it's imperative these services are covered, barriers are removed, and most importantly, we normalize that taking care of our brain is just as important to taking care of the rest of our health. What do you know? They're connected. So anything we can do to ensure that there is parity in coverage. I know others much more informed about this and eloquent will speak to it, but the Office of Health Strategy report that 4 out of 7 commercial insurers in Connecticut are exhibiting warning signs of parity noncompliance was very concerning, and we felt compelled to address it. The second one is 1331. This is about the exclusion of patient health information, opt-in and opt-out. And again, I don't need to rehash what's already been said, but I just want to elevate a couple points. One is about, there was a comment about incomplete information, and I thought that was an interesting comment because at the moment, all healthcare providers have a duty to collect information. It is part of our initial assessment of a patient to get as much information as you can. And we will continue to do that. And I think seeing the rare disease bill saying you have to follow what's in a record and seeing that there's pushback on that is kind of a funny juxtaposition with the health information exchange saying if the information is there, then you follow it, right? Well, the physician, the healthcare provider, APR, MPA is going to do an assessment and make a judgment based on the information they have. Also, personally, in my world, I say, hey, do you know that all your health information is on the Connie? And they say, no, I do HIPAA. Nobody would ever send my information unless I sign for it. It's such an interesting comment. And my parents, family member, was discharged from the hospital. And there was a 1 line on the bottom of the last page of the discharge instructions about Connie. That is in such a contrast to the HIPAA thing we've all been doing since 1996, where you get a paper, it describes it, and you sign it, and you have full understanding and knowledge of that. And if it's happening, I don't think people understand it.
Excuse me, Miss Sandor, but you did
Yeah,
your 3
all right.
minutes. Thank you.
Thanks, Kathleen. I
Yeah.
didn't think I would do it. But thank you.
Oh, Kim, thank you so much for your work. And we do love Kathleen. But do you want to add any other quick thought about any of the other bills that you?
Thank Thank you for that opportunity. I appreciate that. 6979 is the recommendations regarding physician recruitment. I just wanted to elevate, there are many healthcare providers that can continue to contribute to serving the needs of our patients, our communities in Connecticut, and really just look to be able to ensure we're adding APRNs, PAs, and others who provide services in that area. And I just wasn't clear on the last section. I am super fan of these loan repayment programs. I was a National Health Service Corps APRN myself, and I feel like that experience has forever changed my outlook on the healthcare system and patient care, and the needs and how do we address health in our systems. And I just really applaud the ability to do anything where we can have expertise in those underserved areas. And just want to be clear that RNs are included in the definition of healthcare providers, and that APRNs are included. It kind of lists like family health, pediatrics, it doesn't specifically state, it has general words there. And I just wanted to kind of ensure that that was the intent.
Thank you very much, Kim, for your testimony. Questions? Seeing and hearing none. Thank you for being here with us today. We will talk to you soon, we know.
Thank you. Hope to see you in person soon. Be well.
You too. Next, we have Commissioner Jordan Sheff joining us today. It's so wonderful to see you, Commissioner. Welcome.
Thank you. And thank you for allowing me to testify today. But I'm testifying today as Jordan Sheff, dad and advocate for my daughter, who 3.5 years ago got diagnosed with functional neurological disorder. So again, thank you to the Public Health Committee for having me. As I noted, while I'm the Commissioner of the Department of Developmental Services, and many of you have heard me testify on issues germane to that, I'm here today as an advocate for my daughter. I'm also a registered voter here in the state of Connecticut, and taking advantage of the democratic process to advocate today. I'm here to testify in support of House Bill 6920, an act concerning patient-specific emergency medical care protocols for persons with a rare disease or special health care needs. This bill will require a healthcare provider who provides medical care to a patient with a rare disease or special healthcare needs to adhere to any patient-specific emergency medical care protocols developed by the patient's personal medical team. FND, functional neurological disorder, is a rare disease that is a diagnosis of exclusion, meaning there is not currently a specific test, but rather you go through many, many tests for other things that cause similar symptoms. And if all of those get ruled out, you get assigned a diagnosis of FND. Because FND has no cure, you as a patient are continually hopeful that maybe it's some other treatable disease. The exams and testing for all those symptoms are exhaustive, and being told continually that you will just have to keep testing is exhausting and traumatizing. Given that many believe a root cause for FND may be trauma, more trauma often makes your symptoms worse. My daughter, unfortunately, has had multiple traumatic experiences at very fine hospitals and emergency care centers seeking treatment or support for a particular acute symptom, or in some cases, seeking treatment for non-FND related symptoms as well. As examples, she on occasion has been presented with temporary paralysis. We were seeking care to provide some type of intervention for the current episode. Certain meds available at the ER can help provide a pretty quick reduction of symptoms, intramuscular Ativan or something like that. But often they defer to running MRIs, sonography, x-rays, or blood work prior to assisting with what we know may help. What we had asked for was injectable meds, and taking them orally when she's paralyzed can cause choking. She's also fallen during a seizure. What we are seeking in those situations is an evaluation for any fractures or soft tissue damage. Despite that, we have had to submit to toxology tests or been started on IV seizure meds, which will not treat her seizures, and an EEG. We simply needed an x-ray to clear any notion that anything was broken before returning her to school. On another occasion, we presented during a regressive dissociative spell that had lasted longer than we had experienced previously. We had asked for a neurology evaluation. Instead, she was placed in the psych ward. While there, she seized, falling on the floor, having a bloody nose. She came out of the episode. We had not yet been seen by a physician or anyone providing treatment, and she was ready to leave. Being in that area was causing just further trauma. We were told that if we left, we'd be charged for our experience there. because we'd be leaving against medical advice. And this was despite contacting her psychiatrist and neurologist to call the ER and the hospital to ask that she be released. In each of these situations and others, she was just further traumatized. Despite having a plan of care authored by a Yale-affiliated board-certified neurologist and psychiatrist, I think that's pretty high status in the state, her input in advocacy, my input in advocacy, was all ignored. As a parent, I would like to see my child receive the care recommended by her personal medical team when she is in crisis and in need of emergency care to treat her FND. I would also recommend the emergency medical team be aware of her condition, the types of medications she's taking, the protocols in place to keep her safe when treating her for a medical condition that may not be related to her FND. Thank you for consideration of my testimony. And if you have any questions, I'd ask that you reach me at my personal email as opposed to work, because I try and bifurcate the two. Thank you.
Thank you very much. I guess I'll say Mr. Chef today. We are grateful for you coming and sharing your experience. And what's striking to me is that you certainly have the ability to advocate. You know how to advocate. You lead one of our major departments in the state of Connecticut. And yet still, as a parent, have faced such significant struggle. And so your voice here is very powerful testimony on this issue. I believe Senator Elmore has a question.
Thank you, Mr. Chef, for your testimony. And I just wanted to highlight a couple of thoughts. What you say means so much and such an important issue, and that's why we raised this bill at the request also and advocacy of RDAC community. If somebody has an asthma, they have an asthma emergency plan. And everybody knows it. And as soon as they call an ambulance or go to the emergency room, there's a whole plan of action in place. And every disease carries its risks, but the ones that are relatively common, their pathways are very well established. And for the rare diseases, those pathways are not established. And the rare diseases manifest in such a manner that people confuse them with the common diseases. And that's why this bill becomes more relevant, where we actually have a manifestation of the illness in a common form, but it's not the common disease. And then that's why having paper document and a plan of action for the patient to be ready as well would save a lot of healthcare cost and a lot of pain and suffering, as you alluded to as well. And then I think what happens is the people who are practicing in emergent situations, everything becomes a reflex because time is of essence. And I think that's part of the challenge. And I think this conversation was going to help us be more thoughtful in the process and have a plan of action.
Thank you, Senator Anwar. What I can tell you is I have spent much of my career balancing the needs for systems and person-centered care. In order to be efficient and effective, and I'm certain hospitals look at the same thing. How do you effectively treat so many people walking in your door within a system when people have individual needs? And you don't want to be penny wise and pound foolish. So the system is responsive to your standard plan of care, to your more typical illnesses. But in order to effectively treat that individual, it needs an opportunity for a specific person-centered response. And that's what we've lacked.
Very well put. Representative Claridis Detria.
Thank you, Madam Chair. Thank you for being here today. I think it's very important for us to hear. Unfortunately, you have to go through this personally, but that's, as you know, being up here, that's how we hear about certain things. They're personal stories of people we may know. My question to you, and I apologize if it was already answered, how would this roll out? So you have your medical history, I'm sure personally, of your daughter, you said, correct?
Yes, my daughter Stella.
Would it be something that you would bring with you?
She travels she travels everywhere with a medical alert type necklace, a bracelet, just in case the necklace gets removed by staff or someone else, or she pulls it off while seizing. She also carries a binder with her in a bag that is always with her. And that lists the protocol. It lists the physician overseeing a pretty diverse interdisciplinary medical team with contact information, numbers for me, numbers for her mom, numbers for the physician. And that is present with her. And including the physician's license number and the rest of that. And despite that, it's often, and I understand, right? If she's presenting in a way where she's non-responsive, a physician's initial and with good intent reason to perhaps take a more typical approach to intervening with her is how you would respond to somebody else in that. But we have very clearly not to start seizure meds, not to use 911 if she were to fall, be it at a prompt care, and not to bus her out by 911. There are very specific things listed there and authored. I am not, I'm not sure of the bill's origins. It was brought to my attention by the Rare Disease Committee, and they knew that I had an interest in this particular portion of it. So I know there's some reservations from medical folks in the state that the practicality of implementing something, because it really bucks the system response that I get why they need. So how it would be implemented, I'm not sure. How we've implemented it is the bracelet, the protocol, phone numbers, any information that she can provide. So that's the best answer I can give for you today.
Thank you for that. And I'm hoping through this process, we'll figure out if this bill moves forward as it does, what the best protocol and process will be for that.
And I'm happy to be part of any of those conversations, given my knowledge of the systems in the state, and I would do so on my personal time.
Thank you so much. Thank you, Mr. Chair, Madam Chair.
Thank you. Thank you very much for those questions. And Mr. Chef, we thank you for that offer as well.
Thank you again.
That's wonderful. And I imagine we'll take you up on that. Thank you. Next on our list, I just want to note that we will have some of the folks from earlier will be testifying a little bit later, just so that everyone is aware who's following along. So hold on, give me 1 second. I believe we have Christina Mucone, who is with us online. Welcome.
Hi, everyone. Welcome, or thank you. Senator Anwar, Representative McCarthy-Vahey, thank you so much for having me here today. I have written testimony for you. I know that you have it available regarding HB 6975 and HB 6979. I was hoping to talk to you about both of the bills today. For HB 6975 regarding behavioral health parity, I appreciate this bill being introduced. I do urge you and encourage you to continue to move it forward. As I know many of my colleagues have already addressed, we have continued concerns in the state with payers either currently not providing behavioral health parity or being at risk for not providing the parity of services as well. And this bill would help to strengthen those services. I also wanted to address to you HB 6979, as my colleague Kim had done previously. And just for some clarification for this bill regarding physician recruitment, there is currently a pathway for nurses and APRNs to have a retired license, but there's currently in statute under section 2010C, there is language that allows for volunteers to have the license fee waived if they're physicians. I know I'm familiar with many of you. I've spoken to many of you. I currently am an FMP. I practice at the University of St. Joseph as full-time faculty. And I also am a volunteer primary care provider at Malta House of Care, which is a free clinic in Hartford, Connecticut. So currently with my colleagues there, they do, for physicians, they get a waiver of their license fee if they practice 100 hours or more there per year. I do request, if possible, that you consider adding that language for APRNs and nurses and physician's assistants, who are also some of the primary volunteers there at the clinic. In addition to Section 5, echoing what Kim Sandor had mentioned, the language there currently states healthcare providers, but it is not really very clear that it extends to the other professions with the current language. I would request, if possible, if you can make sure that that does somehow clarify that it would potentially represent physician's assistants, nurse practitioners, nurses as well, that work in primary care as a primary care provider. And lastly, as this is very important regarding physician recruitment, many of you are aware we continue to have issues regarding APRN recruitment in Connecticut. There are 30 states and jurisdictions that don't require any physician involvement. As faculty, trying to get faculty to come from other states, it's a regular barrier. So if we can somehow have that reciprocity for APRNs from out of state that have not worked with a physician previously, that would really help us in terms of getting recruitment from other states and keeping our APRNs that we've trained in Connecticut to keeping them here and staying in Connecticut. And thank you very much. I'd be happy to take any questions.
Thank you so much for your testimony and your advocacy and for being here with us today. Seeing and hearing no questions, with my apologies to Dominic Cotton, who is here with us in the room and is number 11. You are up next, Mr. Cotton. Chris, press the button for me,
All right.
please.
I
Thank
should
you.
be experienced at this by now because I've done it enough times. I'm here to talk about 6920 and the protocols for patients with rare
Can you
disease.
introduce yourself, please?
Sure. My name's Dominic Cotton. I'm a rare disease advocate, but more importantly, I'm the father of Michael Cotton, who has a rare disease called SCAD. Essentially, he can't break down fats. So when his liver, which stores glycogen, runs out of gas, so to speak, he goes into a metabolic crisis. And at that time, until he can go back to being able to eat, whatever medical malady might be occurring at the time, he needs to be on an IV drip of dextrose 10, which will basically keep him alive and prevent him from possible brain death. I know over the years, he's been in the emergency room probably about 16 times. Out of that 16, 15, we would hand them his protocol letter, which I brought a copy with me, which explains his disorder. It explains exactly the protocols as to what the physicians need to do. The one time that we did have a major incident happened in Bridgeport Hospital. When we brought him in, usually what we do is we knew the head of pediatrics for Bridgeport Hospital. We would call on our way into the hospital so that they could call and inform the emergency department that we were on our way in, that we had a protocol with us, that this was the protocol that, you know, that they've been following for all the other times that he's been in. Except during this time, the physician on duty decided that she didn't want to follow our protocol, which was pretty simple. You give him an IV with dextrose in it. It's not very complicated. We explained this to her over again. We asked her if she'd spoken with the head of pediatrics. She said she had, and then ignored our protocol to the point where my son basically passed out and his eyes rolled in back of his head, at which point I think she realized that there was something seriously wrong. He survived that, but each time you put a child through that sort of crisis, you're doing damage to his brain. And it took him a long time to be able to come back from that. So we did go and actually complain to Bridgeport Hospital. We spoke with the president. That physician was removed from the emergency department permanently because of her actions. But it just highlights the issue that you have when you have to come in and advocate. I've had plenty of medical situations where I've been capable of advocating for myself. But when it's a child, they can't advocate for themselves. That's why we have these written. He was diagnosed at birth. He was picked up on a heel stick through Connecticut's programs. The first conversation that we had was 2 days after he was born with a geneticist who basically told us, look, you guys have to feed him every 3 hours. So for the first 4 years of his life, That's what we managed to do, was we fed him every 3 hours to make sure he had enough energy, because if you can't break down fat and you run out of like glycogen in your liver, your body starts to break down muscle. And
Excuse me, Mr. Cotton.
the biggest muscle that you have at the time that you're born is your heart. So we've known about this all his life. It's not complicated. He's
Excuse
got.
me, Mr. Cotton, but your 3 minutes, you reached your 3
I
minutes.
understand. Go ahead.
Thank you.
Do you want to summarize there for us, Mr. Cotton?
He's got a specific protocol, and I know Senator Gordon was mentioning previously about you have to look at other situations, and I get that, but you know what? It has to be a conversation, and you can't ignore what somebody's handing you from a geneticist. I get it. If he's got a broken arm, you know what? Treat the broken arm. I got no problem with that. But if he's in metabolic crisis, then you need to follow the protocol that a geneticist has already labeled out and is available to speak to.
Thank you. And thank you for sharing your story here with us. You talked about what happened to your son, and clearly your heart is in a lot of pain to think about that, and for you to share that with us and for all of your advocacy. You've been a tremendous advocate for the rare disease community.
Thank you.
Senator Anwar.
Thank you, Mr. Cotton, for your testimony and sharing that story and a painful story. And I think the relevance of when you put the story in the way you do is going to help a lot in how healthcare systems and EMS systems and everybody manages emergencies. With the healthcare dollars shrinking every day and in the patterns, I came across a situation where a hospital had made a protocol which said that the code of conduct of every healthcare worker will be defined amongst various other things about if they stick with protocols. And I had a significant problem with that mindset that we are being protocol driven for saving money and efficiency and starting to not think through the process and diseases. And with the number and the population that we have in our state who is not going to follow a protocol because they are not part of that protocol that is common for illnesses, we have to have an understanding and be ready at all times to address the patient's needs according to the patient's disease and existing diagnosis, because it takes years to diagnose a disease to begin with, and then not having it managed in emergencies. So your story is helpful for people who want to have a balance with the protocol-driven strategies to a cerebral or thoughtful strategies would be very helpful. So thank you.
Thank you.
Thank you very much, Senator. Seeing and hearing no other questions, thank you, Mr. Cotton, for being with us today. Okay. Next on our list is number 13, Christian Damiana.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, members of the committee. My name is Christian Damiana, and I coordinate the Connecticut Parity Coalition, which is a group of more than 25 organizations working to elevate behavioral health equity in our state. Today, I'm testifying in strong support of HB 6975, an act requiring a biennial study of payment parity, a bill that was recommended by our coalition. I've been deeply involved in our coalition's work on this issue, and I'm happy to provide insight into how this legislation will improve parity enforcement. We're deeply grateful to the co-chairs for their leadership in raising this bill and for the committee's continued focus on behavioral health access. We're joined today by more than 20 advocates, including clinician groups, the Connecticut Hospital Association, the Nonprofit Alliance, and the State Comptroller. And you're going to hear one statistic over and over. 4 of 7 commercial insurers in Connecticut, Cigna, Connecticut, Anthem, and United Healthcare, are meeting federal warning signs for parity noncompliance. The 2024 OHS Payment Parity Report made that clear, revealing information not contained in other state or external reports. especially the specific disparities in payment parity and the identities of the insurers responsible. The Public Health Committee required the initial report, but without continued data collection, we would have no way of tracking whether these disparities are getting better or worse. And what does meeting warning signs actually mean? It means these insurers are blatantly and systematically underpaying for mental health services, and the numbers prove it. Their payments for behavioral health care weren't just a little low, they were consistently lower than they should be, in some cases dropping below 90% of standard rates. Meanwhile, payments for other medical services, those mostly hovered at or above the benchmark rates. If that's not a flashing warning sign that something is wrong, I don't know what is. This isn't just some dry data reporting issue. It's about access to care. When insurers shortchange mental health providers, those providers leave insurance networks. When networks shrink, patients can't find care. And when patients can't find care, their conditions get worse. If insurers were systematically underpaying for cancer treatment or emergency surgeries, we'd have an outcry. But because it's mental health care, we're still here having this debate. Passing HB 6975 is about ensuring we have the data to hold insurers accountable. And yes, we'll need to work to secure modest funding for this proposal, but the cost is not the issue here. The real cost, the one we should be focused on, is the cost of ignoring this parity issue, the cost of people giving up on therapy because they can't find an in-network provider, the cost of untreated mental illness spiraling into crisis, the cost of insurers gaming the system because no one is watching. I urge the committee to advance HB 6975 because when we stop collecting this data, we stop holding insurers accountable. Thank you for your time and your commitment to ensuring behavioral health equity.
Thank you very much, Mr. Damiana, for being here with us today. So you were talking about the differences in payment, and I think some people might say that that's just kind of the market forces at work. How would you respond to that?
Absolutely. What we've been saying is market rates don't exempt insurers from having networks that meet state and federal parity requirements. And so state and federal law requires equal medical, surgical, and behavioral health coverage. But what we've seen is that that is not the case. Insurers are paying drastically lower rates systematically for behavioral health coverage, and that's leading to fewer in-network providers and longer wait times. That's not a practical issue. That's not just a practical issue. That's leading to an access issue and a network adequacy issue that could rise to be violations under state and federal parity laws. And so what we're saying, just like what OHS said in its report, is that this needs additional study to investigate whether or not they are complying with state parity laws.
Thank you. And can you talk for a minute about that, the payment parity versus parity as we have discussed it legislatively, and the difference and the importance of each?
Sure. So our coalition talks about parity through two different lenses. The first, payment parity, and second, legal parity. Payment parity is really the idea, are insurers paying comparable amounts for medical, surgical, and behavioral health benefits? And now because of this OHS report, we know 4 of them are not, and that can rise to being a legal parity issue. It's not necessarily one, but we know that it's a big warning sign that warrants further investigation according to the federal law. And so a legal parity issue would be having an unfair non-quantitative treatment limit as defined in Connecticut and federal law, and basically underpaying providers for the services that they are doing can lead to an access or network adequacy issue that becomes a legal problem.
So, and who were the 4 you mentioned earlier?
Make sure I don't just misspeak. It was Cigna, Connecticut, Anthem, and United Healthcare.
Okay, thank you for that. Are there other questions? I want to not take up all that. Oh, Representative Reddington Hughes, thank you.
Through you, Madam Speaker, what percentage of reimbursement is currently received in the medical field versus the mental health field?
Do you mean in regard to the reimbursement rates?
Yes.
So OHS in its study found that the preponderance of rates for behavioral health care were lower for 4 insurers than it were for the medical surgical. And so what that means is in many cases, they were paying less than 90% of what would have been considered the standard benchmark rate for behavioral health services. The specific percentages are in the OHS report, and I can work on pulling those for you, but
sure,
don't have them
that would
exactly.
be great. And historically, have the mental health services been disproportionately reimbursed?
That's a great question. The OHS report was really just looking at data from 2022 in the all-payer claims database. And there's not a lot of great data historically about what payment parity has looked like. And really, that's why making sure that this report is completed biennially is so important, so that into the future, we do have good data about payment parity compliance.
Right. Thank you.
Thank you very much. And just one other question in terms of you talked about warning signs, given the indicators in the report. And can you talk a little bit more about, why you think those warning signs lead to the need for more information? And I know there are efforts in other committees as well that would complement this bill. So if you can speak to that a little bit more, that would be great.
Thank you, Representative. So warning signs, according to the Federal Department of Labor methodology, typically suggest a need for further investigation to determine whether or not a legal parity violation is occurring. And so our coalition is asking for that investigation to occur to determine whether or not parity compliance is happening in our state. And that investigation is one part of making sure that compliance is happening. But even if there were to be an investigation, our position is that the insurance department does not have the authority it needs to meaningfully enforce parity laws against insurers. And so the Senate Democrats, through its Senate Bill 10 priority, have put together with our coalition a pretty comprehensive proposal about how to make sure that parity enforcement can happen in our state and that we're meaningfully holding insurers accountable when they are ignoring state and federal parity laws. And so we're hopeful that Senate bill will get a hearing in the coming weeks, and that's something we can move forward in coordination with this bill to make sure we have a full scope of tools to enforce Connecticut's parity laws.
Thank you for that. As I have said many times here, we are sticking with our public health bills, but it seemed to be relevant to the conversation as those are complementary efforts and conversations.
Thank you.
So seeing and hearing no other questions, thank you for your time with us today. Next, I believe, I don't know if number 14 is here with us yet and maybe a little bit late. I think next we have Dr. Brandon Barnett. Dr. Barnett, welcome.
Hello and good afternoon. Senators Anwar, Representative McCarthy-Vahey, Senator Sommers, Representative Claridis Dietrich, and other distinguished members of the Public Health Committee. My name is Brandon Barnett. I'm a resident of Norwalk, where I work as an endodontist. I am concurrently an MPH student at the Yale School of Public Health, where I have written extensively on fluoride. I am also a fellow of the Connecticut Oral Health Initiative and a member of the American Association of Endodontists Resident and New Practitioner Committee. I'm here today to testify as an individual in full support of Senate Bill 1326, an act concerning the Department of Public Health's recommendations regarding food safety and oral health. So at the beginning of the 20th century, researchers found hundreds of patients in Colorado Springs had a sort of mottled appearance to their teeth. They did some studies in the population, finding that high levels of groundwater fluoride was the cause, and subsequently that these patients had drastically reduced levels of caries. Due to these findings, in May of 1965, Connecticut joined 7 other states in providing water fluoridation in their community water systems to fight tooth decay. And they actually led the way by becoming the first state to pass a law requiring the practice of water fluoridation. So this bill being raised continues this proud tradition for Connecticut. Since 1965, of course, a veritable mountain of evidence has shown that community water fluoridation has led to drastic declines in both the prevalence and severity of tooth decay at levels of 0.7 milligrams per liter, with a reduction of tooth decay by roughly 25% of children and adults, and children living in fluoridated water communities having 2 fewer decayed teeth than non-fluoridated controls. Communities like Juneau, Alaska, which ended community water fluoridation in 2007, subsequently saw a substantial increase in dental caries and subsequent dental treatment costs. In 2023, residents of Buffalo, New York, filed a class action lawsuit against the City of Buffalo Water Board for damages related to needed dental procedures after they kind of quietly removed fluoride from the water supply in 2015. So currently in the United States, complications from untreated dental caries results in about 2 million annual visits to the emergency room, $2 billion in spending annually. But however, pre-pandemic, roughly 25 to 30% of Connecticut adults did not see a dentist in a given year, kind of contributing to this. For many of these people and their children, community water fluoridation winds up being the only dental treatment they receive in some sense. According to the World Health Organization, dental caries is the most common non-communicable disease in the world. But thankfully, as of 2024, 86% of the population of Connecticut has access to fluoridated community water systems. Like most medications and supplements, fluoride has some side effects. Usually these are at levels greater than 4 milligrams per liter. These are skeletal fluorosis. You can get enamel fluorosis at levels above 2 milligrams per liter. And there's also been some reports of non-skeletal fluorosis associated with some gastrointestinal symptoms. In 2006, the National Academy of Sciences found insufficient evidence of negative health effects. These are metabolic, endocrine, or neurologic, related to fluoride below 4 milligrams per liter. The National Toxicology Program looked at effects at IQ, and setting aside some very important flaws in the study, found a potential link between reduced IQ at fluoride levels above 1.5 milligrams per liter. So if you set those concerns aside in the study methodology and you take it at face value, sure, maybe this underscores the need for ongoing research into side effects of fluoride. This is true for any medication or supplement. But no matter how you slice it, the rigors of the scientific method seem to suggest that 7.7 milligrams per liter is a safe and reasonable level. So for those who are unconvinced by this data, while drinking water constitutes a large amount of fluoride exposure, it's not the only way we get fluoride, right? Even within optimally fluoridated communities, fluoride exposure varies widely amongst individual people. We have different habits in what we eat, how often we brush our teeth. And as fluoride scrutiny has kind of increased in recent years, the crosshairs have been almost entirely focused on community water systems.
Excuse me, Dr. Barnett, but you've reached your 3 minutes. Thank you.
Okay.
Thank you so much for your testimony today. And I'm wondering if you have written testimony. Have you submitted? I wasn't able to double check that.
I have.
Wonderful. That's wonderful. Because as we said at the beginning, we are in and out of meetings, but sometimes even when we're here, we're needing to take care of other committee business as well. So
Yes.
I will be also happy to be able to go back and look again. And again, as you probably heard me say earlier, I've been particularly grateful for those in your profession this year and for the work that you do, and very glad that you have come forward to testify and speak in support of this bill. Senator Elmore.
Thank you, Dr. Barnett, for your testimony. Were you able to hear some of the conversation I had with the Commissioner of Public Health earlier?
Yes, I did.
Would you be able to help demystify some of those in less than 30 seconds, the issues about IQ being affected and so on? Because there are anxieties in the community. We want to make sure that we address those, if you could, please.
Yeah, absolutely. So there's always a concern, and those studies did show a link in reduced IQ, but these were mainly in China and other countries where the water level that they had in community water system was over twice the amount that we see here in our 0.7 milligrams per liter concentration. So that's the kind of only neurological effect that we've seen potentially. There were some issues with the study design because they didn't do a risk-benefit analysis. They had a heterogeneous study methods because this is a systematic review. So the studies that they included were all very different in how they measured outcomes in IQ. So while this was a pretty landmark study, because it was pretty central to the California case, the Food and Water Watch versus the EPA that was widely publicized last year, there were some flaws with the methodology there. So, if we take the concerns at face value, still, even if we assume the study was done perfectly, we're looking at levels that are vastly beyond what is present in the United States.
And it's my understanding the meta-analysis that have been done on the other studies have been very clear about the safety at this time with the levels that we are looking at. Is that a fair statement?
Absolutely. Yeah. Above 4, you can get skeletal fluorosis. Above 2, your teeth can get modeling. And that's all we see.
Thank you so much for your testimony. Thank you for the work
Absolutely.
you do. Thank you, Madam Chair.
Thank you very much for being here with us and for all the work you do. We appreciate your time. Okay, next we have Dr. Immacula Khan. Welcome.
Thank you so much. Good afternoon, Senator Anwar, calling you Dr. Anwar, Representative McCarthy Fahey, Senator Summers, Representative Claritis Detria, and members of the Public Health Committee. My name is Dr. Immaculate Can. I'm the Chief Nursing Officer for Silver Hill Hospital, and I'm also a member of the Connecticut Nurses Association, and I appreciate the opportunity for me to speak today in support of Bill 6975. Peter Drucker, a management guru and author, once famously said, "What gets measured gets done." In addition, Dr. W. Edwards Deming is often credited with the quote, "You can't manage what you don't measure." If we accept the premise that mental illness is a leading contributor to social disruptions, ranging from reduced employee job performance and family conflict to the extremes of suicide and other violent outcomes, then we must also acknowledge the critical role that access to care plays in addressing these issues. HB 6975 is a necessary step toward ensuring that individuals receive the mental health services they need before their struggles escalate into a broader societal consequences. Expanding access to care not only improves individual well-being, but it also strengthens family, workplaces, and communities by reducing the long-term social and economic costs of untreated mental illness. Mr. Christian Damiana, am I pronouncing it correctly? Really spoke about the need for this bill to move forward, and also regarding accountability. And he talked about the 2024 report of the Office of Health Strategy, which revealed that 4 of the 7 commercial insurers in Connecticut are exhibiting warning signs of parity, non-compliance. So I'm not going to go into that. It's also part of my written statement. Mental health is a precursor to physical health. Mental enables physical. From conditioned athletes to employees juggling the demands of work and family, to recently diagnosed cancer patients, the quality of one's mental illness, and importantly, ready access to evidence-based mental health intervention, our society is underpinned by a foundation of mental health. Parity assures our healthcare delivery system is properly structured to meet the challenges. In conclusion, I strongly urge the Public Health Committee to move HB 6975 forward. This bill will provide much needed data on parity compliance, enabling us to address the gaps and ensure that all individuals in Connecticut can access the care they need without facing financial discrimination. I thank you for your time and your consideration.
Thank you so much for being here with us today and for the work that you do at Silver Hill. We appreciate it so much.
Thank you so much. Thank you.
Seeing and hearing no questions, we will go, I believe, to, I think, Ben Shaken. Welcome.
Good afternoon, Madam Chair, Representative Clarice Detria, members of the committee. My name is Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance, Senator Anwar. We are the statewide association of community nonprofits in Connecticut. As you all well know, community nonprofits serve 500,000 people across the state and employ 118,000 people, about 7% of the state's workforce. Our membership includes the state's community-based behavioral health providers, folks that are providing outpatient, residential, other kinds of behavioral health care to adults, kids, and families. I'm here to testify in support of House Bill 6975, talk a little bit about mental health, behavioral health parity today. I'm not going to go into rehashing some of the details that some of my colleagues in the Parity Coalition have shared before. I just want to give you a little bit of a perspective from the perspective of nonprofits. By the mission of nonprofits, and also importantly by the contracts that they hold with the state of Connecticut, community nonprofits provide care to people in need regardless of their ability to pay. And so I want to just talk a little bit about a couple of the ways that that the lack of mental health parity in Connecticut is shifting costs onto the state. So we can talk a little bit about the indirect costs and speculate about someone not getting access to the care that they need and what that costs the state in terms of social costs, medical costs, and other things down the road. But I can talk a little bit about some of the direct costs. So first, I think the thing that if any of you have had a family member with significant and complicated behavioral health needs and have struggled to get them care and have sought advice, the number one piece of advice that we hear when people are in that situation with commercial insurance is find a way to get your family member on Medicaid. The state's Medicaid program covers a much better array of behavioral health services in a way that commercial insurance does not. And so obviously that's a significant cost shift onto the state, but also the state agencies that contract with community nonprofits, the network of outpatient behavioral health clinics, the network of intensive outpatient services, et cetera, they all provide grant funding to nonprofits, and the grants are meant to cover the costs for people who are uninsured or underinsured, people who can't access care. And so if you're someone whose insurance carrier is not providing you services and you've gone to try to find a private practice clinician and you haven't found one who's in network, you're going to turn to the state's network of community providers. And if they try to bill your insurance and are denied, they're going to ultimately draw down from state funding to pay for the services that they're providing you. So we've been a part of this Parity Coalition now for 7 years. Last thing that I will mention is this has been federal law since 2008. This law was signed by President George W. Bush. That's how long this fight has been going on. We're aware of the challenges I think that the state has regulating a marketplace that's largely regulated by the federal government, but we do have a responsibility to ensure here that the federal law is being followed. And so we're proud to be part of this coalition again, following the landmark legislation that we passed in Connecticut in 2019. This is the next step. We've gotten the information that law required. We now know that that information shows there needs to be changes made to the system, and we're happy that the coalition has come together this year to advocate for those changes. So thanks very much. I'm happy to take any questions.
Thank you, Mr. Shaken, also for getting done in your 3-minute time frame. Well done. You are certainly practiced at that. Just to further clarify, and forgive me if you did say this earlier, as you see, juggling in the chair role, what benefit specifically do you think that the study that this bill is putting forward will bring to the conversation and to the overall issue?
Well, so just thinking back a little bit, 5 years ago, when the legislature passed the first go at mental health parity, the main requirement in that bill in 2019 was to require the state's commercial health insurers to submit data to the state about what it is that they cover and how they're covering it in a way that is sort of decipherable by the general public and by the state agencies. And I would say by and large, we've gotten the data, but as the OHS study sort of showed, the best we've been able to decipher out of it is that there's insurers that are showing warning signs. And so the further study, I think, in this bill would hopefully provide even more clarity. This is complicated, and a lot of the information is to some degree proprietary. Insurers negotiate rates with individual providers. And so all we know is what we see on the ground, which is that that folks are out of network because they're having issues with payment for behavioral health services because the payments are too low, and it's hurting access for people. And then those people are turning to the clinic-based model that the state supplements the funding for.
So I think what I'm hearing you say is that a little bit more information, whether it's through this study and perhaps contemplated in other bills and other committees, to be able to more specifically understand what's happening so that we can take the steps needed to assure that the federal and state laws are being complied with. Though I think there are some who are suggesting or saying that we don't have an issue with compliance right now in the state. And do you want to comment on that?
Well, I think that's what has been said all along, and I think it's just difficult for any of us who are working with providers, whether it's my organization or some of the organizations that represent the different clinical disciplines, some of whom you've heard from today, some of whom you'll hear from after me, whose members tell them that there's absolutely no way that the insurance companies that they deal with as practitioners could be complying because of the amount of difficulty that they have receiving adequate payment, timely payment at all for the services that are clearly medically necessary for their clients. And so the federal law doesn't say everyone should have great health insurance coverage. All it says is that you need to be providing comparable behavioral health coverage to physical health coverage. And so that's kind of where the data in the OHS study is important, and further data would be helpful, because what we see in the OHS study is as Christian said, warning signs that the parity piece of this is not being followed, that there is a significantly higher portion of physical health services that appear to be covered at a rate that meets the market demand compared to behavioral health services. And that matches what we hear from providers in the coalition and as part of my organization, that commercial insurance and the amount of difficulty that they have getting payment, even as I'm representing, large community providers with hundreds of employees running clinical settings that have, robust billing teams that work to bill Medicaid and bill private insurance. Nevertheless, they still have concerns and problems receiving payment from private insurance.
I think that's helpful information for us to hear, that specifically what you're hearing on the ground, and you're hearing it from not one, not two, but from many different providers, is what is raising the red flag, in addition to some of the data that has been reported as well in terms of the warning flags there with the reports. So it's both the report and the grassroots information that you have gathered through your organization. Yes. Okay, Senator Elmore.
Thank you, Madam Co-Chair. Thank you so much, Mr. Shaken, for your testimony and the work that you're doing for the organizations. You alluded to this a little bit, and I wanted to see if there's an opportunity to expand. The lack of parity is resulting in a cost to the taxpayers in the state of Connecticut. Can you expand a little bit on that?
I think there's two sort of main ways as it relates to nonprofit community providers. The first, as I mentioned, is the fact that the state's Medicaid program provides for more comprehensive behavioral health coverage and pays while the rates are substantially deficient. And that's a conversation for the Appropriations Committee and the Human Services Committee, as the state's Medicaid rate study has shown. Nevertheless, the actual services themselves are covered in a more comprehensive way. And so as a result, I think when we hear about, families who are needing care for children, particularly, young adult children and others with pretty complicated needs, the advice that they're often given is to find a way to have your kid enroll in the Medicaid program in one way or another. And obviously that has significant economic impacts on the state from a pure healthcare cost perspective, as well as from a sort of lost opportunity cost perspective. There's income limitations to being on Medicaid. And then the second piece is just really directly, the Department of Mental Health and Addiction Services, the Department of Children and Families, all contract with the state's nonprofit behavioral health providers. And in order to hold one of those contracts, in addition to being a nonprofit, you've got to be able to certify that you're going to serve the people who walk through your door, regardless of their ability to pay. Now, that doesn't mean that our members don't attempt to get payment from people who can afford to pay or from their insurance companies, but it does mean if they're unsuccessful in getting that payment, that they're going to provide the service anyway. It's a requirement of their contract and often most of their missions. And so the state literally provides grant funding through DMIS to providers to fund some of these programs that, and part of what the funding is for is to cover the cost for folks who are uninsured or underinsured. Obviously, our members try to get people who are eligible to get signed on to Medicaid as part of this process. But if you're not eligible and you're uninsured, or if your insurance company is not covering the service, the state is providing at least some kind of supplemental grant funding for community providers to be able to ensure that folks are getting the service.
So another way to put this is that a provider who's not following the parity is not only breaking a federal and a state law, they're actually financially benefiting and costing the state even more money.
Yes, I would say that's accurate. We would never advocate for those grant funds to go away, but I do think it's true to say that the grant funding, to some degree, at least that the state's providing to the community-based system, is helping providers cover costs when insurance companies are denying claims.
Thank you so much. The testimony is very helpful and the work you do is very helpful. Thank you. Thank you, Madam.
Thank you, Senator.
Thank you, Senator Anwar. Mr. Shaken, thank you for being here with us today and in this building with us so often. We appreciate it.
Thank you, Madam Chair. Have a good day.
You too. Next is Jessica Bruce, who's joining us online. Welcome.
Hi, everyone. Again, I'm sorry I'm not there in person. I'm recovering from knee surgery. Thank you for letting me speak today. One moment, just trying to bring up my testimony. So my name is Jessica Bruce and I live in Chester, Connecticut, but I work in New Haven, Connecticut. I'm here today in my role as dental director of Cornell Scott Hill Health Center and as a board certified pediatric dentist. I'm here to testify in support of an act concerning the Department of Public Health's recommendation regarding food safety and oral health. I'm here to express my strong support for the practice of water fluoridation. Fluoridating water supplies has been a public health success for decades, benefiting communities large and small across the nation. The Centers for Disease Control and Prevention have recognized water fluoridation as one of the 10 great public health achievements of the 20th century, and evidence continues to support the importance in reducing oral health disparities. This is particularly significant for children in underserved populations, whom I serve, and they have limited access to dental care. Numerous studies have shown that fluoride in the water reduces the rate of dental caries by 25% in children and adults alike. These reductions in tooth decay not only translate into better oral health, but also contribute to improved overall health, preventing pain, infections, and other health issues that arise from untreated dental problems. Furthermore, fluoride has been shown to benefit the entire community, regardless of socioeconomic status, ensuring that even those who cannot afford regular dental health can still benefit from this simple, cost-effective intervention. Water fluoridation is also safe. The levels of fluoride used in drinking water are carefully regulated by health authorities like the EPA and the CDC to ensure they remain within safe limits. Over 70 years of research and real-world experience has shown that fluoride, when used in the proper concentrations, poses no significant risk to human health. It is one of the most thoroughly studied and well understood public health initiatives in existence. Moreover, water fluoridation has proven to be economically efficient public health measure. Studies have shown that every dollar spent on water fluoridation saves communities up to $38 in dental treatment costs. So in conclusion, water fluoridation is a cornerstone of the public health that has been shown to improve oral health, reduce disparities in access to care, and deliver substantial cost savings to the communities. I urge you to require water companies serving a population of 20,000 or more to maintain an average monthly fluoridation content of 0.7 parts per million. Thank you for your time, and thank you for supporting the oral health of Connecticut residents.
Thank you very much, Dr. Bruce, for being here with us, for your testimony, and we wish you a speedy recovery.
Thank you. Thank you. Do you have any questions or anything you want?
No, I think
I've heard a lot of testimony. I've been to a lot of fluoride. Also, I'm Canadian. There's been a lot of fluoride discussion out of Canada as well. Unfortunately, some of those studies that have come out have not been well done studies. So that's something that's also taken into account when evaluating these studies with the IQ levels.
Thank you. Thank you for that. I will just take a moment just to remind folks, if you are on the Zoom, to please accept your promotion invitation so that we can have you in the room to testify. Dr. Bruce, you're all set. Thank you so much.
Thank you so much. Have a great day.
So I think we will next have, I believe, yep, Linda Alderman, and then we will have a group of people coming to testify here in person. Ms. Alderman, welcome.
Hello. Hold on, let me get my camera on. Hold on. There we go. Hello. Esteemed members of the Public Health Committee, my name is Linda Alderman. I live in West Hartford, and I'm testifying in support of proposed House Bill 6920, an act concerning patient-specific emergency medical care protocols for persons with a rare disease or special healthcare needs. Thank you for the opportunity. I'm a two-time survivor of breast cancer, and as a legislative advocate, I testify a lot on behalf of cancer bills. But I'm also a survivor of a rare disease called Cushing's syndrome. Adrenal Cushing's, which is the form of Cushing's syndrome I had, impacts only 1 to 2 people per million annually. It was caused by a benign tumor that grew on my adrenal gland and went 8 years without being diagnosed by my PCP and over a dozen specialists, even though I had every symptom of that disease. Physicians are taught that when they hear hoofbeats to think horses, not zebras, but this can cause them to fail to timely diagnose and treat rare diseases. Ultimately, Cushing's almost killed me at age 42, and its cognitive impacts caused me to lose my 20-year career as an environmental attorney. Further, the delayed diagnosis left me in a state of adrenal insufficiency, which could be fatal in certain situations if not treated quickly and accurately. The adrenal glands put out cortisol and regulate your body's response to stress. Without at least one fully working adrenal gland, your body cannot make the cortisol it needs in situations ranging from a broken bone to a fever or emotional shock. I wear a medical bracelet to notify emergency healthcare workers of my condition. Prednisone is one of the drugs that best replaces cortisol, and I always carry it with me in case of adrenal crisis. If someone in adrenal crisis does not quickly receive prednisone or hydrocortisone, they can go into shock, which can lead to cardiac arrest. Symptoms of adrenal crisis are memory loss and an inability to speak or process thoughts, as well as confusion. After a car accident in 2010 in which I suffered injury and shock, I couldn't form clear sentences to an EMT, didn't remember that I was adrenal insufficient, and I didn't remember that I needed to take prednisone to manage my condition. The EMT saw my medical alert bracelet that said that I am adrenal insufficient, but could not give me my medication, which was in my purse right next to me, because that would have violated his emergency medical services protocols. Thankfully, my son was with me and gave me my medication, but had I been alone, it could have been a life-threatening situation. In an emergency, I need a doctor or an EMT to follow my emergency protocol for my rare disease and give me prednisone or hydrocortisone quickly. This bill would require an EMT to assist me in taking the medication I need in order to avoid adrenal crisis. As different as rare diseases are from each other, those who have one all have one thing in common. In an emergency, we don't have time to wait for a medical provider to figure out that we are zebras and not horses. Please support this bill. Thank you for your time, and I'm happy to answer any questions you may have.
Thank you very much, Ms. Alderman, and I'm sorry that you have been through that, but very much appreciate you coming and sharing your story with us. Your metaphor of the zebras, not horses, is very effective, actually.
Thank you.
Seeing and hearing no questions. Next, we are going to have a group who is coming to testify here in person. We are first, I'm just going to let you know what order we'll be going in. So just give me a moment to do that. We'll start with number 26, which is Ruth Groby. And then we will be going to number 7, number 8, number 10, number 25, and number 47 for committee members who are following along, and those in the public as well. So with that, I would like to welcome number 26, Ruth Groby. Welcome.
Representative McCarthy-Vahey, and members of the Public Health Committee. I come today to talk about issues and legislative language that should be added to HB 6978, an act concerning the Department of Public Health's recommendations regarding various revisions to the public health statutes. Even though I realize that this probably cannot happen, we need to add language to the public health statutes because we desperately need to ensure equitable health care for all people with disabilities. Unfortunately, the two bills aimed at accomplishing this goal, HB 5371 and HB 6563, have both failed to make it onto the Public Health Committee's agenda. The disability advocates who have been working increasingly hard over the past few years with increasing hardship to themselves are devastated that neither of these bills are coming up for your consideration in this session of the General Assembly. Accordingly, I am advocating that HB 6978 be amended to include the language in HB 5371, an act concerning healthcare accessibility for persons with a disability. HB 5371 amends the statutory language adopted last year in Public Act 24-113 to add enforcement procedures that hold medical facilities and doctors' practices accountable for compliance with the law. And there is yet another bill that members of the committee will not lay eyes on, which complements Public Act 24-113 by proposing regulations regarding durable medical equipment. That is, the active and passive lifts that are needed in order to transfer patients with disabilities in medical settings. Of course, we advocates would like to see HB 6978 include the language that Representative Mike D'Amico submitted to the committee, along with his placeholder bill, HB 6563, an act concerning the effective and safe use of patient lifts for patients with physical disabilities. But we realize that this will not happen. However, given the failure to raise HB 6563, we would at least urge the formation of a legislative task force to look at the recommended technical language and come up with a bill that might get a public hearing in the 2026 CGA session. We would like to thank Senator Gordon for participating over the past year in an informal focus group of medical professionals and disability advocates who drafted the language that was submitted for HB 6563. Many disability advocates came last year and testified about the problems with inaccessible medical diagnostic equipment, and their testimony seemed to have had a profound impact on many of the legislators on this committee. Advocates with disabilities are back today and will be testifying to you yet again about the impact on both their physical and mental health when the proper equipment is not provided, along with the proper training for the medical personnel using the equipment. Thank you very much.
Thank you very much for all of your advocacy and for being here with us again today. Seeing and hearing Rep. D'Amico, that is.
Thank you very much, Madam Chair. Thank you, Ruth, for coming to testify again in front of this committee. So I just want to make sure I'm clear and that my fellow committee members are clear. So you're asking that we add or amend House Bill 6978 to include language from a couple of other proposals, correct?
Mm-hmm.
And one of them has to do with, well, if would you just explain in your own words, just so people will understand what are we trying to do here? What are you trying to do here?
Yes. Last year you were wonderful and helped us to pass a bill about accessible medical diagnostic equipment. But the problem is that in medical settings, in addition to the accessible medical diagnostic equipment, there need to be lifts, especially in hospitals, to transfer patients with disabilities from their hospital bed to their wheelchair, from their wheelchair to the bathroom. And then also some need lifts to transfer to an exam table. And we tried to include lifts in Public Act 24-113, but they ended up having to be excluded. And so we're just trying to round out and complement and get, the physical accessibility totally for people with disabilities in healthcare.
And did I understand you to say in your testimony a few minutes ago that there's already been some work done on this topic? Was there a group that was working on this?
Our group sponsored a focus group of volunteers, of medical professionals, including David Ficini, the director of radiology and biomedical imaging at Yale New Haven Hospital. It included from the University of Hartford Department of Rehab Services, Mary Gennady, who is a physical therapist and has a PhD. It included Mag Morelli, the president of Leading Age Connecticut. And it included a number of physical therapists, a number of occupational therapists, to talk about the variety of lifts that needed to be provided and the training of the medical personnel using the lifts. So we've already had sort of an informal group of medical professionals, and of course there were disability advocates on the group as well, and PCAs who've had a lot of experience watching their clients try to get transferred in hospital settings. So we had it was about 15 people. It was quite a group. And so that was where the language that Representative D'Amico, you submitted, that's where it came from.
So thank you. And I presume that you'll, if you don't mind, Madam Chair, I'm just going to ask a couple more questions. So I presume that group can continue its work, failing the opportunity to have a formal work group or set up, or what?
I hope. I mean, these are very busy people. I know you all are very busy people too. Yes, I would hope. Or maybe we could get some other people. But if it was official, it might be a little bit easier to recruit people. I'm not sure about that, but that's the hope.
Okay. All right. And the other proposal that you wanted to amend onto or suggesting that we add to House Bill 6978 has to do with a deficiency in legislation from last year. Did I hear you properly on that?
Yes.
Would you mind just briefly explaining that as
Right.
well?
The Accessible Medical Diagnostic Equipment Bill, Public Act 24-113, that does start to require medical facilities and hospitals and doctors' offices to start purchasing equipment that meets the 2017 U.S. Access Board standards. It's a wonderful bill, but it has no enforcement procedures. And so far this year, there were things that were supposed to happen by January 1st, a month ago, including that medical facilities and doctors' offices were supposed to take an inventory of their medical diagnostic equipment as to how much met the U.S. Access Board standards and how much did not. And we've been, our personal experience, and I realize this is not a statistically significant sample, but the advocates here, none of their doctors seem to know about having to take an inventory or, have it available for the Department of Health to look at it. We haven't been able to get information from the Department of Public Health to what extent the inventories have been taken. And there were several other stipulations that were supposed to be done by January 1st. And we have no idea if they've happened or not. They don't seem to have happened to the people who are going to doctors' offices.
So by amending this bill with that proposal, you would close the loop more or less, and you would then have you would then have that information available rather than waiting for the Department of Public Health to ask for that information. It would, as I understand it, what you're proposing is to require these facilities to affirmatively get that information, provide that information to the Department of Public Health so it would be available to everyone.
Right,
Correct?
so that you could see it under the Freedom of Information Act, because right now we don't know what's happening.
And in view of the fact that the bill in front of us today, House Bill 6978, is a Department of Public Health revision bill or revisor bill, would you agree that this would be a revision to existing statute that would be a good way to amend this bill?
I would agree, yes.
Thank you very much.
Thank you very much.
Thank you, Madam Chair.
Thank you. And before you go, Ms. Brewer, I have shared this conversation with Rep. D'Amico, but I think it's important to share it here with everyone else. When chairing a previous committee, had a similar bill, it was a zoning bill, same thing, it asked for reporting. It took 5 years before we were able to get any kind of, what I'll say, enforcement. And the bill was heard in a 24-hour public hearing. So I just want to be clear that we know that this is an important update. And just as we did in that other bill, there were certainly other factors going on with that bill. But my point is that we are very aware and we recognize, I think I can speak safely for Senator Anwar, that for you and all the members of the community who really did a tremendous job last year, and with thanks to you and to Rep. D'Amico for the advocacy on that, which is what helped us to pass the legislation last year. So we will remain in conversation. We had over approximately 300 bills submitted this year. So there are a lot of groups who we are sadly not able to hear from this year, but we're glad to have you here. And with no other questions, we are going, Rep. Reddington Hughes, I keep missing you over there, Representative. Rep. Reddington Hughes.
Really quick, just to establish presently, if a disabled patient goes to a doctor's office and this equipment is not existent, how do they access care?
Well, they, with the exam table, they're examined in their wheelchair. And a whole bunch of medical doctors have told me that you cannot get an adequate examination when you're sitting in your wheelchair. Pressure sores are a big issue, and you can't identify if there's a pressure sore. So that's part of the problem. And then you're going to hear from one of our advocates a story about scales. So
my assumption is that there are many medical conditions that may be missed as a result of this.
That's the issue. Indeed.
Thank you.
Thank you.
Thank you, Rep. Reddington Hughes. And I will add that we certainly legislatively can check into some of the other conversations. And I think our hospital partners are also actively looking into some of the things that you've talked about today. So we will continue the conversation offline with you. And again, thank you for your advocacy.
Thank you so much.
So next on our list, we are happy to have Mary Ann Langton here with us today. Hello, Miss Langton. We're so glad that you're here. Thank you for coming. I don't know if you have someone here with you, if you both can introduce yourself, and you may be able to use the microphone that's just to your right, which sometimes can move. No, I'm sorry, I meant Miss Langton. If she wants to. Go ahead, please proceed.
Thank you. Hello, Co-Chair Anwar, Co-Chair McCarthy Vahey, and distinguished members of the committee. My name is Mary Ann Langton, and I live in West Hartford. My personal assistant, Patty Ellis from Windsor, hello, will be reading my testimony. We should be proud that a law last year, Public Act 24-113, was passed addressing health care for people with disabilities. This is the first step, but I would strongly urge the Public Health Committee to make Public Act 24-113 stronger by amending HB 6978 to require medical facilities to file their equipment inventories with the Department of Public Health by July 2025. This Department of Public Health Enforcement enhancement was outlined in HB 5371, which will not come up for a public hearing, much to my distress. We must take steps forward to having accessible scales and exam tables for all people now. Why is this important? Presently, people with disabilities, including myself, cannot adequately be examined because we cannot jump up onto the exam table. Therefore, my exams must be done from remaining in my power wheelchair. Is it fair or even legal that people with disabilities healthcare is in jeopardy? No. In addition, as you consider HB 6978, an act concerning the Department of Public Health concerning recommendations regarding various revisions to the public health statutes, I would like to encourage your committee to attach an amendment addressing the lift bill. Originally HB 6563, the lift bill is essential because many people with disabilities require these adaptations. If the language cannot be included in HB 6978, I want to promote that a task force be developed to study these critical devices and make recommendations for legislation in the 2026 session of the General Assembly. In conclusion, I hope that I have shown how these bills would enhance healthcare options for people with disabilities and for others too. Thank you.
Thank you so much, both Ms. Langton and Ms. Ellis, for being here with us and for sharing your experiences. We incredibly value your time today. Thank you.
Thank you very much.
Next, we have Maureen Emerald. Thank you, Ms. Crowley. We appreciate that. And Ms. Amaral, we're so happy to see you. Welcome. And if you, that may actually move a little bit. You can probably move that a little bit closer and you can turn that one off. Yes. There you go.
Good afternoon. Can you hear me all right? Good afternoon, Senator Anwar and Representative McCarthy-Vahey and members of the Public Health Committee. My name is Maureen Amiro. I am speaking on the medical accessibility bills. I am lucky that right now I do not have regular use of a lift. I don't need to use them. I have used them from time to time for appointments and hospital and rehab stays. And I often find that they're difficult in hospitals. They're difficult to locate. Sometimes they're on a different floor. And it resulted a few times in the hospital that we had to actually reschedule an MRI, reschedule a shower because they couldn't find a lift in time to get me to the room that I needed to get to. Also, I've dealt with staff that were not fully trained, and I was almost dropped on the floor on the Hoyer lift, and actually that is a pretty common problem. A few months ago, my doctor ordered a same-day ultrasound to check for blood clots, and I called the imaging center, and they told me they did not have a lift available, and if I can't transfer on my own, I would need to go to the ER. The fact is, I'm kind of in the middle. I don't know. I might need a lift. I might not. So I asked all the questions that I could about the exam room, what the configuration was, what the height range of the exam table was, and if they had any grab bars or anything like that. The staff was not really able to answer all those questions, but I just decided to go and just see if we could make it work. The room was not accessible. I had to leave my wheelchair in the doorway, which is a fire hazard. I had to use my walker to get to the exam table, and I got there and I could swing one leg over, but not the second leg. And the staff was not allowed to help me. So, and then we kind of determined that I was stuck. I couldn't get on the table and I couldn't get back off the table. And at that point, the staff member got authorization to help me. People could share so much worse stories than this, but because this is more like a day in the life of a disabled person, but it does highlight 3 issues that is covered in the proposed lift language, and that is the availability of lifts, accessible exam rooms, and fully trained staff. I testified last year in front of this committee for medical accessibility, and Representative McCarthy-Vahey, I was so impressed with you. You listened to each of us and you responded individually to us. And Senator Anwar, you have helped us so much last year and talked to me individually, asking what you can do for the disabled community. And I'm bringing this up because I really believe that you sincerely care about us and our community. I understand that you are so overwhelmed with bills and legislation. And I'm appealing to that compassion and empathy that you have shown, and just asking that you do what you can to help us. We are asking for a task force to ensure that we can effectively implement the LIFT legislation in next year's session, and to require inventory to be taken to ensure that PA 24-113 is being properly implemented. So please don't forget about us. Thank you.
Thank you so much, and forgive me for mispronouncing your last name. I was way off, but thank you for taking the time to be back here with us again today. I don't think that Rep. D'Amico or Ms. Groby would ever let us forget about you. And we don't. And I'm really grateful for you sharing your story. As you said, day in the life, and a lot of people have a lot of very difficult experiences. So we're grateful that you continue to advocate. And we expect and know that this is probably going to be an ongoing conversation for all of us. Thank you
I
for being
appreciate it.
here.
Thank you.
Seeing and hearing no questions, we will go to Cindy Miller, who is here with us today. Oh, Cindy is on Zoom. Okay. Okay.
About an hour ago and was struggling to get on the
Okay.
Zoom call.
So we will, it looks like, just give me 1 sec. I believe that Cindy, we are promoting you to a panelist. And if, I think, okay, we're going to see if we can work out those issues. And next, instead, we will go to number 25, Suzanne Garafa.
Suzanne dictated her testimony to me and asked me to read it.
Yeah.
Yes. Is that
I'm
okay?
gonna have Ruth read it for me.
My name is that okay?
Yes, please proceed. And you can, if you would like to, you can sit right there to the, yep, and just press the button of the microphone in front of you. Or, yep, either way.
This is good.
Perfect.
Thank you.
Thank you.
My name is, as someone who has been advocating very hard for equitable health care for people like me, I am crushed by the fact that the committee is not going to consider HB 5371, which would have changed the public health statutes to require medical facilities to prove that they are following the stipulations in Public Act 24-113. I have been with the Citizens Coalition for Equal Access for the past 4 years. Shortly after my caseworker at Independence Unlimited helped me to get 100 signatures on a petition to Hartford Healthcare complaining about the lack of wheelchair accessible weight scales, both in my doctor's office and at Hartford Hospital. I want to thank you for helping us in the last session to pass Public Act 24-113 to address this issue, but the act contained no enforcement procedures. You know all this stuff. The language of HB 5371 addressed this lack of enforcement, but it has not been raised for a public hearing. In the meantime, I have had health issues. I have been feeling sick to my stomach and vomiting for several weeks, and the first thing my doctor asked me was, "How much do I weigh?" I was at his office several months ago, and he does not have an accessible scale. And his question about my weight would indicate that he has no idea that his bosses have been required to take an equipment inventory. Despite past petitions and the passage of Public Act 24-113, the chair, it appears as though Hartford Healthcare may be failing to comply with the provisions of Public Act 24-113. And this is why I am advocating for adding the language from HB 5371 to HB 6978. For the last 4 months, I have been very sick and needed more assistance from my PCAs and my healthcare providers, and it has been very hard to get. People get frustrated with disabled people when they get sick because they require quite a bit of care and extra accommodations. By your not addressing this issue, you are contributing to the decline in my health, but I refuse to go to a nursing home.
Suzanne, I would like to say thank you for being here, Ms. Garaffa, for being here again with us today. And I would like to say, I'm sure you are very frustrated, as are others who are in the disability rights community seeking this. And I'm sure it's really no consolation for us to talk about any of the number of reasons why we weren't able to hear this bill this year. But please know that we are going to continue the conversations, bill or no bill. And as I mentioned earlier, there are conversations happening among those who are working to implement this. So we will continue that. Please do. Yes.
I don't mean to be, how do I put this? I don't mean to be pushy or nasty, but every second you deny what we're doing, I know I know you're with us. Every second you deny what we're doing, we're dying.
Yep. We hear you.
Well, please support us next year. Show us you hear us. Support us.
We're going to continue to work to implement the law that was passed last year. That's
Thank
what
you.
we are promising you. Again, bill or no bill, that is what we are doing. Thank you very much. Ooh, there we go. Next on our list, we have number 47, Mary Moberg. Oh, you know what? Forgive me. I know that Cindy Miller is now with us online. So we will go back to number 10, Miss Miller, and then we will go to Miss Moberg if she's available online. So Miss Miller, are you, Miss Moberg, hang on one moment. We're going to see if Cindy Miller is available. Forgive the back and forth, folks, and thanks for your patience. Okay, I think Miss Miller may be having some issues getting online and joining us. So Miss Moberg, Mary Moberg, we are going to go forward and we welcome you.
Thank you so much. Can you hear me? Okay.
Yes, we can.
Excellent. I am a registered nurse and I have worked at Southwestern Connecticut Agency on Aging with the Connecticut Home Care Program and at Community Health Network of Connecticut and in community health jobs as well. So thank you. It would seem our timing couldn't be worse for bringing up concerns about the lift bill within the current political challenges. But it is the best time to consider making favorable conditions. It will ultimately prevent more costly, delayed services, which would incur more medical expenses. We need to access diagnostic tests to treat conditions instead of addressing lack of care causing complications. That would save the state money. I am a bariatric paraplegic dependent on Hoyer lift for my transfers. And a few months ago, I had contacted Midstate Hospital to determine if they had a Hoyer lift to transfer me from wheelchair to the stretcher. They confirmed they had one, so I arranged a wheelchair taxi to travel there. I've had a lot of experience using Hoyers and other lifts as a rehab nurse with spinal cord injuries and community health care work prior to being disabled. Well, the one they had looked like something from a science fiction movie. It was completely foreign to me. The staff tried to use the Hoyer lift pad underneath me to hook up to their lift, but theirs used a pad with grommet circle attachments, whereas my pad had straps. How was I even going to get onto a stretcher? The staff attempted to secure my straps to the lift's pegs, but it was jury-rigged, and trying to lift me was scary and constrictive. I was certain it would end up with me falling and hitting heavy metal parts on the lift. They couldn't extricate the makeshift attachments of my pad to their lift, and they wanted to cut the straps. I would not have the means to get transferred out of my chair once back home if they cut the straps. Besides, I paid about $50 for the Hoyer lift bed. In order to get me on the stretcher, they had to bring in almost more staff than could fit around the stretcher and my wheelchair. In all the various repositionings in the chair, it twisted my gut into involuntarily soiling myself. So I was awkwardly lifted onto the stretcher with great effort and further angst. I had to stay on a soiled pad in order to transfer to my own bed once home. In the lift bill, the stipulations for different medical settings vary according to the number of providers and the number of examination rooms. There are specifications for combinations of either electric lifts and sit-to-stand devices, or for very small practices, just a sliding board would suffice. Except like if I wouldn't be able to use a sliding board. It makes sense that staff would be required to have training to deal with disabled in a sensitive manner, and to also have actual physical training to use the lift devices. In community health, one time a lady never got out of bed and I wanted her aid, and I ended up canvassing the neighborhood to get anybody with a large stuffed animal so we could approximate transfers. And I brought back to this lady's house a giant stuffed giraffe, and we practiced the lift. And then I felt fairly certain that aid could do it, and we proceeded. Mind you, some examination tables were asking for, accessible examination tables, but some examination tables will not accommodate having a Hoyer lift slid underneath. The equipment, the wheels will not fit. Making the lift bill work requires a task force to work out the issues with implementing this all. It should include medical personnel and disabled people. Can you please help us make this work? And thank you. Thank you for your help.
Thank you so much for joining us, also for your work at SWACA and elsewhere. We are grateful for you. And we agree that you should not have to be going through these situations. And again, as I said, we will continue these conversations with all of you. In fact, next, I believe that Miss Cindy Miller is with us online. Thank you, Miss Moberg. You're all set.
You're welcome. Thank you.
Miss Miller, welcome.
Thank you very much. Thank you, all of you, for giving me the opportunity to speak. This is the second consecutive year in which I have testified, last year both in person and on Zoom, regarding the efforts of the Citizens Coalition for Equal Access to ensure that patients with disabilities would be able to seek medical care which is not only comfortable and complete, but which enables the patients to maintain their dignity. Please think of the last story that we heard. Before proceeding further, I'd like to share how it came to be that I have immersed myself in the efforts of CCA. When I began medical school, I had an as yet undiagnosed disease primarily responsible for an unsteady gait and difficulty with activities such as raising my arms over my head. I had had the notion of becoming a pediatrician or an internist, but fortunately, I accepted the advice of the dean of my medical school, who suggested finding something that would not be as physically taxing. I chose to go into radiology. I was able to combine my love of a variety of aspects of medicine with the process of information gathering in order to render a diagnosis. As my disease progressed, I was thankful I had accepted the advice of my dean. I had found a field which I loved, but it also left me energy to pursue other medically related interests. While practicing at Yale over 10 years ago, my own internist asked if I'd be interested in assisting him in teaching an introduction to the notion of disability to students in their second year of med school. It was surprising to me that this was the first time they were being introduced to disability as a concept, but I was delighted that they were absorbed in the material and I could see where their minds were already stimulated to envision change. Several years later, an internist whose practice included a large number of patients with Down syndrome asked if I'd be interested in the CCA. I was enthusiastic about the possibility, and after meeting Ruth Groby and many of the other members, I was sure that this was an arena where I wanted to be involved, planning and advocating for the small to medium-sized steps that when combined would make a significant difference. Our ultimate goals were that every patient would be able to have a complete physical exam, including having an accurate weight obtained, the presence of exam tables with adjustable heights, and exam rooms which were sizable enough to allow for patients in wheelchairs to maneuver with relative ease. We were pleased that last year's legislative session accomplished most of the aforementioned goals. We were cognizant that there was another significant component of the examination of patients with physical disabilities, specifically lifts, which could assist the patients from their wheelchairs to the examining table. Not only would there be the need for potentially several different types of lifts, as no one lift is appropriate for all patients, but importantly, there'd be the need for an appropriate number of staff to be trained and available to assist with the lifts. We have learned that two bills, HB 5371 and HB 6563, both of which deal with the provision of accessible healthcare to disabled persons, have not made it onto the agenda of the Public Health Committee. Given the omission of these two bills from this session's agenda, CC=A strongly suggests that HB 6978 add language which had been included in HB 5371, addressing the need for enforcement procedures directed at facilities and physicians to ensure their compliance with the law. Although very disappointed with the seeming omission of bills addressing the additional features that will provide more complete accessibility, these issues remain on the front burner for the members of CC=A. We are prepared to continue our attempts at educating legislators about the reality of our needs and are similarly prepared to continue to have a visible presence in the halls of the legislature for the years to come. Thank you.
Thank you, Dr. Miller, for being here with us. I think all of us around this circle wish we could do a lot more than we can do, and I hear very clearly the frustration that all of you are facing as we go forward. But again, our commitment that we will continue these conversations and this work going forward. Thank you for being with us today. Next on our list, we have number 21, Erica Smith. Ms. Smith, we see you online. Are you able to join us?
Yes, I'm here. Sorry, I'm a little technologically challenged. Can you guys hear me?
We can. Welcome.
Hi, thank you. Okay, great. So let me just get to the right section here. All right, so let me get started. All right, my name is Erica Smith. Thank you very much for allowing me to testify here today. I am a licensed naturopathic physician in Connecticut. I specialize in the use of naturopathic and biomedical approaches to address the root causes of symptoms associated mostly with ADHD and autism is mostly what I treat. I'm here today as an individual in support of SB 1325. My colleague, Dr. Bob Brody, who's the president of our Connecticut Naturopathic Physicians Association, he's going to soon elaborate on some of the specifics of what we're requesting in the bill, some of which is a limited formulary to include natural substances, including vitamins, minerals, nutrients, and probiotics. We're asking for a clarification on the scope of the naturopathic medicine, our naturopathic medicine scope to include all routes of administration except for intravenous, and an expansion of the naturopathic board to include 3 naturopathic physicians, 1 public member, and 1 pharmacist. But Dr. Brody, he'll be available to answer further questions on that as he's coming up soon. For my time, I'd like to direct our attention to our published stance on vaccinations, which was referred to earlier. As per the Pediatric Association of Naturopathic Physicians, that will be submitted, the actual statement paper will be submitted, but it clearly states that licensed naturopathic physicians, when within their scope of practice, provide vaccinations as part of our holistic approach to patient care. We also have and engage some vaccine hesitant patients who come to us asking questions, and we will engage with them and have that as part of our overall wellness comprehensive strategy. Regarding concerns presented in earlier testimony, naturopathic physicians are educated thoroughly in the mechanism of action and the safety of using B12. And while B12 deficiency is generally considered
Oh, I think we just lost connection. I'm fairly certain. Not full connection. I think we just lost Erica. Yes, Erica Smith. So you know what? Erica, if you can hear us out there, if you can go ahead and log back in and we will come back to you. But for now, we are going to go forward with Thea Marks, who I believe is Thea here. Yes, with us in person. Welcome. You can sit. There you go. You're moving the chair back. Thank you very much.
Senator Anwar and Representative McCarthy-Vahey, esteemed members of the Public Health Committee. My name is Dr. Thea Marks. I'm a licensed naturopathic physician practicing in Shelton, Connecticut. I strongly support SB 1325 and its proposed expansion of the naturopathic scope of practice. My training includes extensive pharmacology education, though it is not the first thing that I reached for, to Senator Austin's point earlier. My education includes over 200 hours of classroom instruction covering method of action, contraindications, and drug interactions, along with successful completion of both basic and advanced pharmacology licensing exams. In my clinical experience, I've worked alongside MDs in diverse settings, including Bronx, Lebanon Emergency Department, a rural clinic in Namibia, and an integrative cardiology practice in Manhattan. In these roles, I was trained to prescribe under supervision, reinforcing the depth of my education and readiness to safely manage prescriptions. In my practice, the inability to prescribe limits timely care. For example, I recently saw a patient with Giardia, which required metronidazole, yet I had to send him to urgent care for treatment. Another patient, a young woman with uncomplicated pyelonephritis, had to endure a 16-hour ED wait to simply because I could not prescribe a fluoroquinolone. These delays impact patient outcomes and increase the burden on an already strained healthcare system. Additionally, expanding our ability to administer treatments such as B12 injections would improve patient compliance and outcomes, especially for conditions like megaloblastic anemia. The proposed board expansion to include a pharmacist is also a responsible step toward ensuring oversight and collaboration. The recent DPH scope review highlighted the need for greater clarity and expansion. SB 1325 is a crucial step toward ensuring Connecticut residents have access to safe, comprehensive naturopathic care. I urge you to support this bill, and I thank you for your time and consideration. I stand for questions.
Thank you. Thank you for being here with us and for sitting with us and listening today as well. Seeing and hearing no further questions. Oh, Senator Anwar.
Yes.
Thank you so much. You probably heard a comment from Senator Austin earlier that naturopaths are different from naturopath physicians. Can you help me understand the difference, please?
Certainly. In Connecticut, we have licensure statutes. And so licensed naturopathic physicians not only have to complete naturopathic medical school at the 8 nationally accredited schools in North America, but they have to sit for multiple licensing exams. That is the difference between naturopathic physicians and naturopaths. Naturopaths do not have the education, the accredited education, nor have they sat for the licensing exams.
So you're saying the training is completely different?
Completely different, yes, sir.
And in the community, for a layperson, how are they able to separate them out?
Look for the licensed naturopathic physician is the best way to sort them out. In Connecticut, the ability to call ourselves doctor and physician is the other opportunity to do that. The other way is to look at the person's credentials and to ensure that they have graduated from one of the 8 accredited institutions in North America and passed the national board exams required from these institutions to license.
Would it be fair to say that these naturopaths are causing negative impact on your profession by colluding the well-trained, relatively differently trained group to look similar?
I certainly would never want to disparage someone that can help another person learn about natural care, which a lot of it is not licensable. Certainly good nutrition, good exercise and healthcare a lot of times is what lay naturopaths profess. It does cause confusion. It certainly does.
And what is it your organization doing to try and reduce that confusion?
I'm going to defer that question to Dr. Robert Brody, who will be up shortly. I feel that he can answer that better than I can.
Thank you. And I have a couple more questions, but I will probably leave it for the next person who's going to speak. Thank
All
you.
right. Oh. Good question.
Thank you,
Oh.
Senator Anwar. Representative Reddington Hughes. I didn't miss you this time,
Oh,
actually.
thank you. Well, thank you for being here and for giving us the valuable information. My question has to do with the injections to begin with. As it is, are you able to inject patients with anything right now?
No, ma'am, we are not.
Okay, thank you.
Thank you, Representative. Thank you, Doctor, for being here with us today.
Thank
We
you so much.
appreciate you. And we will go back now to Erica Smith, who we lost you abruptly.
Yes, that was, I apologize. I think I remember where I was, but I apologize if I repeat myself. I was referring us to the Pediatric Association of Naturopathic Physicians statement on vaccines. I just wanted to make sure that that got into the record because there still seemed to be some clarification needed about our organization's position on vaccines. And then also regarding concerns presented earlier about naturopathic physicians' education and safety awareness, mechanism of action, and clinical applications of B12. That is something that's well within our wheelhouse. While B12 deficiency is generally considered uncommon, there are specific populations that we see who do exhibit a higher risk, including older adults, individuals with certain GI conditions, and those following specialized diets like vegetarian or vegan diets, and these are documented by the National Institutes of Health. However, I'd also like to bring your attention, this is specific to my area of expertise, to the emerging research in the use of B12 in the treatment of autism. That research will also be provided to you by the researcher, Dr. Rosenthal. I'm also a fellow with the Medical Academy of Pediatrics, Medical Association of Pediatric Special Needs, and we use B12 quite often to promote language and cognitive development in children with autism. I've observed that clinically firsthand to be very beneficial. So therefore, while B12 deficiency may not be as widespread, targeted supplementation does have therapeutic benefit and may be warranted in specific populations, specifically with neurodevelopmental conditions. At my practice, I treat mostly children, and I do maintain a commitment to collaborative care. I often refer back and forth with pediatricians and other specialists to ensure truly integrated care. We as NDs in the state view ourselves as an essential member of the patient's clinical team. We're not seeking increased scope to change our collaborative role. It's just to make sure that our patients have access to things that are within our scope. Restricting our ability to provide treatments within our training and expertise sometimes creates unnecessary barriers and financial burdens for families. We are very comfortable referring for concerns that are outside of our scope of practice, but requiring us to refer for additional appointments and expenses for things that are within our scope of practice, we find to just not really be efficient or clinically optimal. So thank you. I apologize for the disjointed testimony due to the technology, but thank you for your thoughtful consideration for our proposal.
Thank you so much. And this is the age of calls
I know.
coming and all that. So that's okay. We understand. We're glad you were able to come back and join us.
Great. Thank you.
Seeing and hearing no questions, we're going to go to Marcy Russo.
Good afternoon, everybody. I submitted written testimony for two bills that you all are reviewing today. The first was in support of House Bill 6975, an act requiring a biennial study of payment parity. I know that there'll be another public hearing on that soon, and so I'd like to focus, if it's okay with you, my testimony on Senate Bill 1331. So, hello, Senator Anwar, Representative McCarthy-Vahey, and all members of the Public Health Committee. You can find my written testimony on Senate Bill 1331, which is an act concerning the exclusion of patient health information and opt-in and opt-out procedures related to the statewide health information exchange. So as you can see, I'm Dr. Marcy Russo. I am the present chair of the Connecticut Psychological Association's Legislative Committee. I'm a practicing psychologist in Connecticut, and I am a resident of Middlebury. On behalf of CPA, I'd like to write and report to you that we are in strong support of Senate Bill 1331. As a member of CPA, our organization has worked very closely with other behavioral health groups in Connecticut, making specific recommendations actually regarding some of the parameters around which one's individual behavioral health and substance use information has to really remain excluded from the Connie system when that Connie system is fully implemented. Although CPA does support implementation of a statewide health information exchange system, and we would like to participate in such a system, we do remain very concerned and very troubled about many of the mandates that have come through the Connie system, because some of them exceed state mandates on confidentiality and privacy, and they also conflict rather with some of the existing state laws on privacy, thereby jeopardizing the confidentiality of sensitive behavioral health information. I also like to focus a little bit on how they might also impose unfair risks and obligations on behavioral health providers, which then can jeopardize care and ultimately the availability of behavioral health services in Connecticut. So we were glad to see that SB 1331 calls to set up a study. And so we strongly urge the committee to adopt not only the bill, but also to include as many as you can some of the substantive recommendations that were submitted first on November 18th, and then later on January 1st. Those recommendations were submitted by Mag Morelli, Amanda Gunthel, and Dr. Anthony Yodel. And I also included a link to such recommendations to the Office of Health Strategy report in my written testimony. So I do thank you for an opportunity to submit testimony on this bill, and I do thank you for allowing us to support the Senate bill, and I am certainly open and available for any questions the committee might have.
Thank you very much for joining us today. Senator Anwar has a question.
Thank you so much for your testimony. I wanted to ask you if you're aware that some of the information, as I gather from Connie, that is, even if the person is opted out, that information is going to be gathered and would be within the Connie system for perhaps 5 days before it moves to separation of the opt-in and opt-out. Have you heard anything like that?
I haven't actually, and to hear that, Senator, would make me even more concerned. Obviously, many people probably know it comes at times to be a big decision for individuals to seek help for a behavioral health or a substance use disorder. And although patients do want other healthcare providers in their life to know information, patients want to also know that they have the security of privacy and confidentiality of that information. Because in our society, in the wrong hands, that information can have significant implications. So any opportunity that we have to actually make opting out of behavioral health information the norm would really be the way to go, where patients then have the choice to consciously share, so rather than consciously opt in terms of their behavioral health information.
Thank you. And another thing was there's this whole conversation that sometimes the patients do not know enough. Do you think that's worthy to include in this discussion? How can we have the patients be aware of their rights about privacy? Because as was mentioned earlier, HIPAA, there's like 5 pages or 2 or 3 pages, depending on what it is. But for this part, there's hardly much.
Yeah, anything. I do think that it's a very state regulations and how we implement state and federal law can get really, really clunky. And the language that we use, the jargon that we use can be very overwhelming for patients. So any effort that we can engage in to make sure that patients understand their rights is really only going to help not only more patients seek behavioral health services, but also remain in behavioral health services. I know with my own patients, I have to specifically take dedicated time and attention to help patients understand even our Connecticut general state statutes on patients' rights and responsibilities, because it's very heavy. It's very heavy stuff and it's very complicated. Even HIPAA is a very complicated document. And so we certainly don't want to set up another unfortunate opportunity where we're needing to move through another very complicated set of parameters or mandates that will be very difficult for patients to truly understand. I hope that answers your question.
It does. It does. Thank you so much. Thank you, Madam Co-Chair.
Thank you very much, Senator Anwar. Thank you for being here with us today.
It was my pleasure. Thank you for having me.
Next, we have Mark Spellman, followed by Catherine Kennedy. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Somers, Representative Carides Ditria, and members of the Public Health Committee. I'm Mark Spellman. I'm testifying in support of the Husky Parity Study described in House Bill 6975. I'm testifying on behalf of the Connecticut Psychological Association, just like my colleague, Dr. Marcy Kane, who was just on. I'm a psychologist in private practice in New Fairfield. Now, given how long we've all been fighting for mental health parity, about 10 years now, right? I'm pretty sure everybody here deeply understands mental health parity from a policy perspective. So I thought I'd share a short story about what parity looks like in a clinical situation in my own practice. This is a story about Lois. Lois contacted me for an appointment last month, and she let me know she was on Husky. My practice is more than full since COVID, but I always try to take people on Husky because I believe we psychologists have a special commitment to work with people whose situations are particularly difficult and complex. That's generally true of folks on Husky. It was certainly true of Lois. Lois is a 39-year-old single woman who's on Husky because she lost her job and her health insurance and her apartment through some pretty Byzantine office politics and roommate conflicts, which I will spare you. But, oh, please. When she came in, she told me about this crisis, and we got that stabilized. And then we began looking at her self-care. Lois had no primary care doctor. She had no psychiatrist. She's out of antidepressant medicines. So I referred her to a local doctor that I work with that I know will take Husky. Great doctor, and a wonderful psychiatrist that I also know will take Husky. She saw the doctor, but she hadn't done the blood work that he ordered. So I gave her the Quest app to make a blood work appointment. She promised to make one. She told me she'd left a message for the psychiatrist, but they hadn't gotten back to her. I told her I would personally follow up if she tried 2 more times, because then that would be appropriate. And I gave her the web link. She promised to do so. Since low motivation and energy to get things done are important presenting problems for her, I asked her about her nutrition. Breakfast? I'm not a breakfast person. Lunch? A refrigerated protein bar. Dinner? I'll cook vegetables if I have some energy. I gave her standard nutritional counseling, as you'd expect, but more importantly, we talked about how we feed ourselves and how we take care of our health is a very important message that we send ourselves for, are we worth taking care of? And we practiced a mantra. I'm going to take better care of Lois because I'm worth it. Every meal, every time I need to make a doctor's appointment, every time I need to fill a script, I'm worth it. I'm worth taking care of. So you see, sometimes medical care doesn't happen without mental health care. So please support this study bill to assess whether Husky is valuing and supporting both equally. Both are equally worth it. We are worth it. Thank you for hearing my testimony.
Thank you so much for your testimony. I agree with your thoughts as well. Seeing no comments or questions, we will move to the next person on our list, which is Catherine Kennedy.
Thank you so much. Hoping you can hear me.
Very well.
Great. Good afternoon, members of the Public Health Committee. My name is Dr. Kiki Kennedy, and I'm a physician practicing psychiatry in New Haven and a Yale clinical professor. I'm here to testify on behalf of the Connecticut Psychiatric Society in very strong support of HB 6975, an act requiring a biennial study of payment parity. The Connecticut Psychiatric Society represents over 600 Connecticut-based psychiatrists and is a district branch of the American Psychiatric Association. Our mission is to advocate for our patients and their communities to improve access to behavioral health services in Connecticut. The Office of Health Strategies 2024 Payment Parity Report is an excellent step forward in providing critical data on how Connecticut residents are being unfairly denied access to behavioral health services legally covered by state and federal parity laws. And it applies to a range of plans, to Husky, commercial insurance, and Medicare Advantage. You've probably already heard this data several times today. Of the 7 commercial insurers surveyed in the study, 4 demonstrated signs of parity noncompliance. That is more than half. Those 4, Anthem, Cigna, Connecticut, and United Healthcare, are all big players. So this report confirmed what patients and providers already know. Behavioral health parity is out of reach for many Connecticut residents. As clinicians, we see firsthand how parity failures harm our patients. Here's what's going on the ground. We spend hours on the phone and the computer trying to help our patients access services we know are medically necessary. But the time and energy we spend on these high, uncompensated administrative burdens takes a toll. And so what happens? We reduce the number of patients we see because the administrative tasks take up too much time, or we stop being in-network providers and go private pay. Our headaches go away, but our patients face higher out-of-network costs, or we burn out and stop practicing altogether. And so what happens to people in Connecticut when we reduce our caseloads, go out of network, or stop practicing? They have less access to care. They wait longer for appointments, their symptoms may worsen, some may end up in crisis situations, and some may even die. Others may never get the care they need. They just suffer. So in closing, I'm asking you to please move HB 6975 forward. Releasing a regular parity payment report every 2 years will help alert us to any warning signs of parity noncompliance and help us hold insurers accountable. Connecticut residents deserve nothing less. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you, Dr. Kennedy, for your testimony. We appreciate your time and sharing the experience with us. I asked this question earlier. What I understand is happening is that many of the time, if the carriers are not covering, people are moving towards Medicaid, which is able to provide somewhat better access if they're eligible for Medicaid. And as a result, it's putting a lot more pressure on the taxpayers because of the lack of some carriers not following the federal and the state laws. Is that what you're hearing out there as well, or seeing this?
To be honest, I haven't heard any specific situations where people have of my patients or other people's patients doing that. Although I've heard testimony today and from other people. I will say that I think the report indicated that and showed that the reimbursement rates for 60-minute psychotherapy sessions under Husky was indeed comparable to reimbursement rates in under commercial insurance. So it does seem as if having patients can probably at a higher rate access psychotherapy services perhaps more easily with Husky. But, you know, I think what I'd love to do is share a story with you about how even when someone is an in-network provider, oftentimes there seems to be difficulty with them getting paid. And this was a story I just heard yesterday from a colleague of mine who actually is a psychiatrist who was the patient seeing another psychiatrist who's in network. This is all in Connecticut. And for a situation weekly for 7 months, had gotten prior authorization from the insurer to see the therapist in weekly meetings, and then learned to her distress that her psychiatrist, her therapist, had never been paid in 7 months. She checked with the insurer, the prior authorizations were in order, but there was an incredible delay in payment. And so it was almost like the therapist was making a loan to the insurance company, that they would be denied or delayed payment for 7 months. So that's just one example. I don't know that that necessarily is a true, this parity report doesn't look at that, but that's just an example of some of the day-to-day problems that people are accessing care. And it impacts her, the patient, because now she feels kind of an ethical problem. Should she still see the therapist if they're not getting paid? Should she just pay out of pocket? And so it actually is now impacting the therapeutic work.
Thank you, Dr. Kennedy. We have a question from Senator Summers.
Yes, and thank you for being here today. I didn't know if you'd be able to answer this or not. Is she still there? Okay.
Yeah, I'm still here.
Great. There have been issues with many clinicians getting paid, not just those, in your line of work, because there was a big data breach. And so some of these large insurance companies, in some cases, I mean, they're starting to catch up, but I do know of a few primary care physicians that have been put in a position where they are essentially bankrupt because they have not been paid by insurers for 18 months on patients, and they're still trying to carry staff and the overhead, et cetera. So when did this happen? Was this just recently, or is this from 6 months ago? Because that might shed some light on why it's taking so long to get payment.
This just happened 2 days ago. So, but I appreciate your perspective, and that's really helpful to know, Senator Summers. So thank you for sharing that with me, and I'll share that with my colleague.
Thank you. So that clearly wasn't part of this data breach that happened quite some time ago. But I do think that this committee should try to work with the insurance committee to see if there's a way where there can be payment made promptly. As somebody who used to have a biotech company, trying to sell directly to a hospital, you are basically floating the hospital if they're not paying you for 180 days. So especially when things are, so tight budget with reimbursements and everything, it's really unfair to have the clinicians trying to carry that float of patients while insurance companies or whoever is being able to, delay that payment and making money on the money that they have. So thank you for sharing that. And, I can share with you privately some of the names of the insurance companies that had the data breach, and you can share that with your colleagues so they know that that could be a part if it is something that happened previously. Thank you.
Thank you so much, Senator Summers. I appreciate that. I'll be in touch.
Thank you, Senator Summers. Dr. Kennedy, we hope you have a wonderful day. Thanks for being here with us.
Thank you so much. Really appreciate it. Have a great.
Next, we have Leslie Bennett, who's here with us in person. 2 days in a row here at the Capitol.
Yes.
It's wonderful to see you here.
Thank you very much.
If you can do me a favor, can you turn the microphone next to you off, and that
this
would
one
be,
off,
yes,
that one
perfect.
on. Okay.
Thank you for doing that.
Sorry. Thank you for allowing me to come. Senator Anwar, Representative McCarthy Vahey, Senator Summers, and Representative Claritas, I'm sorry, I'm so tired today. Claritas Ditria, and esteemed members of the Public Health Committee. I'm here today to testify in support of House Bill 6978, Section 1. You very kindly put in for funding for the Rare Disease Advisory Council, and we thank you for that. We need that, especially now that there have been cuts to NIH and other organizations around the state who help the rare disease community. We're going to need to become a resource for our state. And one of the things we want to do is develop. Okay, sorry. We need to become a resource. So that will help tremendously, and we will do that. We had our educational program yesterday, and we thank you all for coming and listening to it. The other bill I'm here to support is one that we had asked you to introduce, and that is the emergency protocols for rare disease patients and those with special healthcare needs. We are the only New England state, it's my understanding, that hasn't started doing something along these lines to help this population. There are no standard protocols, especially in emergency services for most rare diseases. There are some for something like sickle cell, which has been around, I think, for about 40 years, but that's an exception. Most of our rare diseases aren't even listed on hospital lists of standard protocols or anything. So a patient will walk in and the physician will go, I've never heard of your disease. So there's no standard protocols here. We're not asking for something this is basically common sense. It's a patient safety issue. You have my testimony on all of this. My daughter, Kelly, was a patient that we've encountered. It got to the point where trying to go to the local Stanford hospital was a nightmare because we'd walk in, and even though I had a primary care for her there, and we had 2 of her specialists who consulted with her experts up in Boston, we couldn't get them to, when we walk in, we couldn't get them to even access the records to verify that the protocols or her disorder what it was. The emergency room doctors wouldn't do it. And sometimes it was a conflict because there seems to be this disconnect almost between the hospital itself and the emergency room. And we're running into that even more as these emergency rooms are being basically farmed out. They're being contracted out. And so we see that conflict where they can't access the records in the hospital, which is a huge problem for not just us, a lot of patients. But in my daughter's case, her underlying disorder was metabolic. And it was never fully diagnosed, but we knew it was a protein problem by the world's leading experts. And they had devised a protocol for her. We had a whole package we'd walk in with that wouldn't just include her protocol, it would include a personalized medical history. It would be updated constantly. And if I'd go to Boston Children's, the minute I'd walk in, they'd rip it out of my hands to want to look at it immediately. But the local hospital wouldn't touch it. And we went in one time, she was on a specialized diet. And when her nutrients wouldn't be quite right, she'd start having seizure activity. And we saw it one time, there had been a change in her diet. And we had been talking to Boston. It was starting to progress rapidly, so they wanted us to be treated locally. Went into the emergency room. The doctor wouldn't even look at anything. He wouldn't check her medical records. And he turns around and he goes, I'm going to treat her like a seizure crisis, status epilepticus. And I said, it's going to be wrong. First medication he gave her, she could not metabolize. Second medication, she had an adverse drug reaction. When I looked at it later, it was something that was contraindicated for her. She wound up being admitted. She was admitted for 2 weeks to Stanford Hospital for something that probably should have taken 24 to 48 hours to manage. So there's extra hospitalization costs. She almost died. I mean, these are things that should not be happening to patients, and they can be avoided. It is a patient safety issue. I know the Hospital Association sent in testimony opposing this, and they basically said that ER docs would not be following they'd be following protocols that were outside of hospital control. I know they come through and do these protocols to try and control costs, but when something like this happens to my daughter, and it's not just my daughter, you've heard stories here today that are even worse than what happened to her. They're not saving costs, they're increasing them, and it's the state and state employers that are paying these costs. So these are just, it's just basic common sense. We could avoid all these problems. They also said,
excuse me, Ms. Bennett, but you've reached your 3 minutes. Thank
Sorry.
you. Thank you.
All right, thank you.
No,
Appreciate it.
thank you, Ms. Bennett. Actually, I'd love to continue this conversation because
we
you
will
were
at some point.
talking about the objections that we saw in testimony. So
Yep.
if you could finish that thought, and then I may have a follow-up question or two. for
Okay,
you.
the other thing they said is rare protocols would interfere with the standard of care. Well, in talking to advocates in other places, there is an exception principle in emergency medicine. And what it's for is it's intended for patients who have medical conditions that cannot be adequately addressed by standard protocols that they have written. A lot of our patients are like that. They're outside the standard protocol. And since our doctors, these are physician orders, basically is what we do, they should be able to just at least look at them. Or if they don't want to follow the protocol, they should at least be able to make a phone call. Takes a couple minutes to make a phone call to a specialist, and our specialists do stand by, and they will help. We also have, when I was talking about the website for the Rare Disease Advisory Council, there is a new platform developed by Children's National Hospital and Vanderbilt University. And what they're doing is, because of all the cuts at NIH, they're now starting to compile rare disease protocols so that if we had this up on a website, a hospital would be able to log in and see if there is a protocol there or a standard of care for a certain patient's condition. So these are things that we could help with. So I do urge you to push to pass this bill. Thank you very much.
Thank you. So you mentioned that we're the only hospital, or we're the only hospital. We are
We're
not a hospital right here. I just want
I
to
know.
say that.
It's-
And nor am I a doctor, and nor do I want to be to the earlier press conference conversation. But we are the only state in New England who doesn't have such a, so if I may,
Yeah.
let me just ask the question. The question is there legislative language from other states within New England that you might be able to share with us to help?
Some of the other, not here in New England. I think Massachusetts is considering doing it like we are. Most of them have gone through EMS. They've approached EMS first to give, especially now since our orphan drugs are so expensive, and it's imperative that patients get their drugs as quickly as possible. A lot of our patients, we encourage them to carry it's a whole go bag in which we have their medications. They're usually remain in original packaging, they're unopened and everything else, and they're extremely expensive. We're running into a problem now where hospitals, including major academic centers and especially EMS, do not carry them. So we've seen in other states where they've gone through and they've basically through the EMS programs have gone through and given some sort of exception principle where they can either allow under the scope of practice, they've changed that, the scope of practice where an EMS person can actually administer it, or they can observe a parent or guardian giving the medication as needed so the patient gets their treatment as quickly as possible.
Great, thank you for that. That's helpful. And any language or anything
I'll
that
get
you
that and
have.
have it sent to you if I can.
That would be wonderful.
I think one of the places that we've been dealing with Danny's Dose is the website, and they're the people that have been doing it, but I know that there are several states that have done it.
Great, thank you so much. Senator Anwar.
Thank you so much, Madam Co-Chair. Thank you, Leslie, for your advocacy and the work that you do pretty much 24/7 from what I'm calculating. Here's a couple of thoughts. You heard Dominic Cotton, who was earlier, and in his case, he actually had an entire small document. It was like 2 or 3 pages about the emergency protocol for his son. Do you think in this two-way traffic for the healthcare systems to be ready, but the patients and their families to be ready with those protocols handy, signed by their specialist doctor or their primary care doctor who understands that disorder and or the disease that they may have? How do you think would that be a better way to approach this too, or enhance
it is? It's something that I've been advocating for that for more than 20 years. When Kelly was first diagnosed, my background is in clinical laboratory science and medical research. I've worked with some really well-known physicians, and when she was diagnosed by one of the world's leading neurogenetics experts, he and I sat down and talked about it, and we banged out a whole package that I would carry with her. And in that, I would have a personalized healthcare summary listing. And the first page was all of the physicians that she saw. The second page would have her primary underlying diagnosis and then all the secondary conditions and the things that they could look for with symptoms. The third page would be the actual protocol or his orders on how to treat these, whether she was having a seizure crisis or, what the things that could come up. And there were places to call. We would have, a blurb about the disorder, and I encourage parents to do that. So we give as much information as possible. We would have the medications that she needs, everything we could possibly do. And we encourage this. We have major rare disease organizations that work with families on this, how to do it, what to do, what to include. The National Organization of Rare Diseases gets involved in this, all of the medical centers, and we work with them. We work with physicians on this, and they are signed physician orders. The Europeans have been ahead of us on this. For something like my daughter with a metabolic disorder, they call it letters instead of orders, but they will have a generic order for metabolic disorders. And in it, they have the whole package and they talk about it. And that's what we all do. And that's why it's so frustrating for us to walk in. Like I would walk in, if I walk into Boston Children's, we would rather drive 2.5 hours than go to Stanford Hospital. I'd walk into Boston Children's. And the other thing we do too is when we're going to the hospital, we usually alert our primary care or one of the attending physicians. I always tell them to, alert them so that they can alert the emergency room that we're coming in. And this is a rare disease patient or a patient with special healthcare needs. So they're aware that we need to be handled a little bit different. And these are all things, it's a two-way street. But right now, the problem we're running into, and you're seeing it with the emergency rooms being, contracted out, it's becoming a bigger problem.
I'll just add a quick little comment, and in the last few years, medical education, especially the clinical medical education, has developed a weakness because whenever anybody's going through clinical education at a hospital setup, everything is going through protocols,
Yes.
efficiency, and if you do not follow the protocol, you are not providing quote unquote standard of care. And now they're taking one step further. The code of conduct is inappropriate for a clinician not to follow the code, the protocol, which is like we would have robots then, right? Why are we training people to become robots? You're supposed to think, assess, go back to the basics. And healthcare is in the clinical realms is encouraging people not to think.
Well, they're
Yeah.
taking away your decision-making
Yeah.
tools.
Yeah.
I mean, you're no longer allowed to, I mean, Dr. Gordon referred to being able to adapt a protocol to a patient, and that's what we're getting away from. But in this case, you need to do it. And it's something that we look at how to save costs in the state. And we can save quite a bit of costs. We can save from unnecessary procedures to, like my daughter with an unnecessary, hospitalization.
I think this bill will help us move in the direction so we can start to make sure that we save more money and create a mechanism for better care for our vulnerable population. So thank you for your advocacy and your
I appreciate
testimony.
it.
Thank you, Madam
Thank you.
Co-Chair.
Thank you, Senator Anwar. Seeing and hearing, let me just double check online. Oh, thank you. Next up, we have Myrna Watanabe. Is she here with us? Oh, she is. Wonderful. Welcome.
Welcome. Yes, thank you. Yes, I look around and I see familiar faces. Senator Anwar and Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Dr. Myrna Watanabe. I'm from Harwinton, and I am representing myself and my family to speak in favor of HB number 6920, an act concerning patient-specific emergency medical care protocols for people with a rare disease or special healthcare needs. My husband, Peter Brusitis, has sporadic inclusion body myositis. We call it SIBM, a rare muscle wasting disease that affects perhaps 150 Connecticut residents at most. One symptom is dysphagia, difficulty in swallowing. At 88 years of age, he is a frequent visitor to emergency departments. In general, many of the medical professionals who've seen him in EDs have never heard of his disease and have no information about it. He now goes to UConn and his records show the SIBM diagnosis and his symptomology. Thank you. In the past, however, he has not been so lucky. I'll mention two situations. About 10 years ago, he went to Charlotte Hungerford Hospital complaining of GI pain and vomiting. They admitted him, and the gastroenterologist told him he needed his gallbladder removed and they would do it in the morning. Because patients with this disease don't always respond fully to paralytic anesthetics, an anesthesiologist may see this and increase the dose. That could be fatal. His neuromuscular physician from Hospital for Special Care warned us that if Peter ever needed surgery, the anesthesiologist needed to speak with him. Surgeon never contacted me, and I was not confident that my husband was in the right place for surgery, and neither was his brother. His brother was then head of radiology at Walter Reed. He was like, no. I demanded he be transferred to a major hospital where there was a greater chance that maybe a physician had seen the disease. He was transferred to Hartford Hospital. The anesthesiologist called a neuromuscular doctor, and it worked out well. A second situation, when Peter very clearly had a cerebrovascular accident, could have been more serious. Before we sent him to the hospital by ambulance, I spoke with his neuromuscular physician and another neurologist. Both said this was likely a small vessel bleed. When the ED APRN called me, I told him about SIBM. He decided my husband's symptoms, hemiplegia, which he did not have the day before, were from exacerbation of the SIBM. He didn't understand that this was a slowly progressing disease and would not cause hemiplegia in a man who was walking and using both arms the day before. Fortunately, the ED doctor who covered the next day did understand. He ordered an MRI that confirmed a small vessel bleed in the right brain, causing left side hemiplegia. As a science and medical writer, I wrote and edited protocols for hospitals that were available on a commercial database with a paywall. A template could be edited by the physician for a specific patient. Thank you for your time. If you have questions, go ahead.
Thank you very much. Thank you for sharing your story and all that you've been through. We appreciate you being here with us today in person as well. Seeing no questions, we thank you.
Okay.
And
thank you. And thank you for the bill.
You're welcome. Next, we have Loretta J. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Loretta J., and I live in Fairfield. Thank you for the opportunity today to testify in support of HB 6975, an act requiring a biennial study of payment parity. This bill is fundamental, not just as a policy matter, but because it directly impacts the health and well-being of people across our state. As a special education advocate, I work closely with families whose children have behavioral health needs. And time again, I see how inadequate insurance payments to mental health providers harm those who need the help the most. The failure to pay a fair rate has created a system where many providers are unwilling to accept insurance. This leads to an inequitable healthcare landscape where consumers who rely on Medicaid or commercial insurance are left with few options. The lack of available providers means families face higher out-of-pocket costs, or worse, are unable to access care at all. I have spoken with therapists who accept insurance, but are considering opting out because they could charge twice as much for private pay services. What's more, reimbursement for family therapy is illogical, around $30 less than individual therapy, despite requiring more time, effort, and case management. The shortage of available in-network providers is a severe issue, particularly when a higher level of care is needed. I work with a 13-year-old client who required residential treatment after several hospitalizations, but only 2 centers in the state accept Husky, and they had 6-month wait lists. This delay resulted in another hospitalization. The system is not just inefficient, it's putting our most vulnerable at risk. A 2017 Milliman report found that Connecticut residents used out-of-network behavioral health services 11 times more frequently than primary care services. The trend has only worsened since the pandemic. One case I handled this winter underscores this. A mother and I contacted 27 providers listed as accepting her insurance. None was accepting new clients, or they had stopped taking the insurance. As a result, her daughter got stuck in a more expensive, higher level of care. This made the youth feel hopeless and led to suicidal ideation. Her mother used FMLA for 3 weeks off from work to find a new provider, a financial and emotional burden that no family should have to face. The disparities in how mental health services are paid for are not just a financial issue. They are a systemic barrier to care. HB 6975 is a necessary step to address this. By mandating a biennial study of payment parity, this bill would provide us with critical data to understand how insurance companies and Medicaid are complying with parity laws and to identify gaps in care. I urge this committee to support this bill because it is necessary to ensure that all Connecticut residents, regardless of income or insurance type, have access to the mental health care they need, when they need it, without facing financial barriers. Thank you for your time and consideration.
Thank you. Great job in under 3 minutes there. Ms. J, it's been a privilege to work with you on this issue for many years, and full disclosure to all those here. And I wanted to ask you a little bit about the conversation you heard earlier that I had with Christian Damiana about the legal parity question. You were speaking in your testimony about some of those payment differences, but if you can kind of speak to the compare and contrast there and why both of those issues are important, and how some of this gets at the legal parity issue too.
Okay, thank you. So I'll give my own personal experience as an example. My personal therapist bills 3 times what most commercial or Medicaid pays for payment for a therapy session. And she does not accept insurance. So there's an example right there as 3 times the amount of what Husky would pay for that, or what Blue Cross would pay for that, as an example for how that plays out in real life. I could go on, but there's one.
No, thank you for that. I think there are a few other, actually, I'm going to turn it over to Senator Anwar for a question, comment first, and I'll come back.
Thank you so much for your testimony. There was data that you shared about the frequency of emergency visits or emergency issues with individuals who do not get parity. Can you just repeat there was some data that you had mentioned and I did not catch it.
The data I mentioned, the 2017 Milliman report.
Yeah.
That compared that in Connecticut, people use behavioral health services 11 times more frequently out of network than they do for primary care. So the actual data is 34% of people in Connecticut use out of network behavioral health services. They pay private pay, compared to 3.1% for primary care.
Wow.
Yes, sir.
And that's 2017.
That's 2017, and it's certainly gotten worse.
Yeah, it has. Thank you so much. Thank you. Back to you.
Thank you.
Thank you, Senator Anwar. So just as a follow-up, I think some of the conversation around the issue of parity has focused on, and I think rightfully, the fact that the conditions that you're describing, where so many of the providers are out of network and that we have some difficulty in providers shortages. I guess my question is, would you agree that this is a complex problem that has many different prongs and aspects to it, and that this conversation around the legislation before us and in other places is part of the solution and part of the conversation, but not the entire conversation?
Yes, Representative, absolutely. This is the payment. What providers are paid was one part that is affecting the parity problem, and whether it's not just how much they get paid, it is how they get paid or how they do not get paid more frequently. It is the way that we stigmatize and treat mental health care compared to other health care. Another example, and certainly we know there's other bills pending, but other examples are things like for a mental health provider who might see both an individual and a couple at the same time, insurance will not cover that. Or if they see the parent and then they see the child, and it's, people have to take off from work, or they're navigating getting back and forth, they're seeing the same provider that would like to see them on the same day, but insurance companies will not cover that on the same day. But do we stop someone from seeing a cardiologist and a podiatrist on the same day, if that's their day off from work? So it's a different service, it's a different CPT code, but they're still not being paid.
Thank you. Thank you for that example, for staying with us here today, and for all the years of effort, time, and advocacy that you've put into this. We appreciate you.
Thank you very much.
Thank you. Next, we have Megan Wolf, who's with us online, to be followed by Thomas Burr.
Great. Thank you, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. On behalf of the more than 240 orthopedic surgeons in the Central Connecticut, or in the Connecticut Orthopedic Society, thank you for the opportunity to share the Connecticut Orthopedic Society's testimony in opposition to SB 1325, an act permitting naturopathic physicians to prescribe and administer vitamin B12. My name is Megan Wolf, and I'm an orthopedic surgeon practicing in Central Connecticut, in Wallingford, Meriden, Cheshire, and Southington, and serving on the board of the Connecticut Orthopedic Society. On the behalf of the 240 plus physicians who are members of the Connecticut Orthopedic Society, I testified before you today to express my strong opposition of the proposed bill that seeks to expand the scope of practice for naturopaths by granting them prescribing authority. This proposal raises significant concerns about patient safety and overall quality of medical care in our state. The ability to prescribe requires extensive medical training, education, and clinical experience requirements that are not met by naturopathic programs. Naturopaths primarily focus on natural remedies and alternative therapies rather than evidence-based pharmacology and clinical diagnoses. Their training lacks the depth and rigor necessary to safely prescribe medications, manage potential drug interactions, and recognize contraindications. Physicians, on the other hand, undergo years of intensive education, including thousands of hours in pharmacology, physiology, pathology, and clinical practice, especially including in residency. This is expertise that is critical to ensuring the prescriptions are made with full understanding of a patient's medical history, coexisting conditions, and potential risks. While this bill specifically seeks to allow naturopaths to administer vitamin B12 injections, its passage would set a dangerous precedent. It would allow professions to dictate their own training standards, expand their scope of practice without adequate oversight, and blur the lines of medical authority, ultimately misleading healthcare consumers. This is especially concerning for vulnerable populations, including children, who may not be able to advocate for their own safety when receiving care. Pharmaceutical treatments are often necessary for managing acute and chronic conditions, but they also carry risks that must be carefully managed. Many medications can have severe, even life-threatening side effects if prescribed improperly or without full consideration of a patient's medical history. For example, while generally considered safe, certain medications can interact dangerously with vitamin B12 injections, leading to serious adverse effects. If a prescriber has poor understanding of these medications, the side effects may occur. Patients are extensively trained to identify and mitigate such risks, but naturopathic programs vary widely on their curricula and lack standardized requirements for pharmacological education. Without clear regulated training in this area, it would be unsafe to grant prescribing authority to naturopaths. On behalf of the Connecticut Orthopedic Society, I appreciate the opportunity to bring these critical concerns to your attention. We urge you to oppose this bill in the interest of patient safety and public health. We would welcome the opportunity to discuss these issues further with members of the Public Health Committee and work collaboratively to ensure that all healthcare practices in our state maintain the highest standards of safety and effectiveness. Thank you for your time and consideration.
Thank you very much, Dr. Wolf, and also appreciate how well you did getting all that information in 3 minutes. Was wonderful. Senator Summers.
Yes, thank you for your testimony. I do have a question for you. We've heard today that there is a difference. You keep referencing naturopath, and we've heard today that there's a difference between a naturopath and a naturopathic physician. And this bill is for naturopathic physicians to be able to prescribe vitamin B12. And we also heard the difference in the schooling and the amount of clinical hours. Does that difference make any difference in your testimony today?
No, that does not. And I know that it's unfortunately in my testimony, I do use that naturopaths, but I understand that this is for naturopathic physicians. With naturopathic physician training, I was on a lot of the hearings with this, and we discussed very intensely with the naturopathic physicians in regard to their training. They have pharmacologic hours in their school. However, this is not standardized, and they do not have residencies. I really want to emphasize that we don't allow medical doctors to practice without residencies, or if they do, they really are very few and far between. Naturopathic physicians do not have residencies. In my personal experience, I really did not understand how to truly use these medications until I was in residency and I had a lot of oversight in prescribing these medications. And for example, I'm an orthopedic surgeon, so I'm not prescribing a lot of medications that I didn't really have a lot of training in either. And even though I learned them in medical school. And so I don't think that the amount of training that naturopathic physicians have in their schools do provide them the understanding of how to use these medications in practice, and therefore I do not think that it is appropriate to expand that scope of practice in this way.
Okay, thank you. Did you, were you involved or did you sit on the scope of practice review with DP?
Yes. Yeah, all three.
Okay, and that was, it came back as no one could agree. We've been kind of doing this for over 8 years now.
Sorry.
When you say medications, this bill is specific to vitamin B12. It's not medications. It's just to B12. So I just wanted to be clear on that. So
Yes.
thank you for letting us know that you've sat on that review of scope of practice. We've done that now, I think 3 times and nobody can agree. So I thank you for your testimony. I just wanted to be clear on that. It was clear from some of the testimony earlier and that there is a difference between a naturopath and a naturopathic doctor, so a physician. So I just wanted to make sure that we were all talking about the same thing. Thank you for the clarity that you provided today.
Can I provide a response to that?
Yes, please do.
So yes, I understand that this is for vitamin B12. Vitamin B12 is a prescription medication when it's administered intramuscularly. And so I think one of the things that myself, representative of the Connecticut Orthopedic Society, is trying to say is that we don't want to have this be a bouncing off point of, oh, well, now we can prescribe this and administer this. Then we can prescribe further medications, which I know myself and some of my medical doctor colleagues were concerned about. And so I think that the issue is more the intramuscular administration of a prescription medication that does require prescriptions to be able to administer it in the office.
And I thank you for that. I just wanted to be clear, just because of the testimony you said, prescriptions, like plural. So I didn't want people that were watching to think that this bill would be opening up all kinds of medications because it's very specific to one. But I appreciate your point, and I just wanted to make sure that was clear. Thank you so much.
Thank you.
Thank you, Senator Summers. Thank you, Dr. Wolf, for being here with us today and for your work and volunteering in that regard over many years.
Thank you.
Next, we have Mr. Thomas Burr, who's here with us in person. Welcome. It's great to see you here.
It's good to be here, and good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Thomas Burr. I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I'm also a member of the Keep the Promise Coordinating Council, as well as a member of the Connecticut Mental Health Parity Coalition. And many of you know what NAMI is about, but if you're not familiar with us, more information about us is in my written testimony. I'm here today to testify in support of House Bill 6975, the Payment Parity Biennial Study Bill. NAMI has been actively working in this space towards having the healthcare industry adhere to the full compliance with existing mental health parity laws for a long time. I mean, these laws have been on the books for over a decade, and yet here we are. Too many of our members and people that we care about with mental health conditions routinely cannot access the mental health care that they are already paying for through their premiums. Due to the nature of these conditions, people usually just give up without either appealing to their insurance companies for reconsideration or lodging a formal complaint with the Connecticut Department of Insurance, because typically they're in crisis and they have more important things to do, honestly. And yet study after study confirms that this is a real problem. And in fact, in my written testimony, I've included 5 different links, including a link to that Milliman report that Loretta J. mentioned a few minutes ago, that really illustrate exactly how deep and widespread this problem is. House Bill 6975 is an important step towards insurance payment parity between mental health and physical health services in Connecticut. The need for better data and accountability is clear. There's been references to the 2024 report from the Office of Health Strategy, which I also linked in my written testimony, that said that 4 out of 7 commercial insurers in Connecticut are exhibiting warning signs of parity noncompliance, underscoring the urgency of continued oversight. Mental health parity is the law, and it should be adhered to. When it isn't, many people desperate for services will not receive them, worsening their conditions, which will then cost more to address. People lose time, some lose their jobs or their families, and some lose their lives. For some, they will, if they can, switch over to the Connecticut Husky program, which is in essence a cost shift from private for-profit business to the state of Connecticut and ultimately the tax-paying citizens. And what we refer to as NAMI is Connecticut's dirty little secret. And a shout out to Ben Shaken for his testimony and really the information he provided and how that looks at the provider level. So in conclusion, I strongly urge the Public Health Committee to favorably vote on HB 6975. The bill will provide much needed data on parity compliance, enable us to ultimately address the gaps and ensure that all individuals in Connecticut can access the care that they need without facing financial discrimination and potentially life-threatening consequences. And since I didn't hear the ding, I'm going to just do a quick shout out to the views expressed by Ruth Groby and her Wheelchair Warrior crew, and just let you know that we support their testimony about accessible medical equipment. Thank you.
Thank you so much, Mr. Burr, for all your years of advocacy on this issue. Senator Anwar.
Thank you so much, Madam Co-Chair. Thank you, Mr. Burr, for your testimony. Has something like this been done in another state, the parity? I know there's a federal law, and in Connecticut, some have chosen not to follow it. But are there other states where some of the insurance companies are following the federal law and hopefully their local laws?
There have been numerous legislative attempts to fix this throughout the 50 states. The good people at the Kennedy Forum hold a monthly conference call, and they review legislation from all the states, what's in progress, what's in play, and how it's working. And we have leveraged some of that information in some of the other parity bills that are before the legislature this year to try to get this under control. So yes, this is not just a Connecticut problem, it's a US-wide problem, and some states have had more progress on this than we have, but it's a problem everywhere.
And with the work that you do, is it fair to say that if somebody has a mental health, their physical health is going to have challenges too, and then the overall outcome is going to be worse if the mental health is not addressed?
Oh, absolutely. It just causes a cascade of effects. I mean, the whole mind-body connection is a real thing.
And so this lack of investment of the insurance industry in this arena is actually not saving them any money in the long run.
Oh, yeah, no, it's not. But due to the nature of their business models, it's quarterly profit models that they're trying to, targets they're trying to hit. So I get why, some of why they don't want to do this. But, again, it's the law, and it's been the law for over a decade, both at the state and federal level. So I don't know if you happen to have been in the room at the time when we did the parity press conference. When was that, Christian? Like over a week ago? Last week? Yeah, time flies. But AG Tong was very outspoken about this and saying, this is against the law.
Yeah.
And yet here we are.
And I think you alluded to this, and I'm just going to make a quick little comment, Madam Chair, that what's happening is if you zoom out and look at the health and well-being of a community, it's better to be front loading it and taking care of the people, and you save so much money in the long run. The insurance industry, for profit, publicly traded, they look at everything on a quarterly basis, and they have to show some numbers on a quarterly basis, and they have become tunnel visioned in their ability to change the bigger picture. And their strategy is from every quarter to every quarter, cut corners. And in the long run, they're not helping the health and well-being of their clients. And in the long run, they're losing. And it's a very common sense thing, but it's very difficult from their business model for them to understand this. And so thank you for alluding to that as well. Thank you.
My pleasure.
Thank you, Madam Co-Chair.
Thank you, Madam Chair. Seeing no other questions or comments, thank you again for staying here and being here with us today.
My pleasure, and I appreciate you guys paying attention to this. It's a big problem.
Absolutely. Next online, we have Leslie Miller, to be followed by Betsy Guerra.
Hi, how you doing? Good afternoon, Senator Anwar, State Representative McCarthy Vehi, and committee members. Thank you for allowing me to testify in opposition to SB 1325, scope of practice. My name is Dr. Les Miller. I am a board certified family physician and past president of the Fairfield County Medical Association. My 8 years of medical education included a residency at the University of Connecticut and a Yale Fellowship in Preventive Cardiology. This training took place in hospitals and ambulatory medicine centers. My training called on me to manage patients in the ICU, in the emergency room, on various medical floors, including surgery, obstetrics, and pediatrics. I rotated through each of the medical specialties, learning to treat and prescribe for related conditions. By the time I stepped out of my training, I had substantial real-world knowledge on prescribing safety. I chose my specialty in primary care based on a desire to create wellness. To maintain that privilege, my education continues with 50 hours of medical seminars each year, added to maintenance of certification activities, and a full day board recertification test every 10 years. The above keeps me updated with the algorithms of medical care that include updated information on cutting edge and current medications and their proven appropriate use to advance patient health. Prescribing medication requires a complete understanding of the patient's bodily functions in addition to their pre-existing conditions. If a patient has reduced kidney or liver function, a medication dose is reduced or the medication is completely eliminated, as certain drugs can create harm to the patient. Medications used in younger patients may be inappropriate and harmful to the elderly. Drug-to-drug interactions, as well as drug-to-disease interactions, are frequent. For example, a medication that induces water retention can place a weakened heart into failure. Some medications may increase risk of stroke or arrhythmia in an unknowing individual. Patients have allergies or idiosyncratic reactions to medications, all of which complicate the decision of when and how to prescribe. The medical field has pulled away from injectable B12 in favor of a sublingual approach, even pills in many situations. An exception to this, of course, is certain neurologic conditions. Naturopathic medicine has dedicated itself as an alternative to traditional medicine. It is my understanding that my 50 hours of continuing medical education compares with 15 hours of naturopathic requirement. If an individual desires to insert themselves in traditional medicine, that person should be held to the same rigorous standards of training, knowledge, testing as any other licensed medical professional who is responsible for the life of a patient. Thank you.
Thank you very much, Dr. Miller. Now, you may know, I'm sure you do know, that Senator Anwar is a physician as he sits here, but I'm not. And as I mentioned earlier today, have never wanted to be. But what is sublingual? Can you say what that is and what that means?
So the medication, the B12 can actually be placed under the tongue where there's a vast network of arteries and capillaries, and absorb the medication a little bit better.
Thank you. Thank you for answering that. I appreciate that. And I appreciate your testimony here today and all that you do in the community. Senator Anwar?
Thank you so much, Dr. Miller, for your testimony and the work that you do. Wanted to just, I'm going to make a statement, and if you can reflect on it for me, if you do not mind. With the bill, the inherent idea of the bill is that vitamin B12 deficiency is a disease. And if I was to say that vitamin B12 deficiency is a symptom of a disease, which could be a malabsorption syndrome, could be gastritis, could be pancreatic insufficiency, could be bacterial overgrowth syndrome, could be pernicious anemia, but could be a number of different things, post-gastrectomy complications. So to have the responsibility of a symptom to be managed by somebody without finding the cause of it is creating a delay.
Sorry, my son.
Creating a delay in diagnosis and perhaps real management. This is my statement. How would you respond to that?
Well, I mean, I think that we are all monitoring. As a primary care physician, when I see a patient, I am analyzing the patient from head to toe. I am looking at every disease that they have. I am obviously, if they have gastritis or gastrectomy, I am looking for the B12, and many of those people are supplemented anyway. Maybe not gastritis, but certainly any kind of bariatric surgery. If they have a symptom, I am looking for B12 deficiency. I order lots and lots of B12 tests, methylmalonic acid. I order folates and homocysteine tests. We're all looking for those, and we prescribe for those people, and we monitor the levels.
And so to my point, what I'm trying to say is that if somebody who is not trained in the family practice or internal medicine or adult care in the comprehensive manner with residency, low B12 level is equal to B12 injection is not the answer. It's far more complex than that.
Yes, absolutely.
Okay, that's what I wanted to just clarify with you. Thank you so much for your testimony and your insight and the work you do. Thank you, Madam.
Thank you.
Thank you, Senator Anwar. Dr. Miller, thank you for being here with us today.
Thank you.
Next, we'll go to Betsy Guerra, to be followed by Dr. Emmel.
Thank you, Representative, members of the committee. My name is Betsy Guerra. I'm the Executive Director of the Connecticut Waterworks Association, and I'm here today to discuss House Bill 6977, an act concerning the Department of, I don't know where my camera went, sorry about that. An act concerning the Department of Public Health's recommendations regarding drinking water. We do support the recommendations included in the bill. They're fairly straightforward and really just clarify the department's current authority relative to the review and approval of and the construction and location of new public water sources. What I'm also here today to talk about is an issue that we did discuss with the chairs and ranking members of the committee in a meeting earlier this session to discuss cross connections and whether there is a possibility that language regarding cross connections could be incorporated in either this bill, which again has revisions regarding drinking water, or in the department's larger revisions bill. Cross connection, just by way of background, is any actual or potential physical connection between a public water system and a non-potable source of liquid, solid, or gas that could end up contaminating the public water supply. And so there are rigid requirements relative to cross connections requiring water utilities to inspect for cross connection protections on an annual basis, and also to ensure that the backflow preventers and things of that nature are also tested and inspected and working properly. Again, all of this is designed to protect the quality of the drinking water. Because of the complexity of this issue, our sister organization, the Connecticut section of the American Waterworks Association, actually has a cross connections committee that works very closely with the State Department of Public Health drinking water section to ensure that the cross connection manual and the corresponding regulations are updated on a regular basis to, again, protect water quality. What we're looking for in terms of a revision is fairly minor. We simply ask for the inclusion of language to permit the Department of Public Health to proceed with the implementation of policies and procedures necessary to administer provisions relating to the use, installation, and inspection of cross-connection protections, again, between a public water supply system and an other water system, while in the process of adopting regulations. This would ensure that they can move more quickly in terms of making these changes. Again, we've had very good conversations with the department on this topic, and we will certainly work with them to finalize any language, as well as to continue the conversations on updating the regulations in general. Thank you.
Thank you, Ms. Guerra. Thanks for your work on water, always. I believe that you're probably going to see the language appear in the draft of another bill. So you won't have to testify at that point, most likely, or you may, but I did just want to acknowledge that. And thank you for noting your support for the Department of Public Health's bill.
All right, thank you.
Seeing and hearing no questions, we thank you. Next up is Dr. Emmel, to be followed by Dr. Gumam.
Good afternoon, Senator Anwar and Representative McCarthy-Vahey and members of the Public Health Committee. My name is David Emmel. I'm an ophthalmologist, retired now, but still very involved in advocacy. I'm a past president of the Connecticut Society of Eye Physicians and have held legislative chairs for both the Eye Society and the Connecticut State Medical Society. And I've also been very involved in some of the scope committee hearings in the past with regard to naturopathic prescribing. Dr. Wolf and Dr. Miller did a wonderful job outlining the issues that we have. I'm going to focus on one specific issue that is of concern to me. In order to be a safe and effective provider of healthcare, it's necessary to have certain skills, including aptitude, knowledge, empathy, and experience. But you also need something that I'm going to call, for lack of a better word, attitude. Maybe we could call it disposition or perspective. And it's something I've been thinking a lot about because it's affecting us now in Washington, where we have people assuming important positions at HSS, the FDA, and the CDC that have attitudes, dispositions, and perspectives that may be very different from what physicians traditionally hold. I started thinking about this issue more than 10 years ago while on a scope committee hearing with the naturopaths. And it had to do with a statement that was made by David Brady, ND, who at the time was the vice provost of health sciences at the Bridgeport University in Connecticut. And this is what he had to say when we were discussing limitations on formularies. Specifically, and I quote, "We do not accept the validity of science-based practice, and we do not accept the validity of evidence-based practice. We want to do what we want to do." And that is of great concern to me, because if you look at the curriculum of a naturopathic college, you can see that what they learn is rooted very deeply in the past. Studies like botanical medicines, homeopathy, and other key core curriculum are all hundreds of years old, if not older. And they don't change, it's static. Whereas the practice of medicine is very dynamic. It's science-based, and science is continuously changing. We're always adapting. We know that what we do today will not be what we're doing 5 years from now. So there's a huge difference in attitude between physicians and naturopaths. And this is important in this era where we're living, where truth and fact have become mutable and misinformation runs rampant. Doing what we want to do and its corollary, believing what we want to believe, form a very dangerous foundation for the practice of medicine or healthcare in any form or shape. I do not believe that naturopaths or naturopathic physicians are disposed to perform the scope they're asking for in Senate Bill 1325, and I urge you to oppose it. I would also like to take a moment to respond to—
Excuse me, Dr. Emmel, but you've reached your 3 minutes. Thank you.
You're welcome. I'm happy to answer any questions.
Thank you, Dr. Emmel. Dr. Emmel, just to go back to the quote you shared from the person from the University of Bridgeport at the time, like, if I just may ask the question, that was something shared by an individual speaking on behalf of themselves as opposed to a group? Can you clarify that?
I believe that he was speaking for the group because it was in the setting of a scope committee, and he didn't say the word I, he used the word we. So I believe that he was trying to encompass the greater group of naturopaths in general. And
Okay.
I
Thank
wanted
you. If Dr. Emil, thank you for that. So that was in the conversation of a scope process that happened. You did want to respond to one other thing, and I'd like to give you the opportunity to do so.
Thank you. I mean, we physicians have a habit of saying naturopaths, I think in part because we tend to think of physician as being people who have training with great depth as well as breadth. But I'd like to correct a misimpression that there are lay naturopaths practicing in Connecticut. There may be one or two, but I think if you Google, you'll see that the people we're talking about today are naturopathic physicians with an ND degree. And the scope issues that we're talking about are directed towards them, not towards something that may or may not exist in Connecticut called a lay naturopath.
Thank you. Yes, I think that was also, we talked about that earlier, but not bad to repeat. Seeing and hearing, Senator Elmore.
Thank you, Dr. Emil, for your testimony and the work that you do. Can you repeat that statement? It was it registered, but it was too much for me to comprehend fully. So can you just repeat that statement again?
Yeah. And just to lead up to it, it was in a discussion about limiting the scope, the formulary. And I had an issue with the fact that at that time, their formulary, they wanted to include glaucoma medicines. And for a naturopath to be using a glaucoma medicine would be practicing ophthalmology 50 years ago. And we were arguing that it was improper and illogical. And at that point, he said, and this is a quote, and I remember it very, very vividly. We do not accept the validity of science-based practice, and we do not accept the validity of evidence-based practice. We want to do what we want to do.
Okay. All right. So thank you so much. This is helpful to us. Thank you so much for your testimony, and back to you, Madam Chair.
Thank you. Dr. Emil, in your experience, have the scope conversations been somewhat tense at times?
Yes, I think that's a fair representation.
And I asked that in part because that's a fairly extreme quote. And having been part of one conversation last year related to some scope issues, well, actually not one, many conversations with my colleagues, I would wonder what the context of that was. I am concerned by those comments also, and I understand that you are expressing the concern here, and it's valid to express that concern, but I also just want to provide that context that sometimes in those scope conversations, that back and forth, we weren't there to know what led up to that and how that came across. So I not to suggest that I believe that we should not rely on evidence-based settled science, which I have said previously here and elsewhere, but I just wanted to offer that, and happy to have you reflect on that if you would like to.
Well, that's why I provided that context in terms of the discussion that was at hand. I'm deeply concerned that the average naturopath, and I'm sure there are some that are feel very strongly about science and evidence-based care, but it's just the whole curriculum is retrogressive in terms of seeing things either static or dynamic. And the healthcare is dynamic. We're going to, like I said, we're going to be doing stuff 5 years from now that we're not doing today. Everything will be changing dramatically. You look at just the advertising you see on TV for medications for diseases that really weren't treatable 10 years ago. And there are new discoveries every week, literally, and new medicines. The mRNA vaccines are another example of that. So maybe it was a little heated in the moment for him, but I think it's a very revealing statement. I don't think that it was an accidental expression, but really a fundamental display of his true beliefs. And this is the person who held the highest academic position in naturopathic academics in Connecticut ever, as the vice provost of health sciences at the University of Bridgeport.
Previously, is that correct?
Previously, yes.
Yes.
They
Well,
no
thank
longer
you.
have a school.
Right. Thank you for that. Thank you for being here today and for all the work you've done over so many years. You've been involved for a long time, and we appreciate you spending time with us today.
Thank you for the opportunity.
Thank you. Next, we have Dr. Guman, and after that, it will be Sandra Ferrara Molina, who's here with us in person. Welcome.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridis Ditria, and distinguished members of the Public Health Committee. My name is Khurram Guman, and I am the current president of the Connecticut State Medical Society and a practicing family physician. I'm here to present testimony on two bills, SB 1325 and HB 6979. CSMS is strongly opposed to SB 1325. This bill would allow naturopathic physicians to prescribe vitamin B12, an unnecessary and dangerous step towards broader prescribing authority. While B12 may seem low risk, granting any prescribing rights sets a precedent for further expansion, as naturopathic physicians lack the education and clinical training necessary for safe prescribing. This is not just about the B12. This is about ensuring that all prescribing professionals have the proper medical education, pharmacologic training, and experience to manage medication safely. Naturopathic physicians are not medical doctors. Their training is fundamentally different, with minimal pharmacology education and no required hospital-based experience. Physicians complete years of intensive education, followed by residency training, fellowship training in hospitals and clinics, where they manage thousands of patients under supervision before practicing independently. In contrast, naturopathic physicians complete around 1,200 patient care hours, compared to about 12,000 to 16,000 hours of physicians. Safe prescribing is not about the length of a formulary. It's about the provider's training, experience, and ability to manage complications. Granting prescribing rights to naturopathic physicians, even in a limited way, is a step down a dangerous path that will ultimately put patients at risk. For these reasons, we strongly urge this committee to reject Senate Bill 1325. I would also like to give brief remarks on HB 6979. CSMS supports the underlying premise of this bill to enhance physician recruitment and retention. Connecticut is facing a physician retention crisis, ranking 47th out of the 52 states and territories in keeping the physicians we train. This bill takes an important step forward in creating a retired physician licensure and a student loan repayment program for primary care and behavioral health, but we must do more. Loan repayment should be expanded to all specialties as shortages exist across the board. Additionally, we must reduce the administrative burdens, increase Medicaid reimbursement rates, and provide financial incentives for physicians who train and stay in Connecticut. These recommendations identified by DPH Physician Retention Working Group must be implemented, not just studied, if we really want to make Connecticut a competitive place for practice of medicine. We urge the committee to strengthen this bill to ensure lasting improvements in physician recruitment and retention. And I want to thank you for your time, and we'll be happy to answer any questions.
Thank you so much. We're grateful that you stayed with us today and for your practice and work and leadership in the society. I know Senator Elmore has questions. I'm going to start though with this. Earlier today, I don't know if you were with us when we heard testimony from one of our colleagues talking about wanting to be with a provider who doesn't go straight to medical solutions, for example. You are a family practitioner, correct?
Yes.
So when you are assessing a patient and seeing a patient, can you talk a little bit about that in terms of the idea of going straight to medical solutions in your own practice?
Absolutely. I can take all day, but this is what we teach. I teach primary care clerkship at Quinnipiac National School of Medicine, and this is the cornerstone of what we are trying to train our next generation physicians. There's a biomedical component of the care, and then the biopsychosocial elements of the care. There are terms that we have curriculum about: de-prescribing, polypharmacy. So I urge every single student, every single trainee, and every practicing physician have this in the back of their mind when they are about to prescribe one medication. They think 3 times, not once, not twice, 3 times. Are there any side effects? Are there any interactions? If I'm adding one more medication, can I take one away? So this is a part of the standard of practice. The practice of medicine revolves around patient safety. Do no harm first. If there are avenues to take that we can, absolutely they are available. And it's a choice we make with our patients. And in primary care world, this is where I take, this is the fun part of my day, where because we know our patients, we have a relationship over time. They want to discuss with us in making that decision. And sometimes it's like, you give in to some of their choices in a way that is safer in the long run. And if there are avenues that we can take before we prescribe or de-prescribe, where's the happy medium? So to answer your question, every single prescription we write, we think about that.
I'll ask another question, actually, really to back up. When someone presents with a presenting issue, is it that you are immediately thinking of prescribing a medication, or are there other things that you are doing first, or alongside that, I should say?
It depends, what the clinical concern is. There are times where the medication is the right answer, but now even within the choice of medication, why are you picking this over that? For example, there's multiple different kinds of antibiotics. There's multiple different kinds of diabetes medication, blood pressure medications. Why am I picking beta blocker versus calcium channel blocker? Why am I picking this diuretic for the blood pressure water pill or that water pill for the blood pressure? So even within the same class of medications, there are individual patient reasons that may make you pick one or the other: family history, personal history, other medical conditions. The cardiologist just started them on this medication, so I shouldn't be prescribing this antibiotic because of the potential changes that could impact their heart. So it's not only do I pick a medication, the question is, within this choice of medication class, why am I picking this and not the other one? So it's a whole different and it's again, do no harm, patient safety first. So we are making the choice which is probably the best for this patient under the circumstances we are in.
And I appreciate what you said, which was essentially you try and meet people where they are, but as we often say, and bring them along. So you also talked about patient autonomy and patient choice in terms
Absolutely.
of the patient's ability and willingness to potentially comply with a course of treatment, or their hesitation, that kind of informed consent and that conversation. That's
Absolutely. There's two things that we take pride as physicians: do no harm and patient autonomy. Like, I work for my patients. I take pride in saying I work for nobody else but my patients. And I need to help them make an informed decision. The knowledge, the information, the tools that are available to me, this is my job to help my patient, my family that I'm caring for, to make that informed decision. Decision is theirs, but this is my job to give them the evidence behind my rationale for helping them make that decision.
Thank you. We have Senator Anwar to be followed by Senator Gordon.
Thank you, Dr. Guman, for your testimony and the work you do. Dr. Guman, if there was a naturopathic physician in this room, they would say that we go through training in pharmacology as well. we learn and spend a number of hours in the class. I don't know the exact number of hours, but it's a fair amount of number of hours. And that gives them the understanding of pharmacology to be able to prescribe. How would you respond to that?
So I will very respectfully say, good job, but that's just not enough. Now think about it. Even in medical school, the pharmacology core classroom teaching is mostly in year 1 and year 2. But when they go into their year 3 and year 4, and then years of training in the residency and fellowships, every single patient encounter they have, every single preceptor they interact with, they're asking them questions about why are you choosing this versus that? And what's the context of this patient's presentation, which leads them to make that pharmacologic choice. Even within, antibiotics, macrolide versus quinolones, why are you using this versus that? Again, going back to blood pressure and diabetes and asthma, common prescribing medications, but patients have the story, and the resident, the students, and the fellows, every single patient encounter, they're practicing and learning about the pharmacology embedded, weaved through the entire training in patient care. So the classroom teaching is important, but it's just not enough. And, it's this, but how do you apply this? How do you critically think through and getting to that decision? It's a whole different game. I use this example, with my medical student, which may or may not be truly fitting to your question, but I didn't grow up playing football. But if I play football on PlayStation with you, I can fool you that I'm a decent player. But in real life, I can't even throw 10 yards. So it's one thing to know it, but it's another to practice it. And when you're practicing, the 10-yard versus that, the inches away from that touchdown is a whole different game. So it's really relevant to patient care, clinical world. Classroom teaching is helpful. Beta blockers exist, but which one of these cardioselective versus non-cardioselective you're going to pick for this particular patient happens in the clinic, at the bedside, at the patient care.
Thank you. Now, earlier we had a couple of naturopaths who came and sorry, naturopathic physicians who came, who spoke about how their practice is collaborative. They work with, for example, there was a pediatric naturopath physician who said that I have pediatricians that she works with, and they work collaboratively. How do you see that model evolving, where the patient population that feel comfortable with some of the naturopathic remedies that are there, and then when they need another intervention that would read a prescription, then they could actually work with their physician counterpart?
I would welcome that. They can pick up the phone and call me. Hey, you know what? I've been working with this patient, and these are my clinical judgments or clinical, plan, and this is where I need help with. Just in a similar way as I would have done as a primary care physician, Dr. Anwar, if I needed a critical care patient or a pulmonary care patient, I would pick up the phone and ask for your help. We have another, a patient who needs like a specialty care help. That's why we have different expertise for taking care of that whole patient. So I welcome that naturopathic physician in the community who wants to collaborate and work with their MD physician colleagues, because if the desired outcome is the best treatment plan for that patient that they're serving, why not? Why wouldn't you pick up the phone and call your colleague?
Thank you so much. I'm going to go back to my co-chair, and then I think the others have some questions and comments. Thank you, Madam Co-Chair.
Thank you, Senator Anwar. Senator Gordon.
Thank you, Madam Chair. And how are you doing, Dr. Guman? It's nice to see you again.
Good to see you, Senator. Thank you.
I know there's been a number of questions and a number of things that have been discussed relative to the bill for prescribing for naturopath physicians. And certainly when we talk about B12, that's one thing, but then certainly what may happen in future with more requests for additional prescribing authority relative to care. And certainly we've heard discussions about that there are people who seek naturopathic care, and there are naturopathic physicians who provide that care. We've heard about as well that medical doctors, MDs, DOs don't always rush to give medications or do medical interventions. Many times there are other things that we do look at, understanding about polypharmacy, understanding about potential side effects, understanding about various things when it comes to pharmacology, but also non-pharmacology as well, which is certainly very important. And my question that I have through you, Madam Chair, is, Dr. Guman, you've mentioned about that it's just not the classroom learning, whether it be in person, which was what I did, but also any type of online, educational courses that there might be. But it's actually what we call the bedside learning, the experience over years, given the training for lots and lots of patients, and build it up. And my question for you is, do you feel that that degree of training, all those hours, seeing all those patients in different circumstances, different scenarios of medical conditions, different patient characteristics, different patient presentations, that is really the crux, the foundation of what medical physicians learn when they build up their education, their skill, their knowledge, when it comes to, number one, deciding if to use a medicine, and number two, if a medicine is used, weighing that risk benefit, having that discussion with the patient's family, and then doing the monitoring for efficacy, for safety, that compared to just any type of classroom, so to speak, learning.
Absolutely. So you could not have said it any better, but I will just add one more thing. Having gone through all those years of training at the bedside, in the patient room, clinics, hospitals, that gives you the knowledge, experience, and the wisdom sometimes not to do things that you could do, but in the best interest of the patient, this is safest not to prescribe this medication. This is safest not to go through this procedure at this time. So I think having that knowledge, having that experience is enabling you to be that advocate for your patient's best interest. So absolutely, I think the years-long training, years-long hands-on experience, and having the ability to make those critical decisions about what to do and what not to do is going to help the patients the most.
Thank you for your answer. My last question, Madam Chair, is there was a discussion about collaboration, and in your experience as a physician, I'm interested in what your thought is about the collaboration when, on one hand, a naturopathic physician needs or is seeking collaboration from an MD or a DO, but also it's a two-way street. If, for example, you feel that someone may benefit by you collaborating with a naturopathic physician, given what they do, you feel that overall that type of collaboration has been working well for you in your years of taking care of patients?
Of course, I think like I said, the idea is we are all trying to achieve the best possible outcomes for our patients. So if there is an answer that lies in another team member within the healthcare team that's available, I'm definitely going to seek that help to offer to my patients for their best interest.
Thank you, and thank you, Madam Chair. I don't have any further questions. Thank you very much.
Thank you, Senator Gordon. And Dr. Guman, thank you so much for being here with us today and for taking the time that you did to answer our questions. We appreciate it.
Thank you.
Next, we have Sandra Ferrara Molina. And you're here with us. Thank you for staying with us here in the room. It's great to see you.
Thank you, and thank you all for being here. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Sandra Ferreira Molina. I'm the Policy and Advocacy Director for the Connecticut Oral Health Initiative, and I'm here to strongly support Senate Bill 1326, which upholds community water fluoridation in our state. For decades, water fluoridation has been a cornerstone of public health, preventing tooth decay and improving oral health for Connecticut residents of all ages. Research shows that communities with fluoridated water see 20 to 40% less tooth decay than those without it. That's a significant difference, and it's one of the reasons why the CDC recognizes water fluoridation as one of the greatest public health achievements of the 20th century. You probably have heard that 20,000 times today. Beyond the health benefits, fluoridation makes financial sense. Every dollar invested in fluoridation saves up to $38 in dental treatment costs. When fluoridation is not available, the burden of dental diseases increases, particularly in undeserved communities where access to both dental insurance and dental providers is very limited. I would like you to consider this. In the absence of fluoridation, the average cost of treating dental decay in children can exceed $500 per filling. The more severe cases requiring thousands of dollars in treatment, including extractions, crowns, or even hospitalizations for advanced infections. Nationally, untreated dental disease leads to more than $45 billion in lost productivity in each year as adults miss work due to dental pain and necessary treatments. In Connecticut, departments visits for preventable, the usage of preventable dental conditions cost taxpayers millions of dollars annually, with Medicaid covering much of this expense, costs that could be significantly reduced through preventive measures like fluoridation. Experts across the medical and scientific communities, including the American Academy of Pediatrics and the American Dental Association, support fluoridation as a safe and effective way to protect oral health. Here in Connecticut, we've had a strong commitment to this practice since 1965, ensuring that over 90% of our residents have access to fluoridated water. As you and us consider this bill, I urge the committee to recognize the overwhelming evidence in favor of community water fluoridation. It is a proven, safe, and cost-effective way to protect the oral health of our residents while reducing healthcare costs. I respectfully ask you to support Senate Bill 1326 to continue this vital public health measure. Thank you.
Thank you so very much. We are very glad that you're here in support and for all the work that you do. You heard me probably reference earlier that I started my day at the dentist's office, and experiential learning is certainly one of the best ways to just be totally on board with what you're saying, and prevention. So
key.
thank you for the message and the work that you do.
Thank you so much.
Seeing no questions or comments, we're going on to number 40 online. Alicia Sharmat. Welcome.
Good afternoon, chairs and members of the committee. My name is Alicia Sharmat. I represent Rivers Alliance of Connecticut, an organization dedicated to protecting water resources. So here at Rivers Alliance, we pay close attention to laws and policies that pertain to both water going into our bodies and what's coming out. And for that reason, we have been engaged in wastewater and alternative treatment system discussions for decades. Most recently, I served on the Sewerage Subcommittee of the Commission on Connecticut's Development and Future. And I join you today to address sections 2 and 3 of 6977. So I have not submitted written testimony yet because I found these sections very confusing, and I really appreciate the committee's efforts to clarify those with the commissioner. So section 2 proposes changes to subsection A of section 19A-35A of the general statutes, which pertains to alternative on-site treatment systems. The regulations that the commissioner referred to that are currently open for public comment apply to subsection G of section 22A-430, not to alternative on-site treatment systems. So this means that regulations for ATS are either not already in development or are in the early stages of development. So this section also shifts jurisdiction over ATS to DPH from 5,000 gallons, not 7,500, as previously stated, to 10,000 gallons. So alternative treatment systems require rigorous monitor and maintenance, and failures pose a greater risk to public and environmental health compared to conventional systems. We agree that ATS can be a very effective tool to address water quality issues where conventional systems are a challenge, but Connecticut currently lacks effective, consistent oversight and regulations for ATS. And the way Section 2 is worded, DPH will not only have broader jurisdiction over ATS, but they would be allowed to implement policies and procedures outside of the regulatory process for a class of water system that they have not even developed draft regulations for. Section 3 pertains to Section G of subsection 22A 430, which pertains to household and small commercial subsurface systems. And it is these systems that DPH now has regulations out for public comment. However, what they're suggesting here will allow them to implement policies and procedures outside of the regulatory process. The commissioner stated that they intend to issue guidelines until regulations are adopted. Now, I have serious concerns about this because I have yet to find an agency guideline that is enforceable. So I respectfully urge you to strike sections 2 and 3 from HB 6977. And I thank you for your time, and I'm happy to answer any questions that you may have.
Ms. Sharma, thank you so much for your testimony and for being part of the conversation for quite some time. That commission was part of a bill I referenced in discussion here earlier today, actually, when I served as chair of planning and development. And I do think that we will be having some ongoing conversation about this issue and would welcome your input. We can connect offline. So
Great, thank you.
Seeing no other questions or comments, we go next to, I believe, is it, hang on one second. Thank you for bearing with me. Oh, number 42, who's here with us in person, I believe. Robert Brody. Welcome.
So good afternoon, everyone of the Public Health Committee. I'm Dr. Robert Brody. I'm the president of the Connecticut Naturopathic Physicians Association, and I'm a resident of Middlebury, Connecticut, have practices in Newtown and Fairfield, serving thousands of patients in insurance-based care. I'm a board-certified fellow from the American Board of Naturopathic Gastroenterology. I also did my residency at the Center of Excellence in Generative Medicine. I'm here today to express our sincere gratitude for the decision to raise Senate Bill 1325, which allows us to further discuss the expansion of the naturopathic formulary here in Connecticut. Following a comprehensive scope review conducted with DPH, as well as input for numerous healthcare organizations and associations, it became clear that we share a common objective: the health and well-being of Connecticut citizens. While our approaches may differ, this shared goal unites us. I believe focusing on common ground will be invaluable as we will continue to discuss this important bill. Senate Bill 1325 revisits the dialogue initiated during last year's legislative session regarding prescription and administration of injectable vitamin B12 by naturopathic physicians. As experts in natural medicine, we are uniquely positioned to administer natural substances, including vitamins, minerals, nutrients, probiotics, and herbs through their medically indicated routes of administration. Although many natural medicines are commonly used orally, they sometimes are more effectively used when they are delivered through the muscle, under the skin, or through the skin, as a few examples. These different ways of delivery are known as routes of administration. The statute which governs naturopathic medicine, Chapter 373, explicitly includes oral administration of natural substances only. CMPA would like to correct this by clarifying all routes of administration except IV therapy. In addition, current laws do not allow naturopathic physicians to utilize a number of natural substances that are available by prescription, including vitamins, minerals, nutrients, probiotics, and herbs. While previous legislative efforts explored a much more encompassing prescription authority, we have thoughtfully considered the feedback from our colleagues in medicine, which we received during the DPH scope review. We recognize the current shortage of medical providers in our state, and we propose an expansion of our role within the specific, well-defined boundaries in order to help meet the healthcare needs of our communities. Specifically, we request a focused formulary limited to natural substances, including vitamins, minerals, nutrients, probiotics, herbs, and certain hormones. Clarification of Chapter 373 to explicitly include the prescription of substances through all routes of administration, with the exception of IV. Expansion of the State Board of Naturopathic Examiners to include 3 naturopathic physicians, 1 public member, and 1 pharmacist, and ensuring a robust and appropriate regulation of the expanded scope. We believe these proposed changes represent a responsible and measured approach to expanding access to natural health care opportunities for Connecticut residents by focus on limited formulary of natural substances and enhancing regulatory oversight. We can ensure patient safety while empowering naturopathic physicians to play more of an integral role in our state's healthcare system. We are eager to partner with you to refine and implement these proposals and ultimately improve the health and well-being of our communities. Thank you for your consideration of our proposal and for your continued dedication to the public health of our state. Thank you.
Dr. Brody, thank you very much. You also got a lot in there during that 3 minutes and in under time. That was great. We appreciate that. Question, did you submit on testimony online, written testimony?
I believe we did, yes.
Okay, great, because I think it would be helpful for us to have that in writing. Are there questions, Senator Anwar?
Thank you, Dr. Brody, for staying with us throughout the day. So you saw a little bit of a glimpse of a day in our lives. I wanted to ask you, there's a lot of conversation that has happened, and you've been very calm and nicely listening to everything. How would you reflect some of the conversations that we have had? This is probably a good opportunity to say, look, I don't agree with such and such statement. I think this is a clarification I want to make about my profession and people in my profession who may not be representing it accurately or something to that effect. Feel free to do so right now.
Okay. Yeah, I think a couple of things. I think there's a lot of misinformation out there about different forms of Western medicine. Naturopathic physicians are Western doctors that are trained in the Western arts. There's a difference between an orthodox physician like yourself, Dr. Anwar, and an osteopathic physician, the same way there is a difference with a naturopathic physician. Medical schools are different for all those 3 branches of medicine. We are not saying that we are equivocal to medical doctors. We're just asking for the basic rights of the prescription with the limited formulary of natural substances. We do have clinical hours. I don't know where that notion has been coming from. In school, in our naturopathic medical school, which is after 4 years of undergrad, pre-med, you go through naturopathic medical school. The first 2 years are largely biomedical sciences. And each one of those biomedical classes, and I used to teach gastroenterology at the local naturopathic medical school when I was at the University of Bridgeport. There are prescriptions, vitamins, minerals, nutrients, herbs, diet, everything listed in that protocol and that criteria. After school, you can become a fellow like I did. I continued my training. I wanted to specialize in naturopathic gastroenterology, where I work collaboratively all the time with other providers. I work with great gastroenterologist in the kind of the Danbury system. I refer out left, right, and center for my colonoscopies and endoscopies, to making sure that the patients come to me that might be hesitant to get these basic screenings to prevent colorectal cancer, to get that done. If they're unwilling to do that, we talk about alternatives. There's things out there like Cologuard, et cetera, that we can do to help get them the care that they need to make sure that we're not missing anything. In my other practice in Fairfield, Connecticut, I work with a cardiologist. I work collaboratively with him, and I use his advice, and I go back and forth, and he uses my advice, because naturopathic physicians are trained first and foremost in the therapeutic order. It's least invasive to most invasive. We don't jump in any state where we are licensed with full scope. We don't jump right to prescriptions. We start with basic dietary lifestyle changes and slowly move up the route. Our medicine is evidence-based. I don't know where that notion is coming from. It is evidence-based. Yeah, and providers are not defined by what they use, but how they use it. And that's the philosophy with naturopathic medicine compared to the philosophy of an osteopathic physician or orthodox physician.
Thank you. I've never been called orthodox physician before, but
hopefully that's okay.
Yeah. I'll take that with pride. I wanted to ask you, you're the president of the organization.
Correct.
Thank you. What's the position at this time on vaccines?
It's going to be the one from the Pediatric Association of Naturopathic Physicians, which vaccines are used for prevention of horrible diseases that are preventable, from COVID-19 to measles, mumps to all that. So we follow kind of our state specialty organizations, which would be the Pediatric Association. And while I'm definitely more than willing to give you that white paperwork if you haven't had that already.
Okay, because during the pandemic, what we saw was a little bit different, and we have had frank conversations about this, about how some individuals were representing your organization in a manner which was not the majority's view, and then it created a situation, and because of the pandemic, you guys could not come and counter that, or at that time may have not felt it was necessary. But now I believe you are willing to stand up to anybody who's going to say some of those things and counter it.
And I would. We are evidence-based, and vaccines serve a vital role in prevention of diseases. It needs to be a conversation with the patient. For example, during the COVID pandemic, and I'm sure yourself was this way as well, Dr. Anwar, we were trying to do everything we possibly can to help our citizens, our patients. I was running tests left and right for this. I would have people come into me asking for letters to get vaccines. People come to me who are hesitant about vaccines and what this, that, the other, having the conversation with them. People that like, hey, I want to get the vaccine, but I don't know which one to get. What are you seeing? Which vaccine is less side effects than this, that, and the other? And I would have those conversations with them and be like, you should talk to your PCP about it, but this is what I'm seeing. See if maybe the Moderna vaccine is better than the Pfizer.
I've also noticed in the community, there's some models that are working very well. The collaborative models where you have a orthodox doctor physician and a naturopathic physician, they collaborate with each other, and they seek each other's insight into what is the best next step and there. So do you think that is a better model rather than a prescription model to try and see how they could be working hand in hand to enhance and provide the best care to patients who are have inclination towards both options?
We already have a provider shortage in this state and in the country, primary care providers, et cetera. My last patient yesterday, it's going to take him 6 months to get into a gastroenterologist so I can get a colonoscopy. It's already limited. I work day in and day out with gastroenterologists, and I refer as best I can. And they work with me as well, because they know that their training, their specialty only can take them so far. So collaborative model, we're definitely open. I talk to orthodox physicians and osteopathic physicians on a regular basis.
If you can just give us one moment.
Yep, no problem.
Oh, that was my bag, but he can have it. Yeah. So, but another question is that, last time we were having this conversation, and a number of individuals did come and spoke, and they were naturopathic physicians. And because we have our computers, we started to look, and one of the person who was testifying, she had this website which was basically claiming that she can cure ulcerative colitis, cancers, and all sorts of diseases. You name a disease in the world that is not curable, she had it on her website that she was going to cure it through naturopathic means. And I was telling at that time that that's not fair to the patients. The patient who's had a diagnosis, you lose out on the timely management from the misinformation. It's clearly a misinformation. And as a result, the cancer spread, and then by that time the stage has gone to a different one. What is the organization doing internally to call out their colleagues? In my the physician groups, there are people who are practicing in a manner which is not safe either. So, there's a way to be able to put a check on that, and then perhaps take the privileges away. There's a whole board and system that has been created within the hospital system and healthcare systems, insurance systems, but also the state. What are the checks and balances with your organization when somebody does this? And it's a lot of people.
So there checks and balances, not necessarily with our organization itself, the Connecticut Naturopathic Physicians Association. That would be the State Board of Naturopathic Examiners, which is our governing medical board that governs us, which is made up with 2 naturopathic physicians and a lay person who's an attorney.
All right. And so they've not been able to address this yet because those websites are up and running and flourishing with people hoping to get cures for everything that is incurable. So perhaps that could be something on the agenda to look at. It just takes away your credibility as an organization. It takes away, just to our conversation before, when people stand up and say, we believe that we should not believe in scientific information, that reflects on everybody who does in the organization, just like the example that we just saw. So we would love to work with you all as another group as well. And I have been available for that conversation in the past as well, because you've been trained, you do good work. There's a lot of people who have a lot of love and respect, and myself included. And I do feel people should stay in their lanes, but as soon as we change the lanes, that's when things start to get confusing. And I know different parts of the country do it differently, and that's where it gets a little challenging for all of us. But I just had to go through all of my list of things. Can you, in your simple words, tell us the difference between a naturopath and a naturopathic physician?
So in the state of Connecticut, naturopath and naturopathic physician means the same thing in this state. In states that are not Connecticut, it does mean something completely different. My father is a lay naturopath, no training whatsoever in medicine whatsoever. In Connecticut, naturopathic physician, naturopathic doctor, naturopath means the same thing. It means that we hold a degree that's approved from departments or organizations approved by the Department of Education at the federal level, granting us the degree of naturopathic doctor.
Okay, that's helpful, because I know Senator Austin, when she was speaking, she was looking at it a little differently. And then somebody else, one of the other naturopathic physicians, spoke, and they looked at it a little differently. And so I think of all the people with credibility from the organizational perspective, we should hear you out above others at this point.
And I wouldn't say the one naturopathic doctor that was speaking, she works in 2 states. So she works in Connecticut and another state where the terminology is different. So that can be sometimes confusing. And I try to make it very, very clear. The same way when I say a homeopath, if I say homeopath, that means a homeopathic medical doctor, which is a licensed physician or osteopath in the state that went further training with homeopathy.
Okay, good. Okay. I think this clarifies a number of different thoughts that have been here for us. I appreciate you coming, and I truly appreciate you waiting over here and listening to all of the conversation about this. Thank you, Madam Co-Chair.
Thank you, Senator Anwar. I would echo the appreciation, and I think it's actually helpful for us to be able to talk to you at this point. As we discussed earlier, there was a school here in Connecticut that is no longer in existence, and there are, I believe, 8 places around the country. Is that correct?
I don't know the exact number, excuse me, but there are a number of schools on the West Coast, a couple in Canada, Puerto Rico, Arizona, to kind of name Illinois, to name a few.
Okay, and you answered my other question. I was going to ask you, I believe in the Northwest, and having been there, I think there's a little difference, as Senator Anwar referenced, different ways of doing things in different places. And that is helpful to have some context and understanding about where those schools are located. Thank you, Representative D'Amico.
Thank you, Madam Chair. So perhaps you answered this already, and I missed it, Doctor. So I'm looking at the bill that's in front of us, and it looks to me like the only ask is to be able to prescribe and administer vitamin B12, right? That's it. That's the only change that I see from current language, or did I misinterpret something?
And I believe that was a placeholder for us coming up here. We went through the Department of Public Health scope review process. And we were here last year, and that was the bill that was submitted, I think, last year that brought everything up. So we were asking for more things like probiotics, which are natural substances that we can use to diagnose conditions that I cannot prescribe because I don't have a prescription pad, so I can't prescribe that for someone with ulcerative colitis.
So you anticipated my next question. So you do have you would like this to go further than just being able to prescribe and administer vitamin B12.
With the statement that I made earlier, yes, we are looking for all natural substances in our formulary, excluding IV, all routes of administration, excluding IV.
Okay. And the only other question, Madam Chair, is, and this will probably be a softball question for you, Doctor. I'm looking at the testimony from the Connecticut State Medical Society, and they of course you won't be surprised, and maybe we talked about this already. They say naturopathic training does not provide the depth or breadth of pharmacologic education required to prescribe medications safely. Are they wrong?
They are. That is from a orthodox medical perspective, not from an osteopathic medical perspective or a naturopathic perspective. Didactic hours in the classroom. So when I was in medical school, didactic hours of solely pharmacology classes, so just pharmacology classes, was about 200 hours. Then we have our clinical experience, and we have our other classes that include pharmacology as well. All those classes, gastroenterology, neurology, all the ologies that you can think of that you've heard of before. That comes out to about 4,100 hours on average. There are comparisons as well that I can give that are also in the report from the Department of Public Health. I'm just pulling up that right now just so I can give you the exact numbers of comparing our training to nurse practitioners and other providers out there for pharmacology. So minimum hours for NDs is about 200. And then we have clinical hours, including clerkships, 1,200. For MDs and DOs, it's 91 hours of pharmacology classes within the first 2 years. And they have 1,760 hours on average during their clerkships before residency. And NPs have 136 hours didactic training. And they have 1,000 to 1,300 before they go into taking care.
So the testimony that I'm looking at is not including many things that should be included. Is that fair to say?
I would agree. They didn't include the rotations that we have with our patients. We have hands-on experience with this. Other schools that have different scopes of practice as well in those states, they're able to prescribe and do a lot more. And that is from day one, doing IM injections, doing B12, et cetera.
Okay, thank you.
Thank you.
Thank you, Madam Chair.
Thank you very much, Representative D'Amico, and Dr. Brody. Thank you so much for being here with us today. We appreciate you. Next, we have Dr. John Guzzi, who's with us online. Welcome.
Thank you. Co-chairs Saud Anwar, Kristen McCarthy-Vahey, Vice Chairs Kai Belton, Martha Marks, and Douglas McCrory, ranking members Heather Summers, Nicole Colares-Ditria, and distinguished members of the Public Health Committee. On behalf of the physicians and physicians in training of the Connecticut State Society of Anesthesiologists, thank you for the opportunity to submit testimony regarding Senate Bill 1325 and not permitting naturopathic physicians to prescribe and administer vitamin B12. I'm offering these comments in my capacity as an anesthesiologist, an intensivist, a participant in the Department of Public Health's Scope of Practice Review Committee for Naturopathic Practice, and the Secretary of the Connecticut State Society of Anesthesiologists. I'm here to support my physician colleagues in expressing significant concerns about the expansion of prescriptive authority for naturopathic practitioners. In particular, I have concerns regarding the education and practice patterns of naturopaths in the state of Connecticut. Granting naturopaths the ability to prescribe medications, to me, is a patient safety issue. This year's Scope of Practice Committee to examine the naturopathic privileges in the state of Connecticut is the third time that this committee was assembled since 2013. Each previous committee assembled to address this issue has pointed to concerns regarding education, clinical experience and exposure, and adherence to best practice patterns. There has been no substantive change to any of these concerns in the last 12 years, and as such, there is no basis for expanding naturopathic scope of practice at this time. I'm also troubled by the idea that any medication is being treated as a safe first step in prescribing authority. There is not a medication that is risk-free, and proper prescribing requires a nuanced understanding of pharmacology and patient care that can only be gained through rigorous clinical training. The idea that certain medications are safe is naive. And I'm a little bit disturbed by the description I just heard of prescription as a right. Prescribing medications is not a right of any practitioner from any training background. It is a privilege that is granted with great trust and responsibility. For these reasons, I urge strong consideration of the concerns raised by myself and my physician colleagues. Granting naturopathic physicians prescriptive authority for vitamin B12 may seem narrow in scope, but as we've heard, this is a step towards normalizing a pathway that bypasses the comprehensive training and supervision required to prescribe safely. Therefore, I respectfully oppose this legislation. Thank you.
Dr. Guzzi, thank you for being with us today and for your service on the Scope Committee.
Thank you.
Hearing no questions, we will go on to Dr. Anthony Yoder. Welcome.
Thank you. Good evening, Senator Anwar, Representative McCarthy Vahey, distinguished members of the Public Health Committee. My name is Anthony Yoder. I'm a board certified internal medicine specialist practicing in Hartford, and I also served on the most recent naturopathic scope of practice committee. I submitted written testimony supporting Senate Bill 1331 regarding the health information exchange. I'm going to focus my comments this evening summarizing my written testimony in opposition to Senate Bill 1325 regarding naturopathic B12 administration. I'm doing this on behalf of the Connecticut chapter of the American College of Physicians. For background, internists are specialists who apply evidence-based current scientific knowledge from health to complex disease. There is no realistic comparison between the thousands of hours of rigorous, mentored, standardized didactic and clinical training that allopathic and osteopathic physicians receive and naturopathic education. Any consideration of the proposed prescriptive authority poses substantial safety and public health concerns. Despite claims to the contrary, naturopathic physicians undergo training which inherently does not provide the comprehensive, accredited medical education necessary to assess, diagnose, and treat many conditions, which often manifest as a deficiency, but any of which require thorough evaluation and carefully monitored individual treatment plans. Prescriptive authority is a significant responsibility. Every medication has a risk. It is crucial to consider the implications of this in allowing individuals without necessary qualifications to administer or prescribe anything, even something seemingly as innocuous as vitamins. In addition to use of B12 for known and accepted conditions, a brief web search shows statements by naturopathic physicians advocating its use for depression, obesity, weight gain, fatigue, fibromyalgia, autoimmune disease, and multiple sclerosis, for which I can find no published data. It is also important to recognize that many forms of supplementation can have interactions, including with chemotherapy and other common treatments, leading to drug levels which are either too low to work or high enough to be toxic. There are no published guidelines or standards of care to which largely self-regulated naturopathic physicians are held responsible. While some patients report that B12 supplementation improves their well-being and thus request it, it's irresponsible to prescribe anything without defining its indication and understanding the underlying causes and potentially life-threatening conditions. Absent some standard, sale of vitamin injections which are not emergent and are generally available has historically been ethically suspect for financial gain and prone to misuse. Beyond these ethical concerns, allowing naturopathic physicians to prescribe B12 raises critical issues surrounding scope of practice, both present and future. Given all of this and the potential for misdiagnosis, medication interactions, inappropriate supplementation, avoidable adverse effects, and scope of practice issues, we oppose naturopathic prescriptive authority in any form. I urge that any treatments requiring this be left to licensed healthcare professionals with the appropriate training and expertise. Thank you very much for your consideration.
Thank you, Doctor, for being with us today and for serving on the scope committee. Senator Anwar.
Thank you so much, Madam Co-Chair. Dr. Yoder, good to see you. Thank you for your
Always.
testimony. Dr. Yoder, you just had the opportunity probably to listen to Dr. Robert Brody, who's the president of the Connecticut Association of Naturopathic Physicians, I believe.
Yes, I did.
How would you reflect to some of the questions that we had raised, and he has responded to those?
I respectfully disagree to some of the responses. I think that there are substantial differences in the way I was trained and then the way a naturopathic physician was trained, largely with respect to the clinical hours and the application of knowledge. While the didactics may be the same, the years of training, which is very standardized in allopathic or osteopathic education, is very different from what I understand a naturopathic education to be, which is not standardized and doesn't necessarily have hands-on training.
And we had this conversation on some of the individuals making statements about them being able to cure or address many diseases that unfortunately there's no treatment for, but it's trying to get a market share and then trying to use some treatments without proof of benefit, and that's happening left and right in the community. if there was an opportunity to give the prescriptive rights, does that scare you about the possibility with the people who have not necessarily been self-governing their aspect to have that privilege?
It does give me pause for a profession that's largely self-regulated. And without the appropriate training, it also concerns me that even as Dr. Brody mentioned, the B12 is just a placeholder, and our hope is to add even more.
And I asked this question earlier of Dr. Leslie Miller from Fairfield County, and I said that, and then this is a question for internists more so as well, where vitamin B12 deficiency is not a disease, it's a symptom of something else going on. Can you expand on this a little bit and then perhaps also help us understand that just giving an injection for vitamin B12 may not necessarily solve the problem. It's going to increase that number in the blood test, but it's not going to solve the problem unless you do the full diagnostic test with the understanding and training and experience.
Right, absolutely. And I think it's a very valid question. I think anybody would be remiss just to say I have a B12 level of, say, 150. Let's just get more. I can get the level up to 1,000 or more with an IM injection, but that doesn't answer the question of how did we get there in the first place. As was mentioned earlier, is it a malabsorptive syndrome? Is it a hematologic issue? Like, what is going on to do this? So you can put a Band-Aid on the problem, but you do that without really stopping the bleeding and understanding what is that underlying issue. And I think that's where the breadth and depth of my training sets my profession apart in being able to understand that difference. And as Senator Gordon mentioned earlier, much earlier in the day, like they're supplementing a level of 250, say, it's dubious without understanding the complete picture.
Well, thank you for your testimony. Thank you for staying with us throughout the day. Thank you, Madam Cookie.
Sure thing.
Thank you very much for being here today. Next, we are going to Thomas Barger.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and all the distinguished members of the Public Health Committee. My name is Tom Barger. I'm the Manager of Water Quality and Cross-Connection Control at the Regional Water Authority in New Haven. And I'm with you this afternoon representing the Connecticut section of the American Waterworks Association to comment in support of language providing the Department of Public Health with the ability to address issues relating to cross-connection control, incorporation into the appropriate House Bill 6977 or 6978. The Cross-Connection Control Committee of the Connecticut section of the American Waterworks Association has worked with the Department of Public Health's drinking water section for many years to ensure that the state's cross-connection control manual and corresponding regulations facilitate compliance, to identify and take corrective actions against premise plumbing configurations that may contaminate drinking water. Recently, the Drinking Water Section and the Cross Connections Committee has been actively discussing various compliance issues that may benefit from a change to regulation and a corresponding manual. These changes are intended to better promote regular updates, to recognize new development and equipment, technologies, and to ensure the continuity of appropriate protective efforts by water systems and the best guidance and oversight possible by the Drinking Water Section. Protecting the water distribution systems of both public water systems and those of the individual premise from cross-connection related contamination requires regular surveillance by water system inspectors to identify and eliminate all cross-connection issues. Details have changed to ensure this protection would be addressed via the existing policies and procedures of existing regulations in a collaborative manner involving the public water system, the department's drinking water section, and other interested parties such as the State Fire Marshal's office or the Office of the State Building Inspector. Connecticut section of AWWA respectfully request the inclusion of language in the appropriate House Bill 6977 or 6978 to permit the Department of Public Health to proceed with the implementation of policy and procedure necessary to administer provisions related to the use, installation, and inspection of cross-connection protections between a public water supply and any other water system, while in the process of adopting such policies and procedures as regulation. This will expedite efforts to address various issues and facilitate compliance to safeguard the integrity of drinking water systems and the public health of our citizens. I appreciate your work and thank you for the opportunity to provide testimony this afternoon.
Thank you, Mr. Berger. I don't know if you were on earlier when Ms. Guerra testified.
I was.
And you probably heard me say that it's likely that language that you all are looking for will be included in another bill other than this one. So, but we are hearing you clearly and understanding the need and importance for this for the quality and safety of our water.
We appreciate that very much. Thank you again.
Thank you. Thank you very much. Next, we have Amanda Gunthel.
Hi.
Welcome.
Hi. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Amanda Gunthel, and I am the president of the Connecticut Association of Ambulatory Surgery Centers. I also serve as president of our ASC Patient Safety Organization, and I have been a part of our ASC community since 2005. I am here to testify on SB 1331 regarding the opt-out process for the Connecticut Health Information Exchange. The bill before you today is meant to address an existing issue with the statewide health information exchange known as CONI. Currently, healthcare facilities are expected to participate in CONI and share all patient information. Due to expressed concerns over liability, protected health information, policies and procedures, contracts, and costs, this committee created a working group to discuss and recommend changes. I served on this working group, and I can confidently say that the organizations I represent and many others in the state greatly appreciated this opportunity. I have included with my testimony specific recommendations that I, along with Mag Morelli of Leading Age Connecticut and Dr. Anthony Yoder, submitted to the working group. 23 Connecticut organizations signed on in support of our recommendations. These recommendations were not included in the body of the working group's report, but can be found in brief in Appendix A. We are requesting that SB 1331 be modified to include specific recommendations that will address our concerns, including the risk of a potential data breach from the time that an individual opts out until a data sweep occurs. As Senator Anwar mentioned while speaking with Dr. Marcy Russo earlier, my current understanding is that this time period is 5 days. A HIPAA-compliant participation agreement, waivers for commingled records and sensitive information, provider protection from the burden of CONI's operating and administrative costs, protection of records related to gender-affirming care, and finally, provider involvement in policy review and development. I'd like to note that provider involvement is imperative if we are to successfully operationalize this program. The letter submitted with my testimony includes an executive summary of our recommendations and additional detail for each. While we understand the potential benefits of easy access to shared medical information, many issues remain with the development of the exchange. CONI was created several years ago with limited provider input, and the issues we've identified must be addressed for the program to succeed. I am hopeful and remain optimistic that we can move forward with an inclusive and transparent process that affords both providers and patients with an appropriate level of security and understanding about how this information is accessed and shared. Our organizations and many others in the state are happy to assist in this process. Thank you for your time today. I'm happy to answer any questions.
Thank you so much. Thank you for the work that you put in serving on the committee last year and for your additional recommendations. As you probably heard me say earlier today, this is definitely an area that we will need to be in continued conversation about, both for the reasons that you all have put forward, but also just in terms of the context at not just the state, but also the federal level. And they're certainly very sensitive topics, important to the care that we're providing to patients, important for our providers, but it's very, very complex. Senator Anwar.
Thank you so much. Thank you, Ms. Gontal, for your work and the work that you've been doing. I wanted to explore this a little bit. So the bottom line is that everybody is interested to make sure that there's enough data so we can provide better care and have a better plan. Is that a fair statement to begin with?
Yes.
And so with that background, we also want to make sure that our patients' information, especially sensitive information, is protected.
Yes.
And so with that in mind, and then knowing the vulnerabilities at various levels, and also patients at times not having clear choice in the matter, how walk me through how the program should function so that we can achieve what we want to while giving the patients the choice and the various parts of their healthcare that they want protected to remain protected and minimize or close to eliminate the risk of breach.
I don't know if I have the exact answer to that. I think the answer to your question is going to rely on the input of a lot of people and a lot of providers, really kind of digging through the details of, like I said earlier, operationalizing that process. And I think an important component of that is education for the patients so that they really understand the options, the program, how it works, the purpose of it, and that's going to be a significant effort.
Thank you for that. But you have also identified that the 5 days that the data that is even opted out is not separated out for 5 days or so.
That's right. We need, I think proper disclosure and transparency, the development of policies and procedures, and addressing all of those concerns, and minimizing risks where a data breach is there's a potential for a data breach. I mean, I know that we were all very closely acquainted with what went on in with the Change Healthcare breach. So last thing we want to do is see something like that.
Okay. So thank you so much for your testimony. And I'd heard the 5-day term, and I'm glad somebody else did too. So
Yeah.
Second, in the previous conversation, I thought I was hearing things, but
no. And I think
true.
the issue is partly Senator Hanwar, because even though there's an opt out, like the data still goes.
Yeah, and so this may be a reason to have another conversation with Office of Health Strategies, because when they were testifying, they did not feel that was accurate, but I had heard something like this, so that's why I wanted to clarify. And I think there are more than 1 or 2 people who believe that the data is not fully opted out for at least for a certain time.
Yeah.
And perhaps we need clarification, because that would not be a safe thing.
Agree.
Thank you so much. Thank you, Madam Chair.
Thank you, Senator Anwar. So as we often say here, to be continued. Thank you for being here with us today.
Thank you.
Next, we have Jennifer Searles. Is she here in person? No. Okay. If not, then I believe it's Steve Thornquist, if I'm not mistaken. Welcome.
Thank you. Hi, I'm Steve Thornquist, and I am a pediatric ophthalmologist. Good afternoon. Actually, let me start with that. Be more collegial here. Good afternoon, Senator Anwar and Representative McCarthy-Vahey and the other distinguished members of the committee. I'm Stephen Thornquist. I'm a board-certified pediatric ophthalmologist, recently retired, but still involved, and a past president of the Connecticut Society of Eye Physicians. I'm here representing over 800 physicians in the medical specialties of ophthalmology, otolaryngology, dermatology, and urology in a combined opposition to the raised Bill 1325 and in support of raised Bill 6979, which my colleagues from the Connecticut State Medical Society have adequately addressed already. Many of those who choose to go to a naturopath do so for alternative health treatments and not for the prescription of traditional pharmaceuticals, as we've heard already from several people. Naturopathic training has been proudly focused on non-pharmaceutical treatment, and yet the naturopaths have asked for prescriptive privileges 8 times since 2010. Each time, careful review by this body and by scope of practice committees have found that the request is not supported by the training and their scope of practice. As recently as 2018, the legislature mandated that such requests be going through a scope of practice review, which they have since gone through 3 times. Most recently, in this past fall, there was another scope of review committee, and I asked them directly what had changed since their previous ask in 2019 to make it now acceptable to give them prescriptive authority. And they couldn't answer that. There hasn't really been any substantive change in their training since the last time this was examined by the legislature and turned down. Yes, you can get some credit for persistence, but this is a privilege that, as my colleagues have described already, really you need to demonstrate skill and capability and education before you're granted the privilege, not after by not managing to create problems. This bill specifically asks for the ability to administer vitamin B12, that we've already heard that they want this to be more than that, and that they don't want to do it this go around by intravenous infusion, but that's on the table as well. You've heard from my colleagues about why this is dangerous. I will point out that even in intramuscular and subcutaneous injection does require a really good anatomy, a knowledge of the anatomy, and also a knowledge of where the tip of that needle is. And it is not currently within the purview of naturopathy practice in Connecticut. And in fact, one of their providers even said she hasn't done any injections since she's been in practice. And this bill that they're asking now for the ability to do that tomorrow. And I think that's a serious issue. Additionally, if new privileges are to be granted, the inadequacy of their overseeing board needs to be addressed. And I'm glad to see that my naturopathic colleagues have finally come around to recognizing that and are asking for an expansion of their board. I would agree with them that it should be expanded and probably to 5 members, but I disagree with the composition that they're suggesting. As they state, it's currently 2 naturopaths and 1 public member. By definition, since they are legally practicing in the state of Connecticut, neither ND on the board has experience with prescription medications or with non-oral B12 administration, and yet they would be overseeing it if this bill were to pass. This group is simply too small, too inexperienced in prescription and injection, and too narrowly focused to determine the scope of prescriptive authority injection skills that will affect the care of potentially every patient in the state of Connecticut. If this privilege is granted, we suggest the board be expanded, as they have suggested, and include a provider skilled in the newer privileges, which we suggest should be at least 1 MD or DO. I agree with the pharmaceutical expert being on board. I would suggest a pharmacologist rather than a pharmacist. But I would suggest go to 2 naturopaths, the current public member, an MD, and a pharmacologist. And I would take a little time. I looked up the Pediatric Association of Naturopathic Physicians. It's based in Juneau, Alaska.
Excuse me, Dr. Thornquist, but you've reached your 3 minutes.
All right, then I would just urge you to exercise the wisdom of every other of the 10 times that this has come before the legislature and decline this request as well.
Thank you, Dr. Thornquist. Dr. Thornquist, can you remind me, have you already submitted written testimony?
Yes, I have on both bills.
Wonderful. Thank you very much. You got a lot in there, and I want to make sure people have the opportunity to see it. So thank you so much for being here with us today. Okay. Next, we are actually going to go back to number 51, Dr. Carbonari.
Yes, hello.
Welcome.
Good afternoon or evening. My name is Sandy Carbonari. I'm a member of the executive board of the Connecticut chapter of the American Academy of Pediatrics, and I'm writing on behalf of our over 600 pediatrician members in opposition to SB 1325. I don't think I have to name it. I think you've been hearing lots about it. But it is permitting naturopathic physicians to prescribe and administer vitamin B12. The American Academy of Pediatrics advocates that every child receive high-quality care in a medical home. And to this end, optimal pediatric care is best delivered in a team-based approach that's led by a primary physician who assumes responsibility for managing the infant, child's, or adolescent's care. And all professionals who provide pediatric care must hold to the highest standards of education, and training and continually demonstrate their skills and their competencies. Naturopathy is guided by a philosophy that emphasizes the healing power of nature and combines many methodologies along with sensible concepts such as good nutrition. However, there is currently little evidence on the use of naturopathy in medical conditions in children. Regarding vitamin B12, this drug is readily available in over-the-counter oral preparations. Therefore, presumably, this bill is requesting the ability to prescribe and administer it either intramuscularly or intravenously. This request is problematic in several ways. There's no reference to the age of the individual who would be treated by a naturopath with vitamin B12. Children who truly have vitamin B12 deficiency often have multiple medical issues related to the gastrointestinal tract or an inadequate diet. And these are medical problems that need to be treated in a pediatric medical home. IV and intramuscular dosing is not well established in pediatric patients. All aspects of a child's medical conditions must be considered when determining the correct dose for an individual child, and this requires pediatric training. Administering intravenous medications to a child is a skill that is developed during the years of pediatric training, and as you would probably guess, it's neither simple nor easily mastered without a good deal of practice. The American Naturopathic Medicine Association states that naturopathy or naturopathic medicine never includes minor surgery or prescription drugs. Instead, clients are advised to seek out properly trained professionals that provide such services. Naturopathy does not cure disease. We as pediatricians believe that there is value in non-traditional therapies and certainly share with naturopaths the belief and the philosophy of the importance of prevention as well as good nutrition. However, practitioners of naturopathy are not adequately trained to prescribe or administer medications, especially to children. And thank you, and I'm happy to take any questions. Oh,
Dr.
and
Carbonari.
I was also on that scope of practice committee in the Department of Public Health.
Thank you for adding that. Thank you for your service, both as a pediatrician on the scope review panel. And thank you for staying with us here today and being here. Seeing and hearing no questions, we will go on to Kristen Pendergrass. Welcome.
Thank you, Madam Chair and members of the Public Health Committee. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof, which is a national nonprofit dedicated to ending the addiction crisis. I appreciate the opportunity to testify in support of House Bill 6975, requiring a biennial study of payment parity. And I've also submitted written testimony. Given the late hour, I will be brief. As I mentioned, we are a national nonprofit, but we are based in Connecticut, where our founder, Gary Mendel, lives with his family. Gary started Shatterproof more than 10 years ago after he lost his son, Brian, to a substance use disorder. One of the main pillars of our work is to ensure access to quality substance use disorder treatment for individuals in Connecticut and throughout the country. We have a quality treatment locator called treatmentatlas.org, which helps individuals and families identify treatment facilities that meet their needs, and it includes all Connecticut treatment facilities as of October 2023. But we know that accessing quality treatment means more than identifying the right facility. You also have to be able to afford that care, which is why we also advocate for behavioral health parity at the state and federal level. When it comes to substance use disorder treatment, insurance coverage can truly mean the difference between life and death. An individual who is ready to seek treatment for a substance use disorder is likely in a fragile position, as are the people who love them. And having to fight for insurance coverage of life-saving substance use disorder treatment can mean the window of opportunity to get care closes, or that a person cannot access the right care for them, or that their family has to make a dire financial decision. Shatterproof represents thousands of people in Connecticut and around the country who have been impacted by substance use disorder, and we support House Bill 6975 to ensure that behavioral health parity is monitored and enforced in Connecticut. Thank you for the opportunity to testify on this important issue.
Kristen, Ms. Pendergrass, thank you so much for hanging in here today, for your testimony on the bill, and also for the life-saving work that you do with Shatterproof. We're really glad to have you here and grateful for all that. So thank you. We are going to go actually to number 17, Diane Lauricella. Welcome.
Good evening. Good evening, Senator Anwar, Representative McCarthy Vahey, Vice Chairs and Ranking Members and esteemed members of the Public Health Committee. I want to thank you for the opportunity to comment on House Bill 6978 concerning recommendations regarding various revisions to the public health statutes. I'm going to focus my comments on beginning Section 6, especially lines 161 through 208. I very much am in favor of any chance to tighten up and, of course, allow for better communications and support for our local and district-wide health directors. However, what I believe is missing in lines 161 through 208, and I wanted your advice on how I could lift up this issue. I'm a former hazardous waste senior investigator with the DEP back when there was only one E in the acronym. Since then, I've become a professional environmental waste management consultant and often offer ideas and help health directors as well as neighborhoods in how to avoid the dire effects of contaminants, both air, water, and historic waste pollution. I believe that what is needed now is to embody a special working group or task force to take a look and study, and it would just be something for the fall, for a couple of months, to take a look and see what kind of support we can have in our state so that we have our local and district health directors embrace a more proactive role when it comes to pollution sources, especially with our historic contaminated properties. Right now, the way the law reads is that it is implied, and of course, our health director and our commissioner of health have immense powers that they, of course, want to apply wisely. The problem is that we do have ticking time bombs. I live in the coastal part of Connecticut, and there have been sites that have fallen through the cracks. I have been told by health directors and health sanitarians that they await the state health DEEP to tell them that there is a problem, or that possibly, I don't even know if the toxic section of the Department of Public Health is still active. I used to regularly work with them and collaborate with them on sites that we discovered in the 80s, many of which have been cleaned up, but there still are many that are in need of assessment and review and prioritization. We know a lot more about the health effects of contaminants now than when the health director statute was originally written. So we need to update their role and give them the support they need to perform. And it just isn't the case. So I felt a study committee or a task force would be a way to help have people come together. And this task force could include environmental groups, environmental justice groups, Department of Public Health, DEEP, any of the Children's Committee, medical associations, of course, any of the health director associations. I believe there's a sanitarian or public health professional associations. I think this is a kind of a sleeper issue, because if you were to ask even—
Excuse me, Ms. Lorcella, but you've reached your 3 minutes. Thank you.
Okay, may I just finish my sentence?
Thank you. Yes, if you could just summarize, please.
I will. Many towns have historically contaminated properties that are ticking time bombs for contaminant releases. And because the health directors are awaiting a poorly staffed or understaffed DEEP to tell them there's a problem, I feel we need to address a more robust and proactive way to get a handle on imminent environmental health threats locally. We're falling short of this in many of our district and local health departments. Thank you for letting me speak.
Thank you so much. And you raise a very important issue. We've had a few conversations here today, and we've had others offline related to the crossover between DEEP and the Department of Public Health. And certainly there is a lot of connection, and it's an interesting issue that you bring up. In terms of getting our advice, I believe Mary Hogue has already connected, the two of us or Will, I'm certainly happy to talk with you more offline further about your ideas. Seeing and hearing no other questions, thank you for being here with us today. We appreciate it.
Thank you for all you do. Thank you.
Thank you. I believe we have one more person here in the room with us today who would like to testify. Am I correct? Yes, please come forward and share your name with all of us. If you could press the button right in front of you so we can all hear you. Welcome.
My name is Carmen Worcester, and I have gratitude for your patience and for your work with this issue in support of House Bill 6920. I'm a mother of a 45-year-old daughter who has a rare disease, and that rare disease is called stiff person syndrome. It is the same disease that Celine Dion has and has given a face to for others that have the condition, which is a rare, progressive, and complex neurological disorder. Just think of how rare it is. It's like 1 in a million get it. So when it comes to a flare that a person has with this condition, going to the emergency room has become worse than a nightmare because there is no level of care provided to a person with a rare disease at most of the emergency rooms I've been to with my daughter through the state. Matter of fact, going to the emergency room almost creates another level of flare that continues just from going there and the conditions within the emergency room. There's resistance from the physicians to acknowledge rare diseases, first of all. They almost become combative verbally that it exists. Even when you bring the paperwork and protocols from the neurologist who has made the decision based on specific testing, the emergency room doctors, and this is across the board, I've been almost to all of them here in the state, refuse to look at it, refuse to even call the neurologist to confer. And they will tell you basically that they're there for broken bones and bullet wounds, and that this is not the place. So if this is not the place, where does a person with a rare disease go? There are protocols that a person with a rare disease, such as my daughter has, that are not paid attention to at all. First of all, she has tremors, which is part of the condition. So she needs a place where there's not bright lights. That should be in the protocol, that it should be a darkened room. It should be a room and not in the hallway where there's a lot of noise that would set off a tremor, which would set off a possibility of a fall. There should be a fall risk identified as a protocol for people with rare diseases. And they should understand that the person is coming in because of excessive pain, otherwise they would not be coming. But instead, what they're met with is suspicion of being a drug user or being mentally ill. So you're there from, okay, our average time would be from like 10 in the morning, and then we be leaving at 1 o'clock with nothing done, not even an infusion of liquids that would help with the muscle spasms, much less a pain medication that was recommended by the neurologist.
Excuse me, Ms. Worcester, but you've reached your 3 minutes. Thank you.
The point is that people with rare diseases need a special protocol, and that protocol should be inserted into the protocols for emergency rooms
Thank you.
across the state.
I want to thank you so much. I met you this morning we didn't actually get to introduce
Yeah.
ourselves, but as we were walking in, you've been here all day
Yeah.
and you've waited for the chance to testify. And I have to say thank you because I think your testimony was very helpful and very powerful to us. So, and I'm sorry that this is the experience that you've had, and we're interested in continuing the conversation to see what we can do to improve things for you and your daughter and all other rare disease families in Connecticut.
It's encouraging that 6920 is being considered.
Well, don't go because I believe we've got one other question or comment, Senator Anwar.
Thank you, Ms. Wooster. Thank you so much for staying with us the entire day. And I know you were not able to sign up and you're having difficulties, and you said you'll wait all day for being able to speak about your experience. And I don't know, mothers are special. They can stay all day just to be able to say that the system is failing my child, and the system is failing your child, and we hear you. And I think that's why one of the conversations we'll have to have, we have legislative power. Sometimes we have a convening power, and both Representative Kristen McCarthy and I were just talking that we do have conversation with the emergency doctors organization at the state. Perhaps there's going to be an opportunity, whether the bill passes or not, which we are very hopeful it will, but we need to have a conversation with the RDEC and the ED doctors to try and hear this out, the stories, and see how we can be better. There's a legislative process, but there's also a process of better communication with each other and trying to change the minds of existing systems' weaknesses. I can tell you for me, and it's probably fair to say that for all of the people who are listening right now, your waiting for the entire day was worth it. Thank you.
Amen. I would like to say thank you to every person who testified today, everyone who joined us, our incredible team behind the scenes, and to all the members of the committee who are here and online who've listened in. We appreciate you, and we will see you. When will we see you? On Monday. That's right. Thank you. Monday, we'll be back here for another hearing. Have a great rest of the week, everyone.